Jember, Lawang, Blitar, Kediri, Trenggalek, Ponorogo. At present, Polkesma offers study program, Diploma Program of Nutrition Study, Diploma Program of Nursing, Diploma Program of Midwifery, Diploma Program of Pharmaceutical and Food Analysis, Diploma Program of Medical Records and Health Information, Diploma Program of Health Insurance, Diploma Program of Blood Bank Technology, Undergraduate Program of Applied Nutrition and Dietetics, Undergraduate Program of Applied Nursing, Undergraduate Program of Applied Midwifery, Undergraduate Program of Health Promotion, Undergraduate Program of Applied Safety and Health, Undergraduate Program of Professional Education, Dietitian, Nursing, and Midwife. To support lectures, Polkesma provides educative facilities, starting with lecture rooms with modern learning media. Integrated functional laboratories supported by advanced technology. Digital-based integrated library or library, counseling unit, dormitory, mosque, gazebo, canteen, sport facilities, hotspot area, computer room, language laboratory, nursing laboratory, nutrition laboratory, midwifery laboratory, blood bank technology, medical record, and a secure parking. Supported by the implementation of a top vocational education with 60% of practicum activities and 40% of theory study, which will improve the student skill with practice in laboratories and other practical media. Polkesma continue to implement innovative, fun teaching methods with the concept of enjoying learning. On top of that, Polkesma implements an internet-based test for examination and e-learning and blended learning, which is applying classroom learning methods and utilizing e-learning. A qualified education is formed by instilling values that are presented through 220 teaching staff, qualified master and doctorals who have been certified with various disciplines and examples in daily life. Polkesma also instills national character and ethics and excels in professionalism to withstand the global challenges. Besides academics, Polkesma also prepares students who are confident in their abilities by providing student activity units, developing students' interests and talents ranging from arts, sports, science, Red Cross, Scout, language, and spirituality. This is where the step of realizing the ideal begins, by channeling freedom of expression. Polkesma educates students to be loyal to the country and have a mental attitude of character by providing an education of national defense. Polkesma shows success in producing superior individuals with both national and international achievements. National and international cooperation with the health education institution as well as the health service institutions. This success can also be seen from the distribution and role of Polkesma alumni in international health agencies, spread across Asia, Australia, Europe, and even America. Welcome to Malang State Polytechnic of Health, Polkesma. Polkesma is under the Ministry of Health of Indonesia. The main campus is located on Besar Ijan Street 77C, Malang. The campus, which was established in 2001, is one of the 38 health institutions owned by the Ministry of Health of Indonesia. Polkesma has a vision to become a civilized and globally competitive polytechnic of health. Polkesma has a number of missions carried out, including organizing a qualified education and learning to develop the potential and the personality of civilized and globally competitive students. Polkesma also working on developing the productivity of applied research and service for qualified and innovative communities. Besides that, developing good organizational governance based on information technology. And finally, Polkesma is developing cooperation and productivity both of domestic and international partnerships. Polkesma has 5,000 students that is divided into 4 majors and 20 programs study. The campus is a benchmark of health education in Indonesia, which leads of 7 campuses, which located in Malang, Jember, Lawang, Blitar, Kediri, Trenggalek, Ponorogo. At present, Polkesma offers study program, Diploma Program of Nutrition Study, Diploma Program of Nursing, Diploma Program of Midwifery, Diploma Program of Pharmaceutical and Food Analysis, Diploma Program of Medical Records and Health Information, Diploma Program of Health Insurance, Diploma Program of Blood Bank Technology, Undergraduate Program of Applied Nutrition and Dietetics, Undergraduate Program of Applied Nursing, Undergraduate Program of Applied Midwifery, Undergraduate Program of Health Promotion, Undergraduate Program of Applied Safety and Health, Undergraduate Program of Professional Education, Dietitian, Nursing, and Midwife. To support lectures, Polkesma provides adequate facilities, starting with lecture rooms with modern learning media. Integrated functional laboratories supported by advanced technology. Digital-based integrated library or library, counseling unit, dormitory, mosque, gazebo, canteen, sport facilities, hotspot area, computer room, language laboratory, nursing laboratory, nutrition laboratory, midwifery laboratory, blood bank technology, medical record, and a secure parking. Supported by the implementation of a top vocational education with 60% of practicum activities and 40% of theory study, which will improve the student's skill with practice in laboratories and other practical media. Polkesma continue to implement innovative, fun teaching methods with the concept of enjoying learning. On top of that, Polkesma implements an internet-based test for examination and e-learning and blended learning, which is applying classroom learning methods and utilizing e-learning. A qualified education is formed by instilling values that are presented through 220 teaching staff, qualified master and doctorals who have been certified with various disciplines and examples in daily life. Polkesma also instills national character and ethics and excels in professionalism to withstand the global challenges. Besides academics, Polkesma also prepares students who are confident in their abilities by providing student activity units, developing students' interests and talents ranging from arts, sports, science, Red Cross, Scout, language, and spirituality. This is where the step of realizing the ideal begins, by channeling freedom of expression. Polkesma educates students to be loyal to the country and have a mental attitude of character by providing an education of national defense. Polkesma shows success in producing superior individuals with both national and international achievements. National and international cooperation with the health education institution as well as the health service institutions. This success can also be seen from the distribution and role of Polkesma alumni in international health agencies spread across Asia, Australia, Europe, and even America. Welcome to Malang State Polytechnic of Health, Polkesma. Polkesma is under the Ministry of Health of Indonesia. The main campus is located on Besar Ijen Street 77C, Malang. The campus, which was established in 2001, is one of the 38 health institutions owned by the Ministry of Health of Indonesia. Polkesma has a vision to become a civilized and globally competitive polytechnic of health. Polkesma has a number of missions carried out, including organizing a qualified education and learning to develop the potential and the personality of civilized and globally competitive students. Polkesma also working on developing the productivity of applied research and service for qualified and innovative communities. Besides that, developing good organizational governance based on information technology. And finally, Polkesma is developing cooperation and productivity both of domestic and international partnerships. Polkesma has 5,000 students that is divided into 4 majors and 20 programs study. The campus is a benchmark of health education in Indonesia, which leads of 7 campuses, which located in Malang, Jember, Lawang, Blitar, Kediri, Trenggalek, Ponorogo, At present, Polkesma offers study program, Diploma Program of Nutrition Study, Diploma Program of Nursing, Diploma Program of Midwifery, Diploma Program of Pharmaceutical and Food Analysis, Diploma Program of Medical Records and Health Information, Diploma Program of Health Insurance, Diploma Program of Blood Bank Technology, Undergraduate Program of Applied Nutrition and Dietetics, Undergraduate Program of Applied Nursing, Undergraduate Program of Applied Midwifery, Undergraduate Program of Health Promotion, Undergraduate Program of Applied Safety and Health, Undergraduate Program of Professional Education, Dietitian, Nursing, and Midwife. To support lectures, Polkesma provides adequate facilities, starting with lecture rooms with modern learning media, integrated functional laboratories supported by advanced technology, digital-based integrated library or library, counseling unit, dormitory, mosque, gazebo, canteen, sport facilities, hotspot area, computer room, language laboratory, nursing laboratory, nutrition laboratory, midwifery laboratory, blood bank technology, medical record, and a secure parking. Supported by the implementation of a top vocational education with 60% of practicum activities and 40% of theory study, which will improve the student's skill with practice in laboratories and other practical media. Polkesma continue to implement innovative, fun teaching methods with the concept of enjoying learning. On top of that, Polkesma implements an internet-based test for examination and e-learning and blended learning, which is applying classroom learning methods and utilizing e-learning. A qualified education is formed by instilling values that are presented through 220 teaching staff, qualified master and doctorals who have been certified with various disciplines and examples in daily life. Polkesma also instills national character and ethics and excels in professionalism to withstand the global challenges. Besides academics, Polkesma also prepares students who are confident in their abilities by providing student activity units, developing students' interests and talents ranging from arts, sports, science, Red Cross, Scout, language, and spirituality. This is where the step of realizing the ideal begins, by channeling freedom of expression. Polkesma educates students to be loyal to the country and have a mental attitude of character by providing an education of national defense. Polkesma shows success in producing superior individuals with both national and international achievements. National and international cooperation with the health education institution as well as the health service institutions. This success can also be seen from the distribution and role of Polkesma alumni in international health agencies spread across Asia, Australia, Europe, and even America. Welcome to Malang State Polytechnic of Health, Polkesma. Polkesma is under the Ministry of Health of Indonesia. The main campus is located on Besar Ijan Street 77C, Malang. The campus, which was established in 2001, is one of the 38 health institutions owned by the Ministry of Health of Indonesia. Polkesma has a vision to become a civilized and globally competitive polytechnic of health. Polkesma has a number of missions carried out, including organizing a qualified education and learning to develop the potential and the personality of civilized and globally competitive students. Polkesma also working on developing the productivity of applied research and service for qualified and innovative communities. Besides that, developing good organizational governance based on information technology. And finally, Polkesma is developing cooperation and productivity both of domestic and international partnerships.
Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. Welcome in State Health Polytechnic of Malang. We are delighted to welcome you for the 6th International Conference and Workshop of Health under the title Post-Pandemic Challenges, Current Health Science Developments Related to Diabetes Mellitus Management. That will be held today, November 27 till to 28, 2023. First of all, let us introduce ourselves. My name is Andi Hayun Abidin and my partner Ananda Yuvidya Stuti, and we will be hosting you for today's event.
Okay, and before we proceed, I would like to welcome our honorable guest for today. So welcome to our honorable Dr. Kiki Arianti Anaya MKM, the Director General, the General Director of Health Workers of the Republic of Indonesia. And the second one is, please welcome Dr. Eva Susanti, SKPMKes, General Director of Directorate of Non-Communicable Disease Prevention and Control. And the third one is our Director of Health Polytechnic of Malang, Dr. Muhammad Wildan, FFN MPD. And for all of the Vice Directors of Health Polytechnic of Malang,
all of Head of Study Program, Health Polytechnic of Malang, chairs of the committee and team of Installation Center of Excellence Science and Technology for Health Polytechnic of Malang, and also distinguished speaker of the conference, and last but not the least, participant and audience. Ladies and gentlemen, the first agenda for the morning, we will turn our national anthem and the term of Health Polytechnic of Malang. Ladies and gentlemen, please be seated uprightly.
Thank you. And the next session is prayer that will be led by Dr. Nur Rahman. So, Dr. Nur Rahman, please, the time is yours.
Thank you, Miss Handayu. I will read prayer in Indonesia. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Hadirin peserta webinar hari ini, marilah kita tundukkan kepala sejenak, berdoa untuk memohon agar acara webinar pada hari ini diberi kelancaran, kemudahan, dan membawa barokah untuk kita semua. Astaghfirullahaladzim, astaghfirullahaladzim, astaghfirullahaladzim. Bismillahirrahmanirrahim. Alhamdulillahirabbil alamin. Hamdan syakirin, hamdan na'imin, hamdan yuwafi ni'amahu wa yukafi majidah. Ya Rabbana lakal hamdu kama yanbaghi lijali wajhika wa atimi sultanik. Allahumma sholli wa sallim ala sayyidina Muhammad wa ala ali sayyidina Muhammad. Syukur kami ya Allah, Tuhan semesta alam, atas limpahan rahmat, taufik, dan hidayah kepada kami yang hadir dalam acara webinar pada hari ini di Pusat Unggulan IPTEK dengan tema Post Pandemic Challenge Current Health Science Development Related to Diabetes Mellitus Management pada hari ini Senin 27 November tahun 2023. Ya Allah, kami yang berkumpul di ruangan Zoom ini bersyukur atas izin-Mu kami peserta webinar pada pagi hari ini. Terima kasih kami ya Allah kepada seluruh manajemen Politeknik Kesehatan Kemenkes Malang yang telah memberikan fasilitas ini sehingga kami bisa menyelenggarakan kegiatan ini di ruang Zoom ini. Ya Allah, karena Engkau-lah yang maha memudahkan. Segala yang susah adalah mudah bagimu. Dan di kekuatan untuk menjadi tenaga kesehatan yang mempunyai akhlak mulia, yang senantiasa menjunjung tinggi nilai-nilai kebenaran. Ya Allah, kami memohon untuk
Okay, thank you very much to Dr. Nur Rahman for the prayer. We really hope that our conference today and tomorrow will be held successfully and give plentiful insight for all that can be attended today.
Ladies and gentlemen, for the next agenda is report from the chairs of the committee that will be delivered by Ma'am Rizky Mustikariswari, SSTM PH, chairs of the Committee for Health Polytechnic of Malang. Ma'am Rizky Mustikariswari, time is yours.
Thank you very much for time given to me. I hope you can hear my voice clearly. Baik, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. Selamat pagi. Thank you for attend our annual agenda in international conference and workshop in health held by Poltekkes Kemenkes Malang. First for all, I would like to say welcome to the 6th International Conference and Workshop of Health, ICWH, under the title Post-Pandemic Challenge, Children Health Science Developments Related to Diabetes Mellitus Management, that will be held today till tomorrow in 27 till 28 November 2023. We chose this theme with consideration that Center of Excellence of Polkesma is diabetes mellitus, and we want to do more to support our how to manage diabetes mellitus properly in any field. Before we proceed, I would like to welcome to our special guest for today. Welcome to the Honorable Dr. Gigi Arianti Anaya MKM as a Director General of Health Workers of the Republic of Indonesia, and also for Dr. Eva Susanti SKP MKes as General Director, Directorate of Non-Communicable Disease Prevention and Control, who represent Dr. Maxi Rain, General of Disease Prevention and Control of the Republic Indonesia, and also the Honorable Dr. Muhammad Wildan Aparpan, MPD, as an advisor and also Director of Health Polytechnic of Malang. Thank you, sir. And for all of Vice Director of Health Polytechnics of Malang, all of Heart of Study Program and any unit in Health Polytechnic of Malang, the committee, and also the distinguished speaker of the conference, and the last but not least, all of participants and audience will come or attend of this event today. So let me introduce myself. My name is Rizky Mustika Riswari. Ladies and gentlemen, International Conference and Workshop of Health is an annual scientific agenda that has been held since 2016. And we stopped at the beginning of the pandemic era. Alhamdulillah, say thank you for God that this year we can be held event. Is this still online in the framework of the anniversary of our institution. So I would like to say happy birthday also to Health Polytechnic Malang. We will very grateful for the full support of our management and all colleagues, our strategic partner from other universities abroad and within the country. We have a speaker from Visayas State University of Philippines, and I see that Mr. Dr. Joel Ray has attended. Thank you, Dr. Joel, for your support. And also, I would say thank you for Dr. Jenalin Lakman Taguiam from St. Paul University of Philippines. And also, I would like to say thank you very much for Dr. Suhatman Ramli as a chairman of World Safety Organization Indonesia. And I would like to say thank you for Dr. Kuryah Abdul Hamid from University Technology Mara, UITM, Malaysia. And the last one, I would like to say thank you also for Professor Dr. Barakatunisa from University Putra Malaysia, and I send our grateful for our speaker come from Health Polytechnic of Malang. The first one is Dr. Etik Sulistyawati and Dr. Roni Yuliwar and also Dr. Nurul Hakimah. For this year, we also received papers that will be published in the proceeding with ESBN. Thank you for all supported about that. So I would like to say thank you for all those who are very helpful. So this annual agenda can be carried out smoothly. And we hope that this event can be useful for all of us. So I say thank you and happy enjoy our conference for today's letter. So thank you. I think this is my report. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Waalaikumsalam warahmatullahi wabarakatuh.
Thank you very much, Ma'am Rizky Mustikariswari, for the speech.
Okay, so for all dear participants, the next agenda is the welcome speech from our Director of Health Polytechnic of Malang. So please welcome Dr. Muhammad Wildan, Aperban MPD.
Thank you very much, Ms. Anandayu.
Yes, Doctor.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam
Good morning, everyone.
wabarakatuh.
Shalom, Om Swastiastu, Namo Buddhaya, Salam Kebajikan, Rahayu. Ladies and gentlemen, allow me this opportunity to welcome all you this conference. We praising for all speech good for all His blessing, grace, and mercies that have made it possible to gather here is this excellent condition and health. Let me also say thank you to representative of Ministry of Health, Republic of Indonesia, the first General Director of Headwalker, Ibu Dr. Gigi Arianti Anaya, MKM, the second Director PPPTM, Directorate General of Disease Control and Eradication Program, Ibu Dr. Eva Susanti, SKP MKes, and all securities keynote speaker and beloved participant. Thank you for all your support and contribution to this effort. Dear all, on behalf of myself and the management of Poltekkes Kemenkes Malang, I would like to welcome you all in our annual event, the 6th International Conference and Workshop of Health, with the theme of the post-pandemic challenge, current health sciences related to diabetes mellitus management. This theme is considered to be important due to condition nowadays, which show some increase in diabetes mellitus prevalences in our society. This situation emerges because of the changing lifestyle of our society now. People now tend to have an unhealthy lifestyle and consume more unhealthy foods. Through this conference, we are going to share some studies and insights related to matter to the hope that they will bring positive impact to improve the health condition of our community. As we all know, a healthy society will bring about a healthy nation. So it's our responsibility as a part of health community to support goal and conducting this event is one of the effort to achieve it. We all should admit hand in hand to together to create better future for our better generation. Having a healthy nation is one of these to reset at that stream. Poltekkes Kemenkes Malang, as one of the higher education institutions focusing on health field, must be actively involved in this attempt and is also an accorded with your vision to become of civilized to globally competitive health polytechnic. Ladies and gentlemen, in the following 2 days, we are going to listen to health scientific finding and discoveries in this very awesome opportunity for us to get for knowledge and information in order to deal diabetes mellitus case. Getting more ideas will open up our mind and make us more capability in handling the problem. I believe by contributing actively in this conference, we are already contributing for the betterment of our country. Let us enjoy the conference and make the most of it. Finally, reciting Bismillahirrahmanirrahim, this conference is officially opened. Thank you. Bila taufiq wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you so much for our director. And the next one, please, Pak Andi.
Okay, thank you, ladies and gentlemen. We are now continuing our meeting to the next agenda. That is to listen the keynote speech and also the opening remark by Dr. Gigi Anaya, MKM, Director of General of Health Worker of Republic of Indonesia, and also Dr. Eva Susanti, SKPMkes, General Director of Directorate of Non-Communicable Disease Prevention, which will be led by Ma'am Dr. Ekowati Retnaning Tias, SKPMkes, as the moderator. Before that, I would like to introduce her briefly. Ma'am Ekowati Retnaning Tias is one of lecturer in State Health Polytechnic of Malang. Broadly, her research focus in diabetes mellitus management for specific purpose. Ma'am Eko, are you there?
Hello.
Yes, Ma'am Eko, please, time is yours.
Thank you, Mr. Andi. Assalamualaikum warahmatullahi wabarakatuh. Shalom, Om Swastiastu, Namo Buddhaya, Salam Kebajikan. Welcome in Health Polytechnic of Malang. We are delighted to welcome you for the International Conference and Workshop of Health under the title Post-Pandemic Challenges, Current Health Science Development Related to Diabetes Mellitus Management. That will be held today, November 27 until 28, 20. Okay. Yeah. Thank you. Before we proceed, I would like to welcome our special guest today. Welcome to the Honorable Ma'am Arianti Anaya MKM as Director General of Health Worker of the Republic Indonesia, and Dr. Eva Susanti, SKPMkes, as General Director, Directorate of Non-Communicable Disease Prevention and Control. The Honorable Dr. Muhammad Wildan, Upper Pen MPD, as Advisor and Director of Health Polytechnic in Malang. Thank you, sir. All of Vice Director Health Polytechnic of Malang, all of Health of the Study Program and Health Polytechnic of Malang, and the Chair of the Committee and Team of Installation Center of Excellence Science and Technology for Health Polytechnic of Malang. The last speaker of the conference, and last but not last participant and audience. We give thanks to God present because He has graced we were able to attend the International Conference and Workshop of Health in Malang Ministry Health Polytechnic. This activity is culmination of the Ministry of Health Malang Health Polytechnic celebration and commemorates National Health Day as well as World Diabetic Day. The international conference and workshop of health in the leading science and technology center activity program. The first keynote speaker in this morning, there is Ma'am Dr. Eva Susanti, SKP MKes, as General Director, Directorate Non-Communicable Disease Prevention and Control. The topic is optimizing the roles and contribution of health polytechnic in supporting health transformation in Indonesia to deal with non-communicable disease. Time and yours.
Dr. Eva?
Halo, Assalamualaikum
Oke.
warahmatullahi
Waalaikumsalam warahmatullahi wabarakatuh. Okay,
Okay. Morning, ma'am.
Morning. Assalamualaikum warahmatullahi wabarakatuh. Good
Waalaikumsalam.
morning. Salam,
Waalaikumsalam.
Om Swastiastu, Namo Buddhaya, salam kebajikan, salam sehat. The Honorable Director of Poltekkes Malang, the speaker, ladies and gentlemen. First of all, we praise the Almighty for His mercy and blessing, so that we can attend the 6th International Conference and Workshop of Health in this morning. I appreciate the Health Polytechnic of Malang for organizing the International Conference and Health Workshop in 2023 with the theme Optimize the Role and Contribution of Health Polytechnic in supporting health transformation to address of non-communicable diseases. Ladies and gentlemen, as we all know, non-communicable disease contribute to 73% of death in Indonesia, and the trend of increasing the prevalence of non-communicable disease is also increasing along with the increase in the risk factor. This is a problem for health development in Indonesia because it increases the burden of health financing. Currently, report NCDs are only the tip of the iceberg and need to be addressing systematically and comprehensive at every level of healthcare. The four main metabolic risk factors for NCDs, including overweight or obesity, high blood pressure, high blood sugar, and blood fat, are referred to as NCD behavior risk factor. In order to prevent and control the risk from developing into NCDs, they must be identified early. Basic health research data has shown the common risk factor that correlate to people behavior may increase the risk of growing NCDs. This lifestyle where smoking, lack of physical activity, low consumption of fruit and vegetable, and high consumption of sugar, salt, and fat. Choose the prevent and control the NCDs. It is important to improve health promotion and educating the public to implement healthy lifestyle. Ladies and gentlemen, policies and strategies for prevention and control of non-communicable disease that have been stipulated by law number 70/2023 concerning health residential instruction number 1/2023 17 of the Healthy Living Community Movement, Minister of Health Regulation number 71, 70, 2053 on NCD mitigation, Minister of Health Regulation concern the inclusion of information on the content of sugar, salt, and fat for processed food and ready-to-eat food. Minister of Health Regulation concern the minimum service standard in the health sector and synergize with health-related law and regulation and global commitments such as the SDGs, WHO Global Action Plan for the Prevention and Control of NCDs, Global Action Plan on Physical Activity, and global recommendation in the WHO Acceleration Plan to Stop Obesity document as well. Ladies and gentlemen, the Ministry of Health is committed to develop future improvement by carrying out health transformation. This transformation is not only to improve the health service system, but also to encourage the achievement of national medium-term development plan indicator. The Ministry of Health Strategic Plan and the minimum service standard, the health transformation has 6 pillars to be strengthened, namely primary service, referral service, health security system, health financing system, health human resource, and health technology. Health transformation encourage the achievement of long-term goal indicator. The indicator choose correlate to NCDs are decreasing smoking prevalence in the population at 10 and 18 years and halting the prevalence of obesity the at 10 and 80 years and above. To achieve this indicator, the strategy should be strengthen primary care system by educating people to implement healthy lifestyle, action screening, increasing to capacity and capability of primary services, improve access and quality of secondary and tertiary services support by health financing system, and advocated related stakeholders to improve health in all policies. To generate evidence-based data, Ministry of Health has developed aplikasi Sehat Indonesiaku, an application to be used as platform for integrating, recording, and reporting in real time. Currently, ASIC is only applied to immunization program and non-communicable disease, but in the future, it will continue to all health program and it will work interoperable to other existing health reporting system. Ladies and gentlemen, support and contribution from across sector, including academic, professional organization, research institution, local government, community organization, and the private sector are needed to strengthen the Ministry of Health effort in preventing and controlling non-communicable diseases, including health promotion, early detection, and research related to non-communicable disease, so that the result will give the impact to the healthy society. Ladies and gentlemen, I hope that brilliant ideas will emerge at this conference that will lead to inspiring and exchange real action for healthier Indonesia, especially prevention non-communicable diseases. Finally, thank you for your attention and presence. Hopefully, this conference will be fruitful and have a positive impact on health in Indonesia. Wassalamualaikum, salam, Om Santi Santi, Om Namo Buddhaya, and thank you.
Thank you, ma'am. Now maybe we Dr. Aryani maybe still have some time to have a discussion with Dr. Eva. For all the participants, if you have any question, please leave your hand in the comment section, or you might ask directly by presenting the raise hand button. Maybe there are questions for Dr. Eva. Boleh bertanya pakai bahasa Indonesia. Bisa ya Bu Eva? Silahkan mahasiswa.
Bisa Bu Eko.
Ya, mungkin saya Bu Eva. Kalau kita lihat kami unggulannya diabetes. Nah, sampai saat ini diabetes ini masih merupakan masalah bagi pemerintah. Nah, kira-kira mungkin apa yang menjadi satu program dari B2PTM ini, mungkin kami bisa, karena nanti kami juga ada sentra unggulan pendidikan yang ada di tempat kami juga mengambil diabetes. Nah, ini mungkin waktu yang tepat kita bisa ketemu Bu Eva, bagaimana untuk ke depannya, itu untuk kita bisa menurunkan angka prevalensi ini, bisa nanti kita melakukan kegiatan yang seiring dengan program yang ada di B2PTM. Mungkin itu Bu Eva.
Terima kasih Bu Eko. Jadi memang terkait dengan diabetes ini, Kementerian Kesehatan kan tadi saya sampaikan ada 6 pilar untuk memperkuat capaian indikator kinerja terkait RPJMN, di mana di pilar ke-1 kita mengupayakan komunikasi informasi dan edukasi serta melakukan screening deteksi dini Bu Eko. Nah, di screening deteksi dini ini, jadi kami memang sangat mengharapkan bantuan dari seluruh lintas sektor. Sampai saat ini kita baru sekitar 32% masyarakat Indonesia dari target yang kita harapkan tahun ini adalah sekitar 140 juta, tetapi baru sekitar 47 juta masyarakat Indonesia yang dilakukan screening. Jadi memang kita membutuhkan kerjasama semua pihak untuk bisa melakukan deteksi dini, Bu Eko. Jadi nanti silahkan berkoordinasi dengan dinas kesehatan masing-masing provinsi atau kabupaten kota setempat, dan nanti juga akan kami bantu koordinasikan juga serta dengan kami dari Kementerian Kesehatan. Artinya kita juga bisa ikut membantu untuk melaksanakan. Yang penting Politeknik Kesehatan mungkin membantu mengumpulkan orangnya gitu ya Bu Eko ya. Memobilisasi masyarakat yang ingin dilakukan screening. Nah, bagi yang sudah terkena, jadi kita mempunyai target indikator bagi penanganan kasus diabetes ini, bahwa setiap pasien diabetes itu kan harus gula darahnya terkontrol, Bu Eko. Itulah yang dinamakan keberhasilan tata laksana diabetes. Karena kita tahu diabetes ini adalah mother of disease. Jadi ketika permasalahan penyakit diabetes ini dia terkontrol, dia tidak akan terkena penyakit jantung, tidak terkena stroke, dan tidak terkena ginjal. Tapi kalau misalnya dia tidak terkontrol gula darahnya, dia akan mudah terkena penyakit jantung, terkena penyakit ginjal, dan penyakit-penyakit lainnya. Nah, oleh sebab itu, memang sudah menjadi kewajiban dalam hal ini pemerintah yang merupakan standar pelayanan minimal yang ada di kabupaten kota, bahwa setiap pasien diabetes itu harus terkontrol 100%. Nah, silakan nanti mengakses layanan setempat, Bu Eko, bagi yang misalnya masyarakat yang memang sudah terkena diabetes untuk mengakses layanan sehingga dia diberikan pengobatan, diberikan edukasi bagaimana dia harus melakukan upaya sehingga gula darah bisa terkontrol dan tetap diberikan pemeriksaan gratis untuk ngecek gula darahnya. Gitu ya Bu Eko. Dan sementara itu di layanan tersebut kita juga melakukan sistem pengampuan layanan. Artinya gini, Rumah Sakit RSCM sebagai pusat pengampu nasional bagi diabetes ya, khususnya diabetes tipe 2, itu kita akan rumah sakit SDM itu akan memberikan pengampuan kepada rumah sakit di bawahnya, termasuk di kabupaten kota tersebut, ya, yang paling ujung kabupaten kota yang memiliki rumah sakit, dia akan diberikan cara tata laksana yang terbaik terkait diabetes, sehingga diabetes ini minimal di kabupaten kota itu dia mampu melakukan perawatan nantinya yang kita inginkan adalah madya skalanya. Nah, kemudian kita juga menggandeng artinya rumah sakit terbaik penanganan diabetes level dunia, yaitu yang ada di Amerika. Nah, itu kita sudah melakukan layanan secara bersama. Artinya layanan yang kita buat di rumah sakit RSCM itu skalanya sama dengan pelayanan yang diberikan di rumah sakit terbaik di dunia, sehingga masyarakat kita tidak akan mencari pelayanan ke luar negeri lagi, Bu Eko. Nah, itu pada sistem pilar kedua. Nah, di pilar ketiga kita mengupayakan kan pilar ketiga ini terkait bagaimana kita menyiapkan tenaga kita ya sebagai tenaga cadangan, agent of change-nya PTM. Jadi kita memperbanyak, tadi kami berterima kasih kalau misalnya Politeknik Kesehatan Malang menjadikan mahasiswanya sebagai agent of change-nya PTM yang bisa memberikan edukasi, mengajak seluruh masyarakat dan melakukan upaya-upaya untuk bisa menjangkau, memberikan informasi yang sebaik-baiknya kepada masyarakat. Karena masyarakat kita ini kan sangat banyak dari Sabang sampai Merauke, jadi tidak cukup hanya mengandalkan dari tenaga kesehatan yang ada. Kemudian juga kita di samping itu, kita mengupayakan bagaimana kita membuat produk untuk pelayanan terhadap penyakit ini adalah produk dalam negeri. Jadi dengan produk dalam negeri ini kita melakukan terobosan inovasi untuk bisa menciptakan produk dengan dalam negeri yang nantinya bisa terjangkau, murah dan berkesinambungan gitu Bu Eko, karena kita belajar dari pengalaman kita terkait dengan COVID. Nah, di pilar berikutnya, pilar kelima adalah kita mengupayakan bahwa pelayanan ya untuk terkait dengan pembiayaan itu adil dan memang bisa dinikmati oleh seluruh masyarakat. Jadi uang yang ada untuk pasien itu harus efektif, efisien. Dan saat ini di teman-teman puskesmas sudah ada yang bisa di luar kapitasi. Jadi misalnya ketika mereka melakukan pelayanan yang memang di luar kapitasi, itu mereka bisa mengklaim layanan tersebut, sehingga bisa juga dirasakan manfaatnya oleh teman-teman dan juga dirasakan oleh masyarakat karena layanan akan semakin baik. Nah, kemudian yang berikutnya bagaimana kita mentransformasi tenaga kesehatan. Jadi kami di Kementerian Kesehatan dan didukung oleh Politeknik seluruh Indonesia juga ya Bu Eko ya, karena sebagai salah satu untuk menciptakan SDM yang unggul dan berkualitas. Jadi kita menginginkan tenaga SDM kita itu unggul dan berkualitas. Nanti akan kita berikan beasiswa dalam dan luar negeri. Kemudian kita juga akan melakukan upaya terutama pelatihan-pelatihan singkatnya juga termasuk dengan pendidikan yang cepat ya untuk dokter, perawat, bidan dan sebagainya, sehingga tenaga kesehatan ini kita harapkan cukup untuk menangani permasalahan kesehatan yang ada di Indonesia. Nah, kemudian yang berikutnya pilar ke-6 itu adalah bagaimana kita melakukan upaya. Tadi saya sampaikan bahwa kita sudah memiliki aplikasi Sehat Indonesiaku yang datanya by real time secara terbaharui setiap waktu dari Sabang sampai Merauke. Jadi ketika teman-teman menginput di satu puskesmas, makanya datanya akan terbaharui di seluruh Indonesia sehingga kita bisa betul-betul mendapatkan data yang valid terkait permasalahan penyakit di negara kita ini. Bisa saya sampaikan bahwa dari hasil screening kita ini Mbak Eko, misalnya dari 47 juta masyarakat Indonesia yang sudah masuk ke dalam aplikasi sehat itu, misalnya sudah terdata berapa orang sih yang menyandang diabetes, berapa orang yang menyandang hipertensi, dan mereka ini kemana nantinya, apakah sudah mendapatkan pelayanan yang sesuai, sehingga kita bisa tahu ini by name by address. Jadi dasar datanya itu adalah NIK Bu Eko. Jadi memang betul-betul datanya itu di screening dan tidak ada data double. Jadi ketika masyarakat itu nanti dia terkena diabetes, dia akan bisa ketahuan nih mereka sudah melakukan kontrol belum ya, jadi bisa tahu juga ada datanya dengan kita. Nah, ini termasuk nanti akan digabungkan dengan registri penyakit yang ada di rumah sakit. Jadi kita akan memperbaiki sistem pendataan nasional kita supaya memang lebih baik, lebih valid, sehingga bisa diakses oleh seluruh masyarakat dan oleh kita semua untuk bisa memberikan inovasi lagi terkait hal-hal yang memang perlu perbaikan ke depannya. Demikian Bu Eko, terima kasih.
Makasih Bu Eva. Jadi menarik sekali apa yang sudah disampaikan. Jadi saya lihat ada screening, kemudian ada persiapan untuk peningkatan SDM, kemudian membuat produk, membuat pelatihan. Bu Eva, mungkin kami sedikit menyampaikan, mungkin nanti dari Pak Direktur, Pak Wildan juga bisa menyampaikan bahwa saat ini sentra unggulan pendidikan di Poltekkes Kemenkes Malang itu mengarah ke diabetes, penyakit diabetes. Jadi nanti program diabetes ini itu kita insertkan di masing-masing program studi, Bu. Dan kami ini ada 30 program studi. Dan ini satu hal yang sangat baik sekali buat kami, karena saya lihat ada yang menarik ini membuat produk. Mungkin kita bisa kerjasama dengan Poltekkes untuk penelitian, Bu, karena ada beberapa dosen yang sudah menghasilkan produk terkait dengan penanganan kasus diabetes. Ada yang membuat krim, kemudian ada membuat seperti dari gizi ini kudapan gitu yang untuk menurunkan kadar gula karena indeks glikemiknya rendah. Jadi ini sangat apa ya, hal yang baik buat kami, Bu, untuk kami bisa nanti mendukung ya Pak Wildan program sentra unggulan pendidikan ini karena memang mengarah ke sana. Mungkin Pak Wildan bisa sedikit memberikan informasi terkait dengan SUP, mumpung di sini ada Bu Susanti, Bu Eva ini sebagai Direktur di P2 PTM. Monggo Pak Wildan.
Oke, terima kasih Bu Naning. Matur nuwun Bu Eva, Susanti. Akhirnya ketemu juga di forum ini. Kita sering ketemu waktu rapat-rapat Zoom saya sering ikuti Bu Eva. Jadi terima kasih atas perkenannya untuk menjaga materi dan alhamdulillah sudah berjalan. Jadi sebagaimana tadi sampaikan oleh Bu Naning, Poltekkes Kemenkes Malang itu ditunjuk Bu Dirjen sebagai salah satu Poltekkes yang mempunyai penciri khusus. Karena Pak Menteri kan maunya Poltekkes mempunyai penciri-penciri yang hubungannya dengan penyakit katastrofis ya. Nah kita kebetulan DM karena emang sudah lama kita sudah ada riset-riset yang berkaitan dengan DM. Nah ini suatu hal yang baik dan menjadi tantangan ya bagi kita karena kalau dulu mungkin hanya satu prodi, dua prodi yang memilih konsentrasinya spesifik pada DM, sekarang kan harus semua prodi. Jadi karena Poltekkes. Ya, kalau perawat, Bu Eva kan perawat, saya kira lebih mudah ya dengan orientasinya. Tapi nanti akan kita kembangkan mulai dari preventif sampai dengan mungkin kuratif dan sebagainya. Nah, perawatnya prodinya cukup banyak, ada 4 atau 5 ya, yang dari D3 dan sarjana terapan dan profesi. Kemudian gizi ya relatif mudah karena dengan diet produk-produk dan itu sudah berjalan. Bidan mungkin ada kaitannya, promkes ya memang, tetapi ada juga prodi-prodi kami itu yang memang harus menyesuaikan dengan istilahnya peminatan khusus ya, penciri khusus di MD. Karena kita punya prodi-prodi yang sifatnya non layanan, misalkan rekam medis ya kemarin ya kita harus belajar betul-betul bagaimana pencatatan, bagaimana tadi kan ada data-data satu set yang berhubungannya dengan penyakit-penyakit diabetes, termasuk kita punya prodi asuransi kesehatan. Kita akan kaji bagaimana pembiayaan tentang asuransi kesehatan itu, kita analisis, kita apa dan sebagainya kosnya, karena katanya penyakit PTM itu kan penyakit yang menghabiskan banyak anggaran dari pemerintah. Kemudian juga nanti ada anafarma, ada TBD, teknologi bank darah. Mungkin kita nanti kita kaji bagaimana sih masalah pendonor darah dengan darah. Untuk itu dalam kesempatan ini mungkin saya matur, nanti kita akan terus berkonsultasi Bu ya dengan Direktorat PTM ini hingga kita akan mendapatkan suatu arahan, karena intinya Pak Menteri kan bilang apa yang dilakukan Poltekkes itu harus sesuai dengan programnya pemerintah dan kebutuhan pemerintah. Yang tahu kan Pak Jenengan. Jadi nanti kita tetap akan berkolaborasi tentang apa-apa yang harus kita lakukan dan mungkin bagaimana apa yang harus kita bantu, dan juga nanti kita akan minta bantuan Ibu tentang bagaimana untuk penggalangan program-program kita. Mungkin ini yang saya sampaikan, matur nuwun.
Terima kasih Pak Direktur. Kami menyambut baik ya Bu Eko, ini saya mohonlah ini langsung nih tadi. Karena saya senang sekali karena Pak Direktur sudah menyampaikan ada beberapa hal yang memang kami sangat mengharapkan bantuan ya, terutama dari Poltekkes Malang salah satunya, yang memang kita mengupayakan bagaimana penanggulangan penyakit tidak menular khususnya diabetes ini bisa menjadi lebih baik, karena memang diabetes ini merupakan salah satu perintah kepada masyarakatnya. Jadi tentu kita harus memberikan pelayanan ini adalah pelayanan yang terbaik. Terima kasih Pak, kami akan siap nanti kapan-kapan saya juga akan kunjungi Poltekkes Malang. Mungkin kita akan bicara terkait kerjasama yang bisa kerjasamakan ke depannya untuk bisa melakukan upaya terbaik untuk bangsa dan negara ini. Terima kasih juga Bu Eko.
Terima kasih Ibu.
Terima kasih Bu Eva. Masih ada waktu sambil menunggu Bu Aryani, Bu Dirjen belum bisa join dengan kami. Masih ada beberapa waktu, silahkan teman-teman, Bapak Ibu Guru, mau bertanya, Bu dosen, mahasiswa, monggo mumpung ada Bu Eva di sini. Saya tadi lihat Bu Ana, ada Bu Tuti. Ada yang mau join dengan kami atau mungkin bisa beberapa pertanyaan yang disampaikan? Menunggu teman-teman yang mau tanya. Bu Eva, ini kira-kira kalau yang terkait dengan pembuatan produk yang selama ini sudah dilakukan oleh P2PTM, kira-kira mungkin kami bisa dapat gambaran yang apakah ini memang program dari P2PTM mengadakan penelitian gitu atau kerjasama dengan ini. Kalau misalnya kami bisa kerjasama, bentuknya seperti apa?
Iya, terima kasih. Jadi memang tadi yang terkait itu ya Bu ya, memang kita diminta Pak Menteri juga bekerja sama dengan seluruh Poltekkes. Masing-masing Poltekkes itu kami sesuai dengan binwilnya kita sudah menyiapkan dana penelitian, itu pertama Bu. Kemudian jadi memang penelitian yang dimau oleh Pak Menteri adalah penelitian yang terkait dengan permasalahan program. Jadi seperti itu. Jadi harus inline terkait dengan pelaksanaan penelitian tersebut. Nah, kemudian terkait kerjasama yang lain, saya setuju tadi kalau misalnya ada produk yang sudah dihasilkan oleh
Poltekkes, Bu.
Poltekkes, karena kan kita sebenarnya ada juga yang salah satu direktur yang membidangi terkait dengan obat-obatan tradisional ya Bu. Nah, terkait dengan tadi makanan itu juga itu bisa, kalau memang itu sudah bisa dibuktikan secara ilmiah oleh teman-teman dari Poltekkes Malang, itu bisa kita sampaikan. Dan kami juga sebenarnya punya kenal juga banyak industri ya, punya kenal juga banyak lintas sektor, bagaimana nanti kita seperti apa kita mau seperti ke depannya. Apakah memang itu kita jadikan sebagai pengembangan dari produk yang harus disiapkan oleh industri kah, atau memang kita buat di dalam bentuk produk yang memang seperti jamu gitu ya Bu. Nah, jadi seperti itu. Jadi tinggal nanti pilihannya kepada teman-teman dari Poltekkes. Nah, kita kan juga banyak bekerja sama dengan industri-industri yang nanti bisa kalau memang itu sudah ada penelitiannya ya, dasar hukum yang dasar keilmuan yang mendasarinya. Nah, terkait dengan produk-produk ini, saya juga kemarin sempat berbicara banyak dengan industri ya, industri Indonesia. Artinya kan memang kan kita didorong nih, artinya kita harus mengeluarkan produk dalam negeri ya Bu Eko ya. Jadi seperti itu, kita sekarang berkeinginan Poltekkes juga menjadi salah satu yang bisa menghasilkan produk unggulan anak bangsa ini. Karena apapun yang kita beli sekarang sebenarnya kan sudah ada Perpres peraturan presiden bahwa kita harus menggunakan produk dalam negeri Bu Eko. Jadi seperti itu. Nah, itu tadi misalnya seperti makanan dan lain sebagainya. Kita sebenarnya sudah ada bahkan penelitian untuk nutrigenomik. Nutrigenomik itu misalnya pada saya misalnya atau Bu Eko atau Pak Direktur, ketika misalnya diteliti secara gen, kira-kira Bu Eko atau saya ini secara gennya itu makanan seperti apa yang harus diasup dan seperti apa yang harus dikonsumsi. Nah, itu juga kita sudah sampai kepada tahap itu dan itu bisa dilakukan. Jadi itu sangat baik sekali menurut saya, hal yang memang penting untuk dikembangkan. Tinggal nanti mungkin kita akan lihat seperti apa sebenarnya yang dihasilkan oleh teman-teman, Bu. Jadi seperti itu. Terima kasih.
Terima kasih Bu Eva ini.
Iya, ini ada juga Dokter Esti, ini Katimja DFDM. Silakan Bu Esti, mungkin ada yang mau ditambahkan. Ini saya perkenalkan, ini Ibu Direktur, Bapak Direktur dan Ibu Eko. Ini ada Dokter Esti sebagai Katimja, Ketua Tim Kerja Diabetes mellitus dan gangguan metabolik ya. Jadi nanti secara teknis Bu Esti akan banyak bisa untuk membantu saling bekerja sama ya antara Protekes Malang dengan kita. Silakan Bu Dokter Esti.
Cukup Bu, dari saya. Udah lengkap dari Ibu.
Salam kenal Bu Esti.
Iya.
Ya,
Buka
salam
kamera
kenal,
dulu
Bu
biar
Esti.
Pak juga hadir.
Dari Malang. Nanti mungkin lebih banyak tanya-tanya ke Bu Esti terkait dengan penata laksanaan DM, penelitian terkait dengan DM. Mungkin juga ada pelatihan-pelatihan Bu yang kami juga butuhkan, entah itu perawatan luka kaki atau apa yang bisa nanti kita sharekan ke mahasiswa, juga nanti kita bisa kerjasama dengan klinik, puskesmas, ataupun di rumah sakit untuk kita bisa jadi edukator. Jadi kan tadi juga ada terkait dengan pelatihan singkat gitu, nggih.
Iya, bisa Bu, bisa.
Iya.
Bisa.
Bu Nani bertanya Bu Nani.
Oh iya, silakan Pak Roni.
Oke, izin Bu bertanya untuk Dokter Eva terkait tadi Bu bahwa Poltekkes Malang tadi ada target untuk menghasilkan produk-produk yang terkait UDM Bu. Nah, untuk regulasi kalau misalnya dosen telah menghasilkan suatu produk dan penjualan itu bagaimana Bu? Mohon pencerahan. Terima kasih.
Ya, terima kasih Bu pertanyaannya ya. Saya langsung ya Bu ya, biar Bu Eko ini mau di dekat lift nanti takut sinyalnya hilang. Jadi gini, memang terkait dengan produk-produk yang sudah dihasilkan, tentu kita harus apakah itu produk makanan biasa gitu ya Pak. Kalau dalam makanan biasa kan tentu dengan UMKM ya Pak. Kalau hanya berbentuk makanan. Tetapi kalau itu produk dalam produk yang atau makanan untuk kesehatan ya, misalnya kayak seperti jamu ya itu tentu ada salah satu di direktorat kita yang memang untuk bagian khusus terkait itu ada yang bisa memfasilitasi nanti kita namanya di fasilitas di Yankes kalau nggak salah di pelayanan kesehatan ya sekarang itu yang memang khusus untuk menangani permasalahan tersebut Bu Eko. Jadi nanti bisa kita nanti bisa ke Kementerian Kesehatan artinya untuk bisa mendapatkan informasi lebih detailnya gitu ya Bu Eko ya. Yang penting apa yang mau di itu apa atau memang kalau misalnya produknya itu berbentuk misalnya BMHP gitu ya, bahan medis habis pakai. Nah, itu kan harus ada nanti keluar izin edarnya, nomor NIE-nya, kemudian ada AKD-nya, nomor AKD-nya dicatatkan. Jadi hal-hal seperti itu, Ibu, untuk yang harus dilakukan oleh teman-teman.
Terima kasih Bu Eva. Cukup banyak informasi penting yang kami dapatkan pada pagi hari ini. Kebetulan ya. Iya Pak.
Baik, saya Bu Naning. Bu Win.
Oh ya Bu Win. Terakhir Bu Win ini ya.
Ya.
Bu Win ya, Pak Ibnu.
Hari ini di jalan.
Pak Ibnu. Silakan Bu Win.
Assalamualaikum warahmatullahi wabarakatuh. Kenalkan Bu Eva, saya Bu Vin. Kebetulan yang diberi tugas Pak Wildan mengkawal tentang penelitian dan pengabdian masyarakat. Ada beberapa hal yang mungkin yang saya tanyakan terkait dengan kajian atau penelitian kebijakan, terutama adalah membuat sebuah kegiatan yang kaitannya dengan policy brief, Bu Eva. Apakah diarahkan juga, artinya mungkin ada satu regulasi-regulasi yang bisa kami dapatkan, atau mungkin terutama adalah mengarah ke PTM, sehingga untuk mengarahkan penelitian maupun mengkawal PUI yang ada di Poltekkes Malang ini, harapannya nanti juga bisa bergabung, sehingga atau mungkin kami mohon arahan, terutama adalah kaitannya dengan regulasi. Utamanya saat ini di Poltekkes Malang lagi mengkawal kaitannya SUP-nya adalah DM. Namun untuk mendukung DM itu tentu saja kami di wilayah wilayah binaan memang sedang mengembangkan tentang PTM, sehingga regulasi dan ataupun kebijakan atau penelitian-penelitian yang sifatnya nanti menghasilkan policy brief kebijakan ini barangkali kami butuh arahan, atau mungkin barangkali Bu Eva bisa memberikan gambaran. Begitu Bu Eva yang saya tanyakan.
Oke, terima kasih banyak Bu.
Bu Sriwin Narni.
Ya, terima kasih banyak Bu Sri Winarni atas pertanyaan yang sangat bagus sekali. Jadi terkait dengan regulasi ya atau policy brief yang sudah misalnya dari teman-teman Poltekkes sudah melakukan penelitian, kemudian kira-kira itu sangat baik untuk bisa disampaikan ke kita. Jadi kami bersedia Bu, artinya akan kita fasilitasi untuk bisa policy brief yang dibuat oleh teman-teman ini, kalau memang ini maksudnya kita paparkan dulu di teknis ya. Teknis itu artinya Kementerian Kesehatan, kemudian teman-teman dari organisasi profesi ya Bu. Jadi kita akan membuat policy brief itu lebih berdaya guna dan memang bisa diterapkan nanti. Nah, setelah kita memang baik, ternyata maksudnya itu sangat kita butuhkan kalau secara penilaian kita, itu bisa kita sampaikan ke Pak Menteri, Bu. Terima kasih.
Jelas ya, Bu Win.
Ya.
Terakhir Pak Ibnu, monggo Pak Ibnu.
Ya, baik, terima kasih Bu Naning. Ini mohon maaf Bu Eva, saya Ibnu Fajar dari jurusan gizi, ini sedang menuju bandara, mau ke Semarang, untuk des dengan Bu Mega terkait dengan sentra unggulan Poltekkes Bu Eva. Bu Eva dari jurusan gizi itu memang sudah banyak penelitian-penelitian tentang produk yang akan mendukung terhadap pencegahan untuk DM termasuk juga penanganannya. Nah, di sisi lain kami juga mengembangkan teknologi alat kesehatan Bu Eva. Jadi ke depan itu bagaimana untuk menangani pasien DM supaya bisa lebih cepat, kemudian waktu tinggal di rumah sakit lebih cepat lagi. Kami membuat alat-alat yang bisa mempercepat pelayanan terutama ahli gizi, yaitu ada yang dietitian, sehingga nantinya bisa kita ikut membantu mempercepat penurunan daripada penderita DM ini. Kami sudah ada produk yang segera akan kami urus patennya Bu Eva. Mohon nanti dukungan dari Dirjen Nakes supaya nanti alat-alat kesehatan yang kami kerjasama dengan Politeknik Elektronika Surabaya Bu Eva. Jadi kami punya konsepnya, mereka yang menerjemahkan. Sehingga dari jurusan gizi tidak hanya dari produk, tapi juga teknologi alat kesehatan yang di pilar ke-6. Saya kira demikian Bu Eva dari kami. Saya Ibnu Fajar dari jurusan gizi Poltekkes Malang. Terima kasih.
Terima kasih Pak Ibnu atas penjelasannya. Itu sangat baik ya Pak. Memang kita menginginkan bahwa ke depan bagaimana generasi kita ya, anak bangsa kita ini menghasilkan berbagai penemuan terbaru ya. Karena kalau kita ingin menjadi negara maju ya Pak, tentu kita harus membuat suatu terobosan-terobosan. Dan alhamdulillah itu sebenarnya kan kita sudah didukung oleh Pak Presiden, di mana bahwa memang Pak Presiden sudah sesuai dengan instruksi Presiden ya, bahwa itu sudah memang kita mewajibkan penggunaan produk dalam negeri. Nah, cuman untuk penggunaan produk dalam negeri ini yang terpenting kita harus melakukan uji ya Pak, melakukan uji terhadap produk yang memang dilakukan. Ini contohnya misalnya begini. Ketika kita misalnya membuat suatu anggaplah misalnya reagen gitu ya. Nah, kita membuat reagen. Nanti kita akan uji reagen yang kita buat itu apakah memang spesifisitasnya, kemudian sensitivitasnya sama dengan reagen yang memang sudah teruji melalui WHO gitu kan. Nah, itu nanti tinggal dibandingkan datanya itu, misalnya ini produk buatan kita, produk A. Kemudian ini ada produk buatan B dari luar negeri dan bahkan mungkin sudah bagus lah, sudah dapat dia dari WHO misalnya ininya. Nah, itu tinggal kita bandingkan Pak, kita uji misalnya ada 30 orang menggunakan produk kita, kemudian 30 orang lagi menggunakan produk yang tadi, bagaimana nih nanti hasil spesifitas 6%. Nah, itu bisa berarti kita
Ya baik Bu Eva, terima kasih.
Iya, mohon maaf karena waktunya sudah hampir habis. Jadi nanti kalau misalnya ada Bapak Ibu yang mau menanyakan terkait dengan program dari P2PTM, nanti kita bisa koordinasi dengan Bu Eva atau Bu Esti, Dr. Esti tadi. Nah, banyak hal yang memang nantinya ke depan kita akan bekerja sama dengan beliaunya, karena banyak sekali program-program yang memang kita mungkin bisa join ya di sana. Ini merupakan satu hal yang baik buat kita, karena unggulan kita saat ini memang mengarah ke diabetes. Mungkin itu sekali lagi Bu Eva, terima kasih banyak buat informasi yang sangat penting buat kami, karena kebetulan kami juga sentra unggulan pendidikannya mengarah ke PTM, jadi salah satunya memang diabetes. Jadi ke depan kami akan koordinasi dengan Bu Eva, mohon arahan dan juga informasi terkait dengan program yang terkait dengan penyakit diabetes. Mungkin itu kami atas nama penyelenggara konferensi internasional pada pagi hari ini mengucapkan banyak terima kasih, dan kami akan berikan sertifikat. Mungkin minta tolong panitia.
Yeah, please wait a second, ma'am.
Ya. Nah, terima kasih sekali lagi Bu Eva untuk bisa join dengan kami pada acara International Conference dan Workshop of Health Politeknik Kesehatan Malang pada pagi hari ini. Kami atas nama panitia mengucapkan banyak terima kasih. Mohon maaf apabila ada hal yang kurang berkenan. Wassalamualaikum warahmatullahi wabarakatuh. Selamat pagi.
Matur nuwun Bu Direktur, Bu Eva.
Saya kembalikan ke pembawa acara.
For our moderator, Ma'am Eko. And also thank you very much to keynote speaker with the excellent topic. Hopefully it can inspire all of you.
Okay. Okay, thank you. We have some information that our general director still have some schedule. So maybe before we proceed to our second keynote speaker, we will share you some posters that have been submitted to our conference. Please, the committee, may you share the posters? Okay, so before we see or watch the next posters, we would like to inform you, especially for our director and for all the participants, that this conference participants not only came from our internal participant, but also attended by students or by students from overseas university that have collaboration with our institution, Health Polytechnic of Malang. So maybe we want to welcome first, maybe slightly welcome for the students from St. Paul University. Good morning, maybe any of you, because I saw the name on the participant list. So because this is the international conference, so actually we really hope that our conference will be attended by all of the participants from maybe some countries that have collaboration with our institution. Okay, so because we still need more time to wait our general director, maybe because we know that she is maybe a little bit busy because she has some meeting with the ministry. So maybe we need sometimes to play the other posters that have been submitted to our conference today. So please, the committee, maybe you can share once more the video for the posters. Thank you.
Welcome to Malang State Polytechnic of Health, Polkesma. Polkesma is under the Ministry of Health of Indonesia. The main campus is located on Besar Ijen Street 77C, Malang. The campus, which was established in 2001, is one of the 38 health institutions owned by the Ministry of Health of Indonesia. Polkesma has a vision to become a civilized and globally competitive polytechnic of health. Polkesma has a number of missions carried out, including organizing a qualified education and learning to develop the potential and the personality of civilized and globally competitive students. Polkesma also working on developing the productivity of applied research and service for qualified and innovative communities. Besides that, developing good organizational governance based on information technology. And finally, Polkesma is developing cooperation and productivity both of domestic and international partnerships. Polkesma has 5,000 students that is divided into 4 majors and 20 programs study. The campus is a benchmark of health education in Indonesia, which leads of 7 campuses, which located in Malang, Jember, Lawang, Blitar, Kediri, Trenggalek, Ponorogo. At present, Polkesma offers study program, Diploma Program of Nutrition Study, Diploma Program of Nursing, Diploma Program of Midwifery, Diploma Program of Pharmaceutical and Food Analysis, Diploma Program of Medical Records and Health Information, Diploma Program of Health Insurance, Diploma Program of Blood Bank Technology, Undergraduate Program of Applied Nutrition and Dietetics, Undergraduate Program of Applied Nursing, Undergraduate Program of Applied Midwifery, Undergraduate Program of Health Promotion, Undergraduate Program of Applied Safety and Health, Undergraduate Program of Professional Education, Dietitian, Nursing, and Midwife. To support lectures, Polkesma provides educative facilities, starting with lecture rooms with modern learning media, integrated functional laboratories supported by advanced technology, digital-based integrated library or library, counseling unit, dormitory, mosque, gazebo, canteen, sport facilities, hotspot area, computer room, language laboratory, nursing laboratory, nutrition laboratory, midwifery laboratory, blood bank technology, medical record, and a secure parking. Supported by the implementation of a top vocational education with 60% of practicum activities and 40% of theory study, which will improve the student skill with practice in laboratories and other practical media. Polkesma continue to implement innovative, fun teaching methods with the concept of enjoying learning. On top of that, Polkesma implements an internet-based test for examination and e-learning and blended learning, which is applying classroom learning methods and utilizing e-learning. A qualified education is formed by instilling values that are presented through 220 teaching staff, qualified master and doctorals, who have been certified with various disciplines and examples in daily life. Polkesma also instills national character and ethics and excels in professionalism to withstand the global challenges. Besides academics, Polkesma also prepares students who are confident in their abilities by
Okay, thank you, dear all participants. Our General Director has been attend today, and please, Dr. Ekawati Renaningtyas, Founder. Please, Dr. Ekawati Renaningtyas, be the moderator for the second keynote speaker. Dr. Eko, the second.
Okay, thank you, Mrs. Hanandayu. And we say welcome, Dr. Gigi Arianti Anaya. Good morning. Thank you very much to attend our annual meeting. Selamat pagi, Bu Ade. Mohon maaf, masih di mute untuk speaker.
Yeah, morning.
Good morning. It has been grateful for us because our director from Head of Ministry can attend this event. So, Dr. Arianti Anaya, this is our annual event, and who has the participant is student and lecturer, and the student is not only come from Poltekkes Kemenkes Malang, but also come from other universities in abroad from Philippines. So we have time for you to give us speech about our theme today. Thank you, Dr. Arianti. So please welcome.
Yeah, thank you, Ibu Moderator. Assalamualaikum warahmatullahi wabarakatuh. Shalom, Shalom, Om Swastiastu, Namo Buddhaya. Greeting to all of us. The Honorable Director of Health Polytechnic Malang, guest speaker from Indonesia and overseas, committee, all the participants of this conference, and also all the ladies and gentlemen. Let us praise God Almighty for following us to together at the 6th International Conference and Workshop of Health. For that, I would like to welcome all of you. Hope that all of you are in a good health and the high spirit to participate in this event. First, I would like to deliver my appreciation also goes to the Health Polytechnic Malang for conducting this international event with the theme Post-Pandemic Challenge, Current Health Science Development Related to Diabetes Mellitus Management. And I think this is the important workshop. Yeah. This workshop is expected to be able to increase the knowledge of the skill of the participants so that the prevention and alleviation of the diabetic can be performed.
We sorry, Dr. Arianti Anaya, we can't hear your voice. Hello? We sorry that we can hear your voice, ma'am. Yeah. We sorry, Dr. Gigi Arianti Anaya, your voice is good. We can hear your voice right now.
You can hear my voice?
Yes.
Okay.
Yes, your voice is back. Thank you, ma'am.
Okay. I don't know whether which part that you cannot hear my voice. Okay, let me continue. As we know that diabetic is a major public health concern in our country, according to the International Federation, approximately there is a 19.5 million people with the diabetes, one of the highest absolute prevalence worldwide. And in this project, to increase the 28.5 million in 2045. That's why I told you before that we should give the special attention to prepare or to screening the diabetic incident since the beginning. While we would like to make a screening since in the primary healthcare in a puskesmas, so then early detection is more important to make to protect somebody to get the diabetic. And as we know that from the diabetic, the patient can get another disease like kidney failure, and then the stroke, and another thing. Diabetic was one of the top three direct cause of the death in Indonesia in 2017. It also become a high risk factor for the another disease, such as I mentioned before, such as stroke and cardiac arrest, and also the kidney failure. Furthermore, Indonesian Social Security Agency on Health has expanded about 7.5 trillion rupiah for diabetic for care services in 2022. This number has increased from 7.1 trillion rupiah in 2019. This is a significant amount of money that could be used for other purpose. One thing that we know, an unhealthy life style cause of the diabetic, by prioritizing the prevention and the management of diabetic, we can reduce the economic burden of diabetic, increase and we would like to increasing the productivity, as we know that we will have a bonus demography in 2030. I think that is an important thing to make sure that our people become productive in that year, and create the healthier and more prosperous society. Ladies and gentlemen, currently the Ministry of Health of Republic of Indonesia is carrying out the health system transformation, and implementation with the 6 pillar. First pillar is about the primary health care. Second is about the referral health care. Third is about the health resilience system. Fourth about the health finance. And also fifth about the human resources for health. And last is about the health technology. All the transformation will be important to get our goal, to increase our quality of the health community. Ladies and gentlemen, for implementation, the transformation, I think we should work together. especially the health workforce, have a crucial responsibility for building community resilience and acting as a catalyst for health transformation. Health services in all levels can be ensured by the availability of the adequate and equitability, the competent, and also the professional health workforce. Yeah, we cannot achieve the optimal services in the health services without any health workforce. It is essential to educate and manage the health workforce, yeah, in order to ensure that the quality standards are met and that they are professional. And also they must be improved their knowledge, especially for the existing disease that Indonesia now have, yeah, like a diabetic, stroke, and another thing. In additional, health workforce is essential in the primary healthcare transformation. As caused by the unhealthy lifestyle, diabetic can be prevented. Thus, the health workforce need to enhance health education to promote the community knowledge and skill for the living healthy. Disease screening should be also implemented in every age group in order improve patient health status. Yeah, that's why Indonesia now would like to make the bigger scope of the testing in the puskesmas, like glucotest. Then people can get the test for the glucotest in the not only the puskesmas but also in the posyandu. Ladies and gentlemen, the Ministry of Health has been working tirelessly to combat the diabetic in Indonesia. We have implemented a national policy and also strategy and action plan to prevent the diabetic and improve access of the quality of the healthcare services. However, there is still much work to be done. As we move forward, it is important that we continue to give a priority the prevention and also the management development of diabetic in Indonesia. This requires a multi-program and sectoral approach that involves not only the health sector, but also other sectors such as education, information, and communication. Yeah, that's why I told you that we must working together with all another stakeholder. Yeah, community empowerment is necessary to build the sustainable health program. By working together, we can create the healthier and more prosperous Indonesia. So then I think that is a good challenge for today, yeah, for this transformation. I hope that all the participants can actively participate in increasing public awareness regarding the diabetic, yeah, including prevention, yeah, and also as well as sharing knowledge, innovation, experience with all the stakeholders, so as to create collaboration and opportunity in the strengthen the management for diabetes. I also that professionals can provide insight, their experience and update according to their respective knowledge and authority to answer diabetic challenge in the global era, so that they are able to provide better health services, management, and to support health development in Indonesia. Once again, thank you for the Polytechnic Malang for this event. And finally, by saying Bismillahirrahmanirrahim, I declare the opening of the 6th International Conference and Workshop of the Health. Let us continue to deliver diabetic management improvement for a better health globally. Hope that everybody can get the fruitful discussion in this conference. Thank you. Wabillahi taufiq wal hidayat. Wassalamualaikum warahmatullahi wabarakatuh. Shalom, Om Santi, Santi, Santi Om.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much for a grateful speech from Dr. Gigi Arianti Anaya, our Director General of Health Personnel, Ministry of Health of the Republic of Indonesia. Thank you very much, ma'am. So maybe before Dr. Gigi Arianti Anaya won't leave in Zoom meeting, I invited to all of participants who want to have a little discussion, maybe ma'am, how to optimizing the roles and contribution from Poltekkes to supporting health transformation. So please, maybe if any participant want to have any question or get some discussion with Dr. Adi, you can open your mic or raise your hand before. From Dr. Wildan, maybe our director from Health Polytechnic of Malang. Or from others participant before Dr. Gigi Arianti Anaya short continues a lot of activity today. Maybe we have one or two question how to optimizing or how to develop our health transformation supporting in Poltekkes Kemenkes Malang. So I invited you all to have discussion with Dr. Arianti Anaya. Dr. Wildan, have you still with us? Is there any question or something to talk with Dr. Arianti Anaya or from others participants?
If there is no question, I think I should move to another activity.
Okay.
Ibu Moderator, ya. Okay.
Yes. Okay. Thank you very much, Dr. Arianti Anaya, and thank you for giving us a huge appreciation to conduct this annual meeting. We still really need your supporting to next agenda. So we say thank you very much. And for this session, I would like to say thank you for your coming to attend our annual meeting. So let me say, yes. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
So the next season, I would like to back to Master of Ceremony. Thank you.
Okay, please apologize because I have lost my signal just now. But before we start, actually, I would like to inform you that the attendance link will be shared later at the end of the conference today. So we also inform you that to get the apologize that to get the certificate, you have to join the full conference until tomorrow. Okay, so we're now continuing to our conference session. Maybe before we started, I would like to say hello first to Dr. Joel. Are you still here with us?
Yes, good morning.
Okay, good morning, Dr. Joel. We have Dr. Joel today for our first presenter or speaker for today. And before we start continuing to Dr. Joel presentation, I would like to remind all the participants that actually for each participant are highly expected to be present from the beginning until the end of the seminar tomorrow. And we also hope that every participant could turn on the camera and mute the mic during presentation. But maybe if you have some problem with your signal, maybe you can turn off your camera. It's okay. And then if you have any question for the presentation later, you may write your question in the comment section by mentioning your name, institution, and then you can write the question next, okay? And for this first presentation will be presented by Dr. Joel. And for the next MCN, maybe Mr. Andi Hayun Abidin will proceed to continue.
Okay, thank you, Ma'am Hanandayu.
Yes.
Okay, for the first session for this conference with Mr. Joel with this topic about managing increasing trend of type 2 diabetes mellitus in children in community level. Mr. Joel is a clinical instructor in college faculty member of nursing, Visayas State University, Philippines. Okay, this session will be led by Dr. Wiwin Martiningsih MCUP as the moderator. But before that, I would like to introduce her briefly. Ma'am Wiwin finished her bachelor and master degree at University Erlangga. She graduated from Doctor of Philosophy in Nursing Science at Saint Paul University, Philippines in 2019. And now she is a lecturer in Health Polytechnic of Malang. Her research focused in people with HIV, and she is very active in organizations such as Committee of Health City, and also Red Cross in Blitar City Association Prevention of HIV. Hello, Ma'am Wiwin, are you there?
Yes, Mr. Andi, I'm here.
Okay, welcome please. Time is yours.
Okay, thank you very much, Mr. Andi Hayun. Good morning, everybody here. Thank you very much, Dr. Wildan as director still stay here. Thank you, Dr. Wildan. And then gratitude to Allah Subhanahu wa Ta'ala, because today we can attend in this 6th conference and workshop at Poltekkes Kemenkes Malang through Zoom meeting. Thank you, Mr. Andi Hayun. We will begin the conference with the first speaker. I think the third speaker, Mr. Hayun. Yes.
Yes, ma'am.
Yes, the speaker. Yes.
The session of conference.
Yes. Our third speaker is Dr. Joel Roy Akub. Good morning, Dr. Joel. My friend.
Good morning.
Yes, Dr. Joel from Visayas State University. Yeah. Thank you, Dr. Joel, for your time, because yes, again and again, we invite you as a speaker. Thank you very much for your time. Yes, and now Dr. Joel will defer the topic about the advancing basic community care for diabetic children. Like that, Mr. Joel? Okay, yes. Before Dr. Joel deliver the material, maybe I will read the curriculum vitae. Yes. Yes, this is the curriculum vitae of Dr. Joel Rai Uksang Akop, doctoral nursing science. Yeah. The educational qualification is registered nurse 2010 and get Master of Art special in nursing medical surgical nursing 2011 and get doctor in nursing science 2019. The same with me, doctor. Yes. and then get postdoctoral fellowship in Erlangga University 2021. And he expertise and field of interest in caring science, elderly care, gerontology, nursing education, management, research, and health management. And the course taught and handled is nursing leadership and management with jurisprudence, nursing research and education, coordinated school health program, health ethic, and also quality management, medical surgical nursing, gerontology, fundamental of nursing, and therapy fundamental, nursing pharmacology. Next, yes. And the result involvement is hospital staff nurse 2010, clinical instructor 2011 until now, and destination is college dean July 2020 till August 2022, and also college secretary since 2019 till 2020. Other designated non-academic function as editor-in-chief to peer-reviewed nursing journals, reviewer to international journal, member of the technical working group in research function. And his publication is number of researchers reviewed for publication is 50. I think many, and number of publication in peer-reviewed journal 36, and citation already 136. And he get sorry, I cannot see. And he get H index 7 and I10 index is 4. Next. Okay. I already read the curriculum vitae of Dr. Joel. Dr. Joel, you have time 1 hour for deliver your material. And then we will open the question and answer for 30 minutes. Like this, Dr. Joel. Like this, Dr. Joel.
Okay. Thank you.
Now,
Can I start?
Yes. Okay.
Okay, thank you so much for the presentation of, the opportunity to share to you this morning. I hope you can see my screen. Is it in full?
Yes, we see.
Yeah. Is it in full screen now?
Yes, full screen.
Okay. I will not discuss more about diabetes mellitus because it's already a well-known knowledge, its effects, its causes, and what happens into our body when there is increase of glucose level. And one of the myths is if we keep on eating sugary foods or sweet foods, then that's the moment we only get the diabetes. But the fact is everything that we have taken in as a source of food, is considered also a possibility contributing to the increase of blood glucose. And so I will not be discussing that one here, but my role is to share with you the ABCs of community care for diabetic children. So ABC is advancing the basic community care. With the lot of literature telling us that we only need to give medication whenever the sugar or the glucose level increases. And with all these medications, there would be a corresponding side effects or complications that may happen or that may acquire by our patients. But what is unique in this presentation is we will have a closer look on treatment or management for the vulnerable population. And this refers to children. Aside from the elderly, aside from the mentally challenged, we also consider children as being part of the vulnerable population, and therefore the treatment may vary. Some of this may vary, or we need to tailor fit the intervention based on the needs of our population. And so the emphasis of my presentation this morning, we will talk about the challenges of caring for the vulnerable population, the children. What are the advantages that we are having right now in the market, and what needs still to be discovered in order to advance our care? We will also would like to appraise the resources that we have at the community level. When we talk about community management, we only are left with the promotive and preventive approaches, supportive approaches. The cure or the medication may not be part of our solution, as we are situated in a community where we are called to maximize the resources, whatever resources that we have. And so we will discuss that one. And how are we going to identify if we really succeeded in our treatment, in our combat to address this diabetes in children through evaluation. So this graph presentation, I obtained this in ResearchGate, and this is comparing the prediction of new cases of diabetes mellitus in children aging from 0 to 4, or as early as toddler years, or when they are attending their basic education, and even their junior years. So based on these statistics, it is very alarming that even in the early childhood years, there is already presence of this non-communicable disease. Considering that diabetes mellitus is non-communicable, this can be categorized either to sedentary, or yes, the lifestyle that we are having, or in rare cases, there are chances where it is hereditary by nature, but that's very isolated. It's very rare in nature. And so therefore, as I read with this research findings via this chart, one of the reasons why there is increasing cases of diabetes in children as early as in childhood years, it's because parents tend to give food as a form of reward. So the literature, I mean the findings have taught that when one is succeeding, when their children excel in school, they always give food as a source of reward, as a form of reward. Or if the children do not want to, example, receive vaccination because they're afraid of needles, like that. And so the parent may bargain, may say that if you will submit yourself to vaccination, if you will what do you call this, you go to the hospital and the doctor will get some checkup and you make good. No, you will not cry in the hospital or in the during checkup with the doctor. I will give you food. So all of these are, giving the chances of these children as early as their childhood years to experience diabetes, no? Because we always use food as a form of motivation. We always use food as a source of reward to them because um, we never anticipated the fact that children may also have the chance of being acquiring this diabetes. And so this graph in comparison, and this is changing, the statistics is changing, and I believe this is increasing now that as early as childhood years, they already acquire this lifestyle where increase of glucose in their bloodstreams are observed. And so these are the challenges in childcare with diabetes mellitus. And I presented this based on the years, the age, no? It varies, it differs. So some of the management issues or concern refers to the medication regimen. So we have difficulty in introducing eating patterns and lifestyle with our children. So we have to be more creative in the presentation of food because the knowledge is still correct. The knowledge is still at the moment. We always utilize food, exercise, and changing our lifestyle as the core preventive component of acquiring diabetes mellitus. And so when we introduce food not to our children or to younger population, we may have difficulty as one of the issues in the child care management. What about for testing, for example? So children, of course, they're afraid of needles. They're afraid of these nurses in white collar. Sometimes we call this a white collar syndrome. Whenever they see someone in white uniform or with white cap bringing with them medication tray, they always are afraid of these people because they feel that these people will give harm or would inflict pain. Okay, so these are some challenges that we are having now, and so we don't have the option if we will not prevent this at the community level. We will always bring them to hospital. We'll always send them for admission if the role of health providers are not maximized in the community setting. And that's really our goal as educator, as health advocate, to not extend the agony or pain of these children when they already acquire the diabetes itself. No? So as much as possible, we have to prevent that in our home or in our community setting. So these are some of the challenges that I would like to share with you. Another is the hypo and hyperglycemia as one of the management issues. Not all caregivers are knowledgeable of the things that they have to do, especially when the signs and symptoms are not very obvious, especially for working parents. The children are left at home with their nannies or with their care providers or the house helper, and the house helper or care provider is not knowledgeable about the common signs and symptoms when there is hypo or hyperglycemia. All these are challenge that we need to surpass in order to increase the survival rate of our younger population. And so, in the pandemic, or even in the post-pandemic era, there are a lot of concerns faced by the health providers. And two of the major concerns surrounds on the insufficiency of the patient and family education. And the other one is the accessibility of healthcare services. The first bullet is about family education. So in community setting, in the promotive and preventive management, the spirit, the core of our existence revolves on education. We always want to educate people about what is happening, about the effects of the increase of blood glucose level in the younger years or in the younger population. We have to educate them that the food is part of the basic need. The food is part of the physiologic requirement for survival, but it should not be utilized as a form of reward or a motivation for whatever success the children may acquire. We can utilize other form of reward because this food might be of need to our body, but this is also giving another problem, an example, which is diabetes mellitus. And we don't want that to happen, to experience by our children. So the knowledge, the correct knowledge, of course, the internet nowadays are giving luxury of information, but because we are part of this advanced world, but the role of educator is to give the right amount of information, the correct, the precise, the very exact information as much as we can in order to prevent this problem from happening or the exacerbation of this problem. So one of the issues right now is the education at the doorsteps of this family. So the insufficient education and the difficulty of accessing healthcare services. In the pandemic, we were isolated for quite like 2 years or more because of the fear of contacting the virus. But in terms of the delivery of services, the community we're not able to distribute properly, I should say, the resources because of the said prohibition to transfer or to visit or to perform community or house visits. And so that leads even to the increase of diabetes mellitus at the home setting. No? So we were taught to increase the level of our immunity because COVID is viral in nature. And so we even forget that whatever food that we have taken in may even contribute to the increase of our blood sugar. No, so there might be cases where there is available resources in your community, but it might not be accessible. Those are two different concepts. There might be access to healthcare services, but it's not available in your community. Your health center might be too far from the community people, giving them the difficulty of not availing the service. Okay, so the accessibility and the availability of the health resources of the community care services are also contributing factors for them not to address any other form of diseases. Example, your diabetes mellitus. So before pandemic, during pandemic, and even at this time, we are experiencing these concerns. We always know, this is a general knowledge, that diabetes is non-communicable disease by nature. It is true. No, diabetes mellitus is not communicable, yet the effect of this non-communicable disease is destructive and, to the extent, paralyzing both the human and financial resources. Why destructive? Because it overwhelmed the resources of our community. It overwhelmed the resources, the health resources and delivery of our health facilities. We know that there is a huge gap between the healthcare provider and the increasing population. Other health workers are moving out of the country, migrating for employment, and that even add to the issue of not able to equally distribute the resources right at the doorsteps of our community people. And so, diabetes, although not communicable, but it is tantamount to saying that if there is increase of the cases, especially for children, it is overwhelming the resources, both the human and financial resources of the government. And this now leads to the damaging effect of the healthcare system, making it communicable. Yeah, because we need to prioritize, we need to give more emphasis or importance on the immediate need of our people, and to so much effect, disregarding or not prioritizing or not even implementing other programs of the government because we already ran out of our resources. And if that happens, this will again overwhelm, and this would affect the delivery of our resources in the community. And worse, the SDG number 3, which is good health and well-being, will not be attained. So let us not wait. Although we know that diabetes is non-communicable, this is highly preventable. But if we are not able to fairly or justly distribute the resources to give priorities to our health issues or concerns in the community, then this would be another disaster into the human health. Into the human health. So what are the community-inspired initiatives? I said initiatives because the resources or the intervention of these diabetes is not only the responsibility of the government or the health sector. We must have a fair contribution, a fair play in participating to addressing the problem, especially on diabetes type 2. So what are those community-inspired initiatives? Number one, although I made mention about the post-pandemic concern of insufficiency of education and resources, we have to inculcate into our family at the community level the importance of health status identification. You know, it is a problem now in the Philippines, and I think it is speaking similar to other parts of the globe, that we failed to recognize the importance of early detection, of initial screening, of wellness checkup. We always submit ourselves to to check up when we feel feeling ill or feeling sick, or when we are not in our good shape, we think that we are having this disease. That's the moment for us to go and consult a doctor. But it should be the wellness checkup. It should be preventive. The approach should be preventive in nature. Okay, so the importance of health status identification, the early screening is of big help in order to cut the chain of increasing cases of diabetes mellitus in children. So the early screening, the treatment, if there need to be treated, but at least we undergone or we actually seek medical opinion or diagnosis to properly correct the problem, and we can prevent the over-the-counter medication or the self-medication thing, because that's another issue in healthcare now, the polypharmacy. No, sometimes we are treating by our own based on what we've read on the social media, what we've heard over the advertisement, or maybe our neighbor has more or less the same signs and symptoms that you have manifested as well. Then you just ask for the kind of medication, then you buy it yourself without proper screening, and that is not advised. So one of our initiative is emphasizing the role of early screening, the role of early treatment if there is, and in order to prevent the complication, we should empower them, to seek consultation at the community level. Another is establishing family support. I made mention about the reward system for children, which is based on that literature I have read. Parents are always giving, showing support and love through food. I cannot see problem in that, but the problem comes in when complication related to increase of glucose now takes into the circle. So there might be other means, there might be other ways to show support and love to our children. And so the family has to be knowledgeable. That's why in one of my presentation, I've said it must be education from the family, not just only to the patient or the children, but to the family or the immediate care provider of this younger population. So the care support, the healthy habits, the warmth and understanding. No, sometimes when the children is experiencing some bouts of anxiety and depression because they have not seen their parents for the longest time, they sort food as their comfort, as their means of comfort, as their source of comfort. So, and we fail to recognize that this obesity, this truncal obesity of the children, is brought about by our negligence and is brought about by less show of love and concern, and that they sorted out of this kind of stuff. So the family support, not only at the home setting, but also into the community or in the school setting, because the school is considered to be the second home of our children. So there must be presence of warmth and accommodation. There must be presence of our non-traumatic or accommodating environment, so they could express freely their thoughts. So that's another way of preventing the increasing number of our diabetes to children. Another is care outside of the home. I made mention about the school. I made mention about the community at large. And should they receive the same level of diabetes management in school? So the informal education happens at the family or home setting, and it has to be validated at the school as a formal avenue for learning. So the teacher's role is very crucial because whatever words that they've heard in that formal community, in that formal avenue, is a fact to them. It's very factual. They always believe what we say. Therefore, the challenge is we have to be very sensitive and careful to whatever teachings that we share. Similar with our community people, when nurses or health advocates or health workers are giving teaching to the community, they always believe that, they always perceive that to be true and correct because we are people of authority. And so the showance of care outside of their home is or has to be observed meticulously. They should always be medically safe. They should be medically safe at school, have the same access to educational opportunities as their peers, and not be excluded from their extracurricular events or field trip. Meaning, the role of the school, no, the community or the role of the school as a safe space for these children is also made into consideration. In what way? Example, in our canteen, we have to be very picky or choosy as to the kind of food that we are offering to them. Yes, I said they have the money, they have the resources, but what if we are not putting much value on their money because we sell foods that may not be of help to them or that may lead into the increased chances of acquiring the disease. So the role of the school as a second home is not only to educate, it's not only for knowledge enrichment, but it even cascaded down into their attitude in the rightful food choices. Okay, so we have to offer them the food that instead of giving them harm would yield much benefit on our children. Their peer can also be a factor of their wrong food choices. And so it is the role of the school to ensure that the environment is as safe as possible. The issues of bullying, the issues of infliction, harm and inflict can be unnoticeable avenue for them to sort out to, wrong food choices. And so if they notice that they are being bullied because of their body structure, I said I made mention about truncal obesity, then that might be a traumatic experience for them. So that should be eliminated at the school setting. The care should have immediate access to their supplies and be able to obtain a blood glucose reading and should be able to respond to the results as quickly and conveniently as possible. So it is not just the role of the school, as I've said, to provide education, but even to coordinate. No, we call it coordinated school health programs that should the children already manifested these signs and symptoms, then we have to refer that to the school clinics or to our school physician or even to the parents of these children so we can address the problem and patch up the problem the earliest time possible. So these are some of the examples that we show or we express our care even outside our home setting. As you can see in this puzzle, the patient, the children, is at the core of our endeavor, and we coordinate this to other stakeholders, interested individuals that may contribute to the advancement of the basic care for children with diabetes mellitus. So the family takes part of that pie. The science research, the role of the academe is to increasing and producing knowledge on the different techniques and modalities in the care for children with this kind of concerns. The role of technology, I heard of digitalization, the use of technology for early detection and assessment. That's very welcoming environment, I mean, welcoming opportunity for us to advance the care. The system of care refers to our referral mechanism. We don't just go refer this to higher facility, but we make sure that we maximize all our means in order to address the problem at our level. If that is impossible, then that's the time for us to refer. And the role of the healthcare worker is to identify the chain or the system to properly coordinate this concern. Advocacy, healthcare team, and the social determinants. The social determinants here refers to the outcome. No, the outcome is always the quality of life. It's always attainment of the SDG number 3. So if we failed short of this social determinant, then there must be something wrong somewhere, and that's the role of revisiting or reframing the structure that we have. If the intervention seemed not effective, then there must be something wrong in the planning phase. In order to acquire this quality of life, the attainment of SDG number 3 as one of the social determinants, then it is our call to always review and revisit our policies. We make some guidelines to support the existing policies, and those are social determinants. I think this is the last presentation that I have. I obtained this from the National Institute of Health. This is true to all. It's not only for children. We call this health track. Tracking, meaning we have to take the medications as prescribed by the doctor, as prescribed, as per prescribed, not as per heard, not as per bought over the counter, not as per self-medication. It is as prescribed by our medical doctor, suggestive that we have to undergo the assessment and the diagnosis properly before we get into the medication. Another is reaching and maintaining healthy body weight. The role of the advocate is to ensure that the BMI of our children is still on the right track based on their weight and height, that the healthy weight is maintained all throughout, that the giving of food is basically dependent into the kind of work or activities that they have engaged. A is to additional or to add more physical activity to your daily routine. We have to change the landscape of education, and now it's more on the outcomes-based education. Gone are the days of the paper and pen. Therefore, we have to maximize their energy, not just to, to loosen their weight, not just to sweat, but also for education to be more engaging and interactive. The OBE, the role of the outcomes-based education, is to always see things into the end result as basis for our basis of our judgment whether the student really grasped the objective or the course intention. So we have to put in more engaging activity, more physical activity for them to learn in a more interactive manner. Education should be fun, but let us also consider the safety component when we introduce this physical routine or this physical activity. Another is control of the ABCs, meaning your HbA1c, your blood pressure, and the cholesterol level, and is to kick the smoking habit. I am not certain if children 10 years below are engaged into smoking. Maybe to some teenagers they are into smoking. No, these are bad habits, but the role of the older population is guidance by example. When we say guidance by example, if we preach that smoking is not good, then we should do what we are preaching. We should become a model based on the behavior that is in alignment with what we teach them. No, there are also statistics telling that the effects of smoke or smoking is much higher, way higher to secondhand smoker or secondhand smoke. And if there are parents or older adults inside that home facility and are smoking, it may even affect more indirectly to this younger population. So this might be some of the contents that we need to introduce into our teaching when we do teaching to the community level. And I think that that's the end of my presentation about the topic. Good morning.
Good morning. Thank you very much, Dr. Joel. Yes. Now we will move to open the question and answer session. In the chat room, I think there is no question. Maybe the participant will want to ask something. The participant can raise your hand or maybe type in the room chat. Ma'am Ramning, maybe you want to ask something? Always Ma'am Ramning.
Thank you, Miss Vivin. Hello, Mr. Joel. How are you?
Yeah, I'm fine. Thank you also.
Yeah. I asked about the diabetes type 1, especially for children. Diabetes in children is certainly not easy to manage, especially diabetic with insulin therapy. How to manage so that blood sugar remain under control. And the second, I think the role of parent is very important. What is the role of the family, especially parents, in treating children with diabetes with insulin therapy? Thank you.
Okay, so I believe that when we say insulin therapy, it's type 1 already, and there might be problem in the pancreas or uncontrolled in increasing of blood glucose. So I think aside from the meticulous or religiously following the treatment regimen, we have to inform them that it's not an excuse of just always taking in food, because that's our contention. We keep on taking a lot of food because we are confident we have the insulin helping us to to deliver this glucose into the cellular level. Same like with hypertension, we eat a lot of fatty foods because anyway we have hypertensive medication, but there must be discipline, and the discipline is not being prescribed. This is not prescribed, but this is taught. This must be embedded into the system of not only the children, but their immediate family members. So the insulin is there. It is non-negotiable. We really have to follow that because it's part of the treatment process. But something that we can help them to expedite, if not to make lesser possibility of complication, is the imposition of discipline to our family. No, there is no for me, there is no specific diet for them. They can eat in moderation, and that's discipline. They can engage in any activity with safety, and it's discipline as a requirement. The role of parent is also critical because most 24/7 they are with their parents. They can only be seen at school setting maybe 5 or 7 hours, or nurses in the community maybe 2 or 3 hours, but most of their lives, most of their days are consumed within their family members. And so the parent has to be consistent, with the discipline or the imposition of the food that they're taking in. What else? The parent has also to be educated because, as I've said, when they show care and love, it's not through food. It is something that is beyond that, which is not which will not give more harm to their children. No, that's that research I've read, I shared earlier. They utilize food as the source of reward, the source of motivation, and it's not good. Okay, so we have to look into other possibilities of how we can show support and care and love and motivation, but not food. So education for parent is also important. Education to children, meaning describing to them the effect if they are consistently exposed to this kind of food habits, is showing them concern and explaining them to their level of understanding. Meaning, if that is a grader student, we have to explain what is diabetes at their own level of understanding. We should not be in assumption that every time we speak to our client, they easily understand what we are talking. There are medical jargons, there are terms that they don't even know, and we just presume that they understood that well. So the education should be tailored fit, should be very specific, should be in alignment to their level of understanding. And even to the parents, not all parents are open to these kind of, issues. Yeah.
Okay, thank you.
Okay, Dr.
Thank
Hani.
you.
There is another question. Maybe I will ask something, Dr. Joel. Yes. Maybe you can share, Dr. Joel, about the program in your country or maybe your place. You have 3 treatment for diabetes mellitus, like the early screening treatment and also prevent complication. Maybe there is program about the early screening because we have, but for adult. Maybe in your place there is the program for children. Yes, we have the peer group, like peer group for diabetes mellitus, but for adult. Yeah, hypertension also. But for the children is, I think, rarely. Yes. Thank you.
Yeah. I think I have not heard, personally speaking, I have not heard of the peer group or a community support or a program for early screening for diabetes for children. For adult, we have also a support system for adults, but for children, I think uh, we do not have that one. And this becomes our challenge at the moment because the statistic is telling us that diabetes is not only for adults, but now it is already starting at the very young age for children. I said challenge because we do not have the direct access to these children because they are still under the custody of their parents. And so, if we want really to have this addressed, very early, then the population of choice should be the parents and not the children. So the education for the parents, the the right amount of knowledge to management at home or at the community level should be directed to the parents so that this will be properly being cascaded or being implemented into the home setting for their children. I think that's how I see the address the issues and concern for children having diabetes. We have to like utilize the parents, the older adults, the immediate family member with immediate care for that children as our participants to care for children with diabetes mellitus. But right now, I have not heard of any community-based care support or core support team which advocating DM for children. So I think we can have that as a future project uh, to really address this issue, this non-communicable disease.
Yes, I think we need maybe in the next collaboration research, we can take the title about the diabetic children, I think, because the need of the diabetic children, I think the same with the adult also. So we have to make the group, peer group like this. But maybe the parent and the children will go to some place, and then there is the education from health worker like this. The same with adult diabetics, thing like this.
I think
Maybe
yeah, if I may add, I think in my mind now, I have the assumption that if the parents are diabetic, more or less their children who are consuming the same kind of food at the family may also have some manifestations of increase in blood glucose. I'm not saying that these are diabetic, but they are risk. They are prone to having this diabetes early in their childhood because they share the same plate, they share the same food. And so I think that can be our if we go on research or identifying our population, the gateway would be whoever those with diabetic parents can be the possibility, or that can be a good hypothesis that we can go deep down and checking their children if who among them have these common manifestations of diabetes. Good if no diabetes at that, because our role is more on the prevention for diabetes to happen.
yes, Mr. Joe. There is Ma'am Maria Dia, I know that we have the special for diabetes mellitus. Ma'am Maria, there is in this Zoom meeting. Maybe still busy, Mr. Joel.
Yeah, okay.
Yes. Hopefully for the next research, Mr. Joel, maybe the first time we will exploration phase, yeah, exploration phase for the diabetic children, maybe from the parents. Yes, from the parent, and we will know how about the children like this. Yes. If there is no question, maybe I will close this session. Mr. Andy Hayon, how about the time?
Yes, ma'am. Okay, I think time is up, ma'am.
Yes, your voice is not clear.
Okay, I think time is up for the first session of this conference.
Okay, thank you very much for sharing, Dr. Joel. Hopefully for the next research, we can explore about this problem. Okay, we will back to Mr. Andy Hayon. Thank you very much.
Thank you so much, Ma'am Wiwin, for leading this discussion in the first session of this conference. And also thank you so much, Dr. Joel, have give for the valuable insight about in type 2 diabetes in children. And also we would like to share our certificate of appreciation for you. Yes. This is a certificate of appreciation for Dr. Joel. Okay, once again, thank you so much, Dr. Joel. We hope in the next opportunity we can see you again. Okay, thank you.
Thank you, Joel.
Thank you.
Thank you, Dr. Joel, for sharing.
Sama-sama.
Maybe for the next session.
Thank you, Dr. Hanandayu.
Yes, Dr. Ruben, thank you so much.
Okay, for the next, maybe Ma'am Hanandayu will be held will be host this event.
Okay, thank you, Mr. Andy. And of course, our beloved participant, the next topic that will be presented by Dr. Chenalin Lakman Taguyam. I apologize maybe for the mispronunciation. She is the lecturer from St. Paul University, Philippines, and the topic will be roles and management pregnancy with metabolic disease. Dr. Takiam, are you here with us?
Good morning.
Okay, good morning, doctor. And this session will be led by Mrs. Eka Wulandari, Magister of Education, as the moderator. And Mrs. Eka Wulandari is a lecturer from Nursing Department of Health Polytechnic of Malang, and her interest is English for Health. Mrs. Eka, good morning.
Good morning.
Okay, we can hear you now. Okay, so for this session, Mrs. Eka, you have full control for this presentation. The time is yours.
Okay, thank you very much. Good morning, Miss Jenalyn. How are you today?
I am very fine, ma'am.
Thanks, God. Okay, maybe before you begin the presentation, let me read your CV, for a little while. I can see that you are really, really capable in this kind of matter, If we see from the educational background, Mr. Jenalyn is a registered nurse starting from 1994, and then also a registered midwife in 1995. And she got the Master of Science in Nursing in 1997 from St. Paul University, Philippines, and Bachelor of Science in Nursing from St. Paul University, Philippines also. As for the employment history, she already become a lecturer in the School of Nursing and Allied Health Sciences from SPUP from 2023 until now. And then the lecturer in Niswa Sultanate of Oman from 2011 to 2023 as the lecturer and clinical instructor of College of Nursing in SPUP also. And as the reviewer for licensure examination for obstetrics for nursing and midwifery students in the Philippines from 2003 to 2011 as the lecturer and clinical instructor, the College of Nursing Medical Colleges of Northern Philippines, and also as the volunteer for nursing, and the People Emergency Hospital in Tuguegarao City, Cagayan, Philippines. So I can see that you are really an expert in nursing program. And because of that, you are also handling the position for administrative position in School of Nursing in SPUP, and then also in University of Niswa, Sultanate of Oman, and also as a QA officer, clinical coordinator for nursing, program coordinator for nursing college in SPUP. And for more responsibilities, I think there are so many of you. How can you manage your time, ma'am? Okay, you become the committee chairmanship, in the School of Nursing and also the College of Pharmacy and Nursing. And then if we talk more about responsibilities, you become the member of CPN board, CPN curriculum committee, assessment committee, and then also student appraisal committee, academic advising, assessment, revision, and nursing professional examination, and also the academic advisor. And for the research, you are also involving in graduation project supervisor, School of Nursing, University of Niswa. And as the awards and citation, we can say that you have some citation and award also here in academic and education excellence in University of Niswa, Sultanate of Oman. And for the skills and professional traits, we can say that you are having the leadership, communication, problem solving, critical thinking, commitment, initiative, and flexibility. So I can say that the skill that you have is not only on nursing and midwifery, but also in education, ma'am. So I believe you are really having the capability for sharing what you are going to share today. Okay, so for the following hour, maybe it's about 30 to 45 minutes. We will give you the time to share your material, and then after that, we are going to follow with some question and answer. Okay, ma'am, the stage is yours.
So good morning, everyone, and thank you, ma'am, for that warm introduction. If I may share?
Yes.
So is my material visible to everyone?
Yes, it's already visible.
So at the outset, in behalf of St. Paul University Philippines and my Dean Ann Tolosi, we would like to thank Polytechnic Health Malang and especially Ma'am Rizky for inviting me to this conference. So today I am tasked to discuss our roles as nurses in the management of gestational diabetes. So let me start by outlining my talk's objectives. This presentation is aimed to discuss the impact of pandemic on the prevalence of GDM, discuss maternal and fetal effects of GDM, outline the standards of care for GDM, and summarize strategies and challenges for GDM to improve outcomes. Let me first anchor my presentation to the Sustainable Development Goals, or the SDGs. These are global goals that were adopted by the United Nations in 2015, and as a universal call to ensure that by 2030, all people globally have better health, we live in prosperity, and there is a peace in the world. There are about 17 SDGs that all countries committed to, and these SDGs are integrated, so an action in one will affect the outcome in the other areas. Let me highlight goal number 3, because that's where my talk is aligned, okay, which is good health and well-being. Under this, there are 13 target goals. And in relation to gestational diabetes, we as nurses can contribute to the achievement of 3 target goals, which are: by 2030, reduce the global maternal mortality ratio to less than 70 per 100,000 live births; by 2030, end preventable deaths of newborn and children under 5 years of age, with all countries to at least as low as 12 per 1,000 live births, and under 5 mortality to at least as low as 25 per 1,000 live births. In the next slides, I will be emphasizing how GDM increases maternal, fetal, and perinatal risk. This complication contributes to the causes of maternal and neonatal mortality, I should say. The third one, by 2030, ensure universal access to sexual and reproductive healthcare services, including for family planning, information and education, and the integration of reproductive health into national strategies and programs. I will also emphasize in this presentation our roles as nurses in ensuring that our clients will have access to reproductive health care services. For starters, let me discuss the statistics of GDM so we can have a picture of its prevalence. Wang and her team in 2022 published the results of a meta-analysis of 27 studies estimating the prevalence of GDM. The results showed that globally, the pooled standardized prevalence of GDM is 14%. The results also showed that 3 regions have lower prevalence than that of the global rate. And these are your North America and Caribbean, Europe, and South Central America. While Africa and Western Pacific have comparable prevalence with that globally. It is worth note-taking that our nations, okay, that belong to Southeast Asia belong to the top regions where GDM is prevalent, second to the Middle East and North Africa, having higher prevalence than that of globally. This result showed us that GDM is truly a health concern for nurses and midwives. In the recent years, we were challenged by COVID-19, and its impact on the global health, economy, and lifestyle has been devastating. In relation to GDM, the pandemic negatively impacted its prevalence. Let me share some research findings. In a study in Italy published in 2022, the results showed that COVID-19 pandemic negatively impacted GDM prevalence. Comparing that of during the pre-pandemic in 2019, the rate was 9%, and during the pandemic in 2020, the rate was 13.5%. Another study in Canada Gestational diabetes rates were higher during the first wave, about 13.2%, and second wave, which is 14.3%, than those during the pre-pandemic period, which is only 12.4%. The risk of gestational diabetes increased in both wave 1 and wave 2 compared with that of the pre-pandemic period. However, most of the increase in gestational diabetes rates was driven by low-risk women without COVID infections who were socioeconomically advantaged and had no comorbidity and were ages 25 to 34 years old. In Australia, data from 3 hospitals for 2 years during the pre-COVID period was compared to the data during the first year of COVID with limited pandemic mitigation restrictions and the second year of COVID with stringent restrictions. Okay? GDM increased across exposures, accounting for 21.2% during the pre-pandemic, 22.9% during the first year with limited restrictions, and accounting for 24.8% with stricter restrictions. So let us revise first on our fundamental knowledge of what diabetes is. So gestational diabetes is defined as any degree of glucose intolerance with the onset or the first recognition during pregnancy. Using the International Association of Diabetes and Pregnancy Study Group criteria, an OGTT of 75 grams of glucose is given to the mother at 24 to 28 weeks AOG. Diagnosis of gestational diabetes is made if one of these values are met. The values are fasting glucose of equal to or more than 92 milligrams per deciliter, a 1-hour postprandial glucose of equal to or more than 180 milligram per deciliter, and a 2-hour postprandial glucose of equal to or more than 153 milligram per deciliter. Likewise, gestational diabetes is classified into 2. We have what we call your A1 GDM, which is the diet-controlled GDM. This is a GDM that is managed without medication and is responsive to nutritional therapy. While A2 GDM is the GDM that is managed with medication to achieve adequate glycemic controls. We all know that GDM both impacts the maternal or the mother and the baby as well. So under maternal effects, research showed that the higher the fasting glucose levels are, the higher the chances of developing preeclampsia. Preeclampsia is more frequent among women with diabetes versus the non-diabetic population. The risk of preeclampsia also increases with maternal age, increased BMI, and the duration of pre-existing diabetes. Now, GDM with preeclampsia increases risk for intrauterine growth restrictions, abruptio placenta, and maternal stroke. Next, GDM is highly associated with fetal macrosomia, thus the need for cesarean section. About 25% of A2 GDM requires cesarean section, while 17% of diet-controlled GDM undergo cesarean section. This comparing to only 9.5% mothers who undergo cesarean section without GDM. Now, a mother who has been diagnosed with GDM will carry a lifetime risk of progression of type 2 diabetes up to 60%. Looking at the fetal and perinatal risk or effects, in all women with pre-existing diabetes, there is a 9 to 14% rate of miscarriage. Current data suggests a strong association between the degree of glycemic control before pregnancy and the miscarriage rate. Next is your birth defects. In women with overt diabetes and suboptimal glycemic control before conception, the likelihood of structural anomaly is increased 4 to 16%, as compared to the general population who have only 1 to 2% risk. 2/3 of the birth anomalies involve cardiovascular and the central nervous system. The third one is growth restriction. Although most fetuses of diabetic mothers exhibit growth acceleration, growth restriction occurs with significant frequency in pregnancies in women with pre-existing type 1 diabetes. The most important predictor in fetal growth restriction is the underlying maternal vascular disease. Fourth is obesity. Approximately 30% of fetuses with diabetes mellitus in pregnancy are large for their gestational age. In pre-existing diabetes, the incidence appears to be slightly higher. Now, a baby whose mother has GDM, its excessive body fat stores stimulated by excessive glucose delivery during diabetic pregnancy often extends to childhood and adult life. So it's well documented that children of mothers who have GDM and are born macrosomic can also have obesity later in life. Macrosomia occurs in 14 to 45% of babies born to diabetic women. And lastly, metabolic syndrome. The adverse downstream effects of abnormal maternal metabolism on the offspring have been well documented well into puberty. Glucose intolerance and higher serum insulin levels are more frequent in children of diabetic mothers than in normal controls. By age 10 to 16 years old, offspring of diabetic mothers have 19% rate of impaired glucose intolerance. Now, how do we care for mothers who have diabetes mellitus? Now, the American Diabetes Association, I should say, yearly publishes standards of care for diabetes, including GDM. Their guidelines is summarized in the following infographics published by ADA in cooperation with the Women's Health Initiatives. One standard is on screening guidelines. So what is their guidelines in terms of screening? Screening must be done at 24 to 28 weeks in women without pre-existing diabetes, while earlier screening about before 15 weeks should be done to women with risk factors so that we can rule out any pre-existing diabetes or type 2 diabetes. At postpartum, mothers should also be screened at 4 to 12 weeks postpartally. Because of the lifelong risks of diabetes mellitus, mothers with history of GDM should be screened every 1 to 3 years. The next guideline is on treatment. Treatment of GDM begins with medical nutrition therapy and physical activities. Study shows that this should be enough to achieve glycemic controls. However, in cases where medication will be needed, insulin is always recommended as the first-line agent. Next in the standards of care is the blood glucose monitoring. Blood glucose must be monitored on regular intervals, whether it is fasting, 1 hour, or 2 hours after meals. It should be checked regularly before meals, at bedtimes, or when a mother has symptoms of low or high glucose levels. The guidelines also emphasize that the blood glycemic targets of fasting glucose should be less than 95 milligram per deciliter. For 1 hour after meal, it should be 140 milligram per deciliter. And for 2 hours after meal, it should be less than 120 milligram per deciliter. However, mothers who are taking vitamin C should be cautioned when monitoring blood glucose level, as vitamin C and maltose can cause positive interference in resulting in misdiagnosis of true glucose level. Lastly, the standard of care also endorses a key strategy in managing GDM, which is ensuring health equity. Addressing the social determinants of health is the primary approach in achieving health equity. This will be further discussed in my next slides as I discuss the nursing challenges. So, what would be our personal care in patients who have GDM? I have summarized this in 4 components. When do we care for our patient? So we care for our patient during the preconceptual period, during the prenatal period, and during the postpartum period. How do we care for this patient? We can care for these patients in clinics, during home visits, and now we have what you call your telehealth, okay? With whom? When we care for patients, we have to emphasize interprofessional collaboration. Collaborative practice happens when multiple health workers from different professional backgrounds work together with patients, families, and communities to deliver the highest quality of care across settings. And lastly, what are we going to care for? Okay, what would be the emphasis of our nursing care? It would be screening and monitoring blood glucose level, lifestyle behavior modification, and your medication. So let me discuss this one by one. So let's start with your preconceptual care, okay? We highlight in preconceptual care, we highlight preconceptual counseling, starting at puberty, continuing it in all with diabetes and reproductive potentials. Health assessments and screening must be done to determine any health risk for GDM and potential comorbidities. It is also important to highlight, it is very important to highlight the importance of achieving and maintaining a near euglycemia as safely as possible before conception and throughout pregnancy. We will also emphasize during the preconceptual counseling, family planning. We should discuss family planning and the use of family planning until blood glucose level are optimized for pregnancies to avoid both maternal and fetal risk on the mother. During the prenatal periods, we highlight glycemic targets in pregnancy to achieve metabolic control. Better sugar levels, okay, decreases complications. Lifestyle behavior change is also highlighted. It is an essential component of the management of GDM. And as I've said earlier, it may suffice as a treatment for many individuals. We usually start this with medical nutrition therapy, physical activity, and weight management. While in the postpartum period, we usually do postpartum follow-up, such as screening for blood glucose, lactation. So breastfeeding, it has been found in a lot of studies that breastfeeding confer a long-term metabolic benefits for both the mother and the baby. Breastfeeding decreases the risk for developing type 2 diabetes. And lastly, your contraception. Planning pregnancies until euglycemics are achieved prevents congenital malformations and decreases the risk of complications in mother. It is also highlighted that the risk of unplanned pregnancy outweighs the risk of the currently available contraception options that we have in the market right now. So where to conduct our nursing care? So we do it in clinic visits, okay? We inform the mother of the schedule of visits. Usually literature will say from first month to the 7 months that they have to come to the clinics every month, from the 8th month to the 9th month that they will come every 2 weeks, and on the 10th month that they will come every week, or depending on the condition of the mother. What we usually do in clinics are your initial and follow-up assessments in order to monitor maternal and fetal health. Home visits can also be done for follow-up care. Home visits allow the health worker to assess the home and the family situation in order to provide the necessary nursing care and health-related activities. Family-centered care is one of the approaches of maternity nursing, as pregnancy does not only affect the mother, but the family as a whole. Right now, we have your telehealth. Okay, we are now in the age of the internet. We are now in the age of technology. Okay, the use of technology to conduct nursing and delivery care in remote areas. It can come in all settings. We can use video conferencing, messaging. Okay, we now have software applications, like in the Philippines, we now use serving as an application to deliver care over a long distance. There is an extensive evidence that telehealth visits for pregnant people with gestational diabetes improve outcomes, similarly as the standard in-person care. So this is one thing that we should look into, your telehealth nursing. Okay. With whom? So, interprofessional collaboration. This is the trend right now. We no longer care for the client individually, but rather collaboratively, so that the client can receive the best possible health care. Different healthcare professions, such as your physicians, family physicians, nurses, diabetes educators, dietitians, pharmacists, should work closely together to manage diabetes care, provide services, and refer to community programs when necessary. The use of interprofessional collaboration augments the patient's experience and more efficient resource utilization, leading to cost savings and improved resource allocations. So what are we going to highlight when we are caring for our patient? Okay. As I've mentioned earlier, screening and monitoring. Okay. We said earlier, screening should be done 24 to 28 weeks for women without history of diabetes, while screening before 15 weeks should be done for mothers who are having the risk factors to rule out pre-existing diabetes or diabetes type 2. Postprandial glucose monitoring is associated with better glycemic outcomes, and it lowers risk for preeclampsia. While pre-prandial testing is also recommended when insulin is used, so that pre-meal rapid-acting dosage can be adjusted. The A1C test, okay, which is a simple blood test that measures our average blood sugar over the past years. It may be useful, but it is only used as a secondary measure for glycemic outcomes during pregnancy. Due to the physiological increase in RBC turnover, A1C levels fall during normal pregnancy, and it does not fully capture postprandial hyperglycemia, which drives fetal macrosomia. The next that we should emphasize is lifestyle modification. Okay? In here, we're going to discuss about medical nutrition therapy, physical activity, and weight management. Medical nutrition therapy for GDM is an individualized nutrition plan. This should be developed between the patient and referring the patient to a nutritionist and dietitian. The food plan should provide adequate caloric intake to promote fetal and neonatal as well as maternal health, achieve glycemic goals, and promote weight gain. The current recommended amount of carbohydrates is about 175 grams, or about 35% of a 2,000 calorie diet. Focus should be on high fiber complex carbohydrates, which is also known as your slow carbohydrates or slow release carbohydrates, I should say. It keeps blood sugar levels even because they are digested more slowly, thus preventing the body from producing too much insulin. It also provides lasting energy and help us stay full, so therefore decreasing the need for us to eat again. We also take into consideration the glycemic index of our carbohydrate sources. We always emphasize that it should be the low glycemic index or the low, that's correct, the low glycemic index. The nutrition plan should emphasize monounsaturated as well as polyunsaturated fats, which we call the good fats, while limiting saturated fats and avoiding our trans fats. So fast foods, this should all be avoided. Then we have your physical activity. We all know that exercise lowers blood glucose levels by increasing the uptake of glucose by body muscles and improving insulin utilization. It also improves circulation and muscle tone, as well as increases your lean muscle mass. A systemic review demonstrated improvements in glucose control and reduction in the need to start insulin, or even the decrease in insulin dose requirements with an exercise intervention. We always say a lot of our gadgets right now are provided with pedometers that can track the number of steps that we have every day. Everyone has cellular phones, right, or mobile applications, so we can easily instruct mothers about this. Both diet and physical activity aids in achieving ideal body mass index. Obesity has been found to be the largest environmental influence on the prevalence of diabetes in a population. Then we have your medications, the use of medications in GDM. Insulin is the first-line agent recommended for the treatment of GDM. Treatment of GDM with lifestyle and insulin has been demonstrated to improve perinatal outcomes. Metformin, our oral hypoglycemics like metformin and glyburide, should not be used as a first-line agent because it was found out that they cross the placenta going to the fetus. Your sulfonylureas are known to cross the placenta and have been associated with increased neonatal hypoglycemia. A recent meta-analysis concluded that metformin exposure resulted in smaller neonates with acceleration of postnatal growth resulting in higher BMI in childhood. However, there are some people with GDM requiring medical therapy who may not be able to use insulin safely or effectively during pregnancy, maybe due to cost, language barriers, comprehension, or cultural influences. This is the time that oral agents may be used as an alternative for these individuals. However, we need to discuss to them the known risk and the need for long-term safety data in offspring. Also, due to potential for growth restrictions or acidosis, in the setting of placental insufficiency, metformin should not be used in pregnant people with hypertension or preeclampsia or those at risk for intrauterine growth restrictions. Now, pregnant individuals with type 1 or type 2 diabetes should be prescribed with a low-dose aspirin starting 12 to 16 weeks because it lowers the risk of preeclampsia. The use of hypertensives. During pregnancy, treatment with ACE inhibitors, your ARBs, and your spironolactons are contraindicated as they may cause fetal damage. Okay? So the antihypertensives that is known to be effective includes your methyl dopa, labetalol, and your long-acting nifedipine. Diuretics are not also recommended to control blood pressure in pregnancy, but may be used during the later stage if needed for blood volume control. So, what are the nursing challenges in improving health outcomes for GDM? Now, as one of the standards a while back mentioned that we need to address health equity, let me align my discussion on the challenges of nursing in a publication entitled The Future of Nursing, 2020 to 2030, Charting a Path to Achieve Health Equity. Health equity is the state in which everyone has a fair and just opportunity to attain their highest level of health. To achieve health equity, the focus of care is now shifting from treatment of the disease to the mitigation of the social determinants of health. Social determinants of health are the non-medical factors that influence health outcomes. They are the conditions in which people are born, grow, work, live, and age, and a wider set of forces and systems shaping their conditions of daily life. The publication's outlines our roles in achieving health equity. These are also aligned in our roles in improving health outcomes in the overall care of patients with gestational diabetes. Our roles include increasing nurses' accessibility, lifting barriers to expand the contribution of nursing, strengthening nursing education, valuing community nursing, fostering nurses' roles as leaders and advocates, and preparing nurses to respond to healthcare emergencies and disasters. So let me go through one by one. So increasing nurses' accessibility. Nurses at all levels are present in a wide range of settings outside the traditional healthcare facilities. As nurses, we work directly in communities to provide care in workplaces and school. So therefore, there is a need for allocation of more nurses in healthcare facilities. More nurses in primary level as frontliners are needed in the promotion of health equity. Increasing nurses' accessibility to work with the public makes healthcare services more accessible. Lifting barriers to the contribution of nursing. Nurses can improve health equity by providing care management as well as team-based care. There are a lot of nurse initiatives in the care of GDM clients. Studies have shown that nurse-led, web-based health management is effective in improving outcomes and may play an important role and show the feasible clinical value in changing the current healthcare models. We need to expand also the capacity of primary care and advanced nursing practice, especially in maternal and pediatric care, in telehealth, as well as in school, home, work, and public health settings. The ability to fulfill these potentials is usually limited by the state-level regulation restricting nurse practitioners' scope of practice. Therefore, policies, standards, and guidelines of each country for advancing nursing practice must be formulated and lobbied to policymakers to give nurses the legal authority for more expanded roles and autonomous capabilities. Strengthening the nursing education. So in the undergraduate, we must be able to provide student nurses with substantive, diverse, and sustained community-based experience. This will prepare our nurses to identify and act on the complex social, economic, and environmental factors that influence health and well-being. Nursing is increasingly practiced in community settings such as school, workplaces, as well as through home healthcare, I should say, and public health settings. That's the reason why we should not only prepare nursing for them to work in hospitals, but they should also receive the same level of training and preparation for community and telehealth nursing. Then the incorporation of internationalization activities. Internationalization involves teaching and learning activities involved in international cultures in order to enhance global learning. Then, for graduate programs, we must have advanced nursing practice programs, okay? Advanced practice, okay, is a level of practice in which a practitioner has demonstrated their abilities to work autonomously at a high level. The pillars of such would be clinical practice, leadership, management, education, and research. So therefore, there is a need to formulate curriculum as well as policies, standards, and guidelines for advanced nurse practitioners in every country. The Western countries are already having this, programs. Valuing community nursing. School and public nurses play a vital role in adopting health equity. They are frontline healthcare providers. They focus on prevention of illness, injury, or disability, the promotion of health, and the maintenance of health of the population. The public health nurse also performs leadership, management, and supervision roles within the health unit to implement health programs and to engage in community organizing activities. School nurses serve as a bridge between the healthcare and the education systems and other sectors. Then we have fostering nurses' role as leaders and advocates. New generation of nurse leaders are now needed. We need to use and build on increasing evidence practice. This highlights the need for nurses to be more engaged and to lead in the formulation and implementation of more initiatives and protocols in the care of GDM clients. Nurses are called on to lead in the development of effective strategies in improving the nation's health, okay? Our contribution as nurses is needed in implementing change to address the social determinants of health and advance health equity. Rather than hierarchical system of leadership, a collaborative leadership assumes that everyone involved has a unique contribution to make to achieve the ongoing goals. And lastly, preparing nurses to respond to healthcare emergencies and disasters. The increasing frequency of public health emergencies, natural and environmental disasters such as the COVID-19 in the recent years, reveals in a stark detail the critical importance of having a national working workforce prepared with the knowledge, skills, and abilities to respond to these events. Articulation of the roles and responsibilities of nurses in disaster response and public health emergency management will be critical to the nation's capacity to plan for and respond to this type of events. That's all. Thank you. And if you have any questions.
Okay, thank you very much, Miss Channeline. I think that's a very interesting topic, yeah, and it's really in line with what we are facing today because there are so many problems related to that, and we can see that nurses, yeah, really have a very big role in handling this situation, in especially in community.
Yes, we do.
Okay, we still have some, maybe about 10 to 15 minutes left. If you have any question, you can raise your hand or maybe just write down in the chat box if it is possible. Okay, audience, time is yours now to ask the questions. You should make the most from it, yeah, because we have the expert here. I can see that you are also explaining about telehealth, yeah, ma'am. Do you think it is quite, what is it, effective for today's situation, ma'am?
Yes, ma'am. Actually, there is a study that's saying that telehealth is as effective as a standardized inpatient visits. Okay, especially with the effect of the COVID, ma'am, where people are afraid to go to hospitals. Okay, then we have to find ways of how we can reach to these people, and that is the use of the technology. There are a lot of applications right now, like as I've mentioned, in the Philippines, we have what we call now serving, that it's an application where we can connect with the doctors. It is still with the doctors, but this is a challenge for nurses, that we can come up with applications, or we can be members of a network of healthcare professionals that can communicate or can contact patients for follow-ups, for health education through the use of the internet. The only challenge here is reaching the far-flung areas where internet
Yes.
connections are a problem. Okay, so therefore we have to lobby to our government, we have to lobby to private entities, the NGOs, so that there will be health equity.
Yes, because Indonesia also having that problem, I think. There are so many remote areas that cannot be connected with internet. Okay, ladies and gentlemen, any questions, audience? Seems that your explanation is already very clear, ma'am.
I hope so, ma'am. I hope I gave justice to the task that was given to me.
Yes, that's really good. And I think that's really interesting because, yeah, we need to learn from each other, yeah, if we are talking about this problem. Okay, audience, any questions? Let me see the chat box. Maybe there are some questions in the chat box. Yeah. Okay, ma'am, there is one question.
Yes, ma'am.
In the chat. Okay, from Mr. Arif Polkesma. Okay, thank you, Mr. Arif. Mr. Arif is our head of study program, nursing study program, ma'am, in Malang. In terms of strengthening nursing education, I'd like to ask you about nurse specialists. Does your country, does the Philippines have nurses specialists? And if so, how to get that? Okay, thank you.
Right now, ma'am, our Association of Deans of the Colleges of Nursing in the Philippines are on the formulation of the policy standards and guidelines for advanced nurse practice. And of course, this needs to be lobbied to our politicians, so that the scope of nursing, which is a law in the Philippines, we have the Nursing Act of 2002 that describes our scope of practice, can also be changed into a new law. So the process of lobbying, the process of formulation and lobbying to our Congress is on the way now. And
Okay,
in
so
that way, we as academic institutions can also start, through the help of the Association of Deans in the Philippines, are also trying to formulate the prototype for the curriculum of advanced nurse practice.
Okay, so still on the go, yeah. Okay, Pak Arif is also one of the graduates from SPUP, ma'am. Maybe you know him. Pak Arif, can you show your face?
Yes, yes, ma'am.
Good afternoon.
Magandang umaga, ma'am.
Magandang umaga din po. I am a new old faculty of St. Paul right now. I just arrived again in September, ma'am. And so therefore, for a decade, I was out of the country. And I just came back. I know we had a lot of graduates from Indonesia.
Yes,
we
ma'am.
are so happy.
I graduated on 2020, ma'am.
Yes. Nice meeting you, sir.
Nice to meet you too.
Okay. So thank you, Pak Arif. Is it clear already? The answer
Yes,
from
ma'am. It's very
the
clear.
channel? Okay, very good. Yeah. We have the second question, ma'am, from Ibu Ika Yudianti. Ibu Ika is from midwifery. She was to SPUP. She was going to SPUP the last 2 weeks, visiting you maybe.
Yes, ma'am.
Yeah.
Yes, Ma'am Ika and Ma'am Rizky came to the
Hi, ma'am Gina.
Hi, Ma'am
Glad to
Ika.
see you. Do you have an example of best practice in the management of GDM on pregnant women who didn't come to health facility center? Thank you.
Okay. So that's one of what I mentioned a while back, Mom. There is a research that web-based health management for women who cannot go to the healthcare facilities shows an effectiveness of or prior how do I call this positive outcomes. So a lot of researchers right now, Mom, are telling about that one of the best practice is the emphasis on the use of telehealth. Did I answer your question, Ma'am Ika?
Okay, Ma'am Ika? Bu Ika?
Okay, thank you, Ma'am Jena, Ma'am Eka.
Ma'am Ika, nice.
Okay.
I
Hi,
need to
with
Hi,
you already.
yes.
Ma'am Ika want to go there again, ma'am. She said
Come
like
back,
that.
Ma'am. Come back.
Someday maybe. Thank you, thank you.
Okay, thank you. Any other? No? Okay. Okay, you can continue the chat. Yeah, there are so many chats already. Okay, I think we have 2 questions. There is an answer from Dr. Talosik. Yeah, some hospital have a teleconsult. In the Philippines, you have teleconsult already. But I think we have to be really careful, yeah, ma'am, if we are talking about telehealth. Is it like that, do you think?
What do you mean by we should be careful?
Maybe there are some fake account or fake website.
Yes, of course, our how do we go? We have also to be vigilant in utilizing this applications. However, there are, as I mentioned a while back, we in the Philippines we have what you call your now serving. It is an application that we can register to, and it shows there only the doctors that the doctors are there, their credentials are there, their clinics hours are also there. So especially in a particular region or like here in Tuguegarao, so the list of doctors are there, so it can be easily look upon whether these are bogus accounts or not, because Tuguegarao is only a small place. So usually the teleconsult, we usually do it within, they will ask you where are you from, and they will give you a list of doctors that they can help in your problems.
Okay. Precautions, yeah, is really needed. Okay. I think let me see the chat box. Okay, I think we don't have any more questions, and it's already 12 p.m. in Indonesia. So time is already enough, I think, ma'am. Maybe you have some closing statement for your presentation?
So I hope that you have I have given justice to the task that you have given me, and I look forward, especially when Mom Ika and Mom Rizky were here in the Philippines, we're looking forward for a collaboration in terms of maternity, okay, with Mom Ika. Okay.
We still discussing on that, Ma'am Jena.
Yes, ma'am.
Yes, we all hope that this collaboration will go on and on forever and ever. maybe everlasting. Yeah. Okay. Thank you very much, Ma'am Jenna, for all your presentation today. I hope they will be really useful for all of us. Thank you very much. And I would like to apologize if there are some shortcomings from my leading the presentation today.
No problem.
Okay. Thank you. Back to back to the MC, please.
Okay, thank you so much to Mrs. Eka and Dr. Takiam for the presentation. And to show our highest appreciation to our speaker today, we will give the appreciation certificate to Dr. Takiam. And please allow us to capture this for the documentation. Give me a second. Okay, Sven, thank you so much for the attendance, Dr. Takiam. And yes, and we would like, or we will send the copy of the certificate to your email after this event ended. And okay, because this time is already on 12 past 5. Right now we will have some breaks. Okay, so before the next session with Mr. Ramli, and please join us at 12:45 at 12:45 p.m. in West Indonesian time, because we are hoping that we can start our next session on time with the next presenter or the next speaker. Okay, and please still stay online in this room, and please join us again on the time that we already shared. And we also would like to remind you that the that the attendance link will be shared later at the end of the conference in the first day. And we also like to remind you again that if you want, or if you were willing to get the certificate, you have to fill the attendance link for the full conference in 2 days. Okay. Okay, I think that's all for me as the MC for today and for this first session in the morning, and we will start again the afternoon session after 12:45. Thank you. Have a good break. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Selamat siang, Assalamualaikum. Suara saya masuk.
Selamat siang, masuk, Bapak. Mohon berkenan untuk menunggu sebentar lagi ya, Bapak.
Suaranya udah masuk.
Iya, suaranya sudah masuk, Pak
Bagus.
Ramli.
Oke, ya
Ye.
udah ngetes saya dulu.
Iya, baik. Insya Allah nanti kita akan mulai jam.
Background bebas kan?
Oh, silahkan Bapak.
Ya. Oh, ini
Ye.
kami yang hadir ya.
Iya, alhamdulillah Bapak.
Saya uber-uberan habis selesai.
Oh iya,
Balik.
ada kegiatan.
Iya. Baik, saya tunggu ya.
Iya Bapak, setelah ini kami informasikan kalau sudah akan dimulai lagi.
Iya, Pak Dewo juga sudah masuk, Bu Bidi.
Oh iya, selamat datang Pak Dewo. Terima kasih sudah hadir.
Iya, lagi sudah masuk kan kangen juga itu ya.
Iya Pak, betul. Ditunggu sebentar ya Pak Dewo.
Yip, siap.
Siap.
Itu tadi ada link absensi nggak, Mbak tadi?
Ada Bapak. Kami sampaikan tadi akan kami bagikan di akhir, nanti menjelang konferensi
Ya.
selesai.
Oke, oke. Makasih.
Baik, ya terima kasih.
Oke.
Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, everyone. Welcome back with us in State Health Polytechnic of Malang in the 6th International Conference and Workshop of Health under the title Post-Pandemic Challenges, Current Health Science Development Related to Diabetes Mellitus Management. For the next topic in this conference, the first day in this conference, with the topic is hierarchy of control to manage risk in workplace in post-pandemic era. This topic will be delivered by Mr. Swetman Ramli, DIPL SM SKM MBA. Hello, good afternoon, Mr. Swetman.
Good afternoon, selamat siang.
Okay, thank you. As you know, this session will be led by Ma'am Rizky Mustika Riswari, SST MPH. I would like to introduce her first. Okay, Ma'am Rizky Mustika Riswari finished his bachelor degree at nursing and graduate from master degree public health. Now she is a lecturer in Health Polytechnic of Malang. She focused on occupational and health safety. Hello, Ma'am Rizky. Are you there?
Hello, thank you, Mr. Andi Hayun
Okay,
Abidin,
thank
for
you. Please,
introduce
time is
myself.
yours, Ma'am Tika.
Yes. Thank you very much. And welcome back, all of participants, for this event. Here we now at the third speaker, I think, for today. And selamat siang, Pak Suharman Ramli. Assalamualaikum
Selamat siang,
warahmatullahi
Bu Tika, apa
wabarakatuh.
kabar? Assalamualaikum.
Salam sehat, Bapak. Senang sekali bertemu
Alhamdulillah.
kembali dengan Pak Suharman yang buku-buku karya tulis beliau ini menemani kami belajar di bidang K3. So, of the participant, Mr. Suhatman Ramli is one of legend who's mastering in occupational health and safety. So, before we start to hear what he's speak today, let me read his CV. So, I would like to share screen. Yes, thank you, Mrs. Ola. Yes, Mr. Sohatman Ramli, Diplom SM, SKM, MBA as a chairman of World Safety Organization, WSO Indonesia. Educational background, Bachelor of Chemical Engineering, ATN Semarang. Muhammadiyah University, Chemical Engineering Palembang. Occupational and Health Safety Public Health, Indonesia University, MBA, IMBI Yogyakarta. Organization as an investigator, team member KNKT at 2014, chairman of tim teknis penyusunan kompetensi ahli K3 nasional at 2014, independent team leader of pengendalian keselamatan migas start from 2017 till 2018, as a representative WSO, World Safety Organization National Office Indonesia, start from 2014 till present. Member of DK3N, Dewan K3 Nasional Depnaker, start from 2020. Employment history, Asahimas Plat Glass Jakarta, Pertamina Kilang Pelaju, Pertamina Kilang Cilacap, Pertamina Pemasaran Dalam Negeri, Pertamina PDN, Dinas Pengkajian dan Pengembangan, Pertamina Marketing and Trading, DuPont, lecturer at Indonesia University, and also at Sahid Jakarta University and Binawan University. K3 Education as a Safety Inspector Course Pertamina, Oil Spill and Pollution Singapore, EHS Training British Petroleum UK, Environmental MGT Oxford University, Diploma Safety Management British Safety Council UK, getting from Loss Control Management ILCI Atlanta USA, and also as Safety Audit ISRS ILCI Atlanta, USA, Oil Spill Control at Texas A&M University, HS Advanced Mobile Oil USA, and so many ergonomic, lead auditor ISO, auditor SMK 3 BNSP, ahli utama K3 BNSP. And also he is very grateful getting award from Karya Patra Utama, President Director of Pertamina, Satya Lencana Wirakarya, President of the Republic of Indonesia, and also James K. William Award, WSO. So there's the CV for our speaker today in this afternoon. And Bapak Suhatman Ramli berkenan untuk memberikan pemaparan materi untuk kurang lebih 1 jam ke depan, Bapak, untuk menyampaikan topik terkait dengan hierarchy of control to manage risk in workplace in post-pandemic era. Jadi di masa-masa pasca pandemi, Bapak, di mana banyak perubahan kondisi di workplace, banyak terjadi perbedaan di workforce, bagaimana K3 memandang itu sebagai salah satu upaya pengendalian penyakit akibat kerja yang barangkali salah satunya fokus ada di populasi pekerja. Jadi disilahkan Pak Suhatman Ramli untuk dapat menyampaikan materinya.
Terima kasih Mbak Tika, already introduce myself. Selamat siang Bapak warahmatullahi wabarakatuh. Salam sejahtera bagi kita bersama. Ya, nantinya kita panjatkan puji syukur kehadirat Allah Subhanahu wa taala atas nikmat rahmatnya kita bisa bertemu dalam kesempatan ini. Mungkin saya share aja sendiri Pak ya, slide-nya. Ya,
Siap, baik Bapak.
Ya, biar
Yes,
mudah
please.
keluar ruahnya.
Oke.
Ini saya juga dapat permintaan dari rekan-rekan saya, tentunya persiapannya juga singkat juga, jadi saya akan coba share ini mengenai ini. Masih ada gangguan. Maaf. Sudah kelihatan Mbak? Sudah ya?
Ya, sudah Bapak.
Oke, lanjut aja. Oke, thank you very much. Ini bahasa Inggris bagaimana? Benar aja. Bisa bahasa Indonesia aja?
Bisa bahasa Indonesia saja Bapak.
Yeah, because I don't get information from Mbak Tika. Terima kasih Bapak Ibu sekalian atas kehormatan yang diberikan pada saya untuk ikut mengisi di dalam webinar ini. Walaupun cukup dadakan ya, dimintanya topiknya sangat menarik juga. Jadi saya agak ini bagaimana membahas topik ini karena ini kan bicara era pandemi dan kemudian setelahnya pandemi ini bagaimana kita menghadapinya kan gitu ya mintaannya. Oke. Jadi kalau kita lihat di masa pandemi ini kan cukup dampaknya luar biasa ya yang baru saja kita lewatin. Kita melewatinya kalau dari data-data aja hampir 15 juta kematian seluruh dunia. Ini luar biasa ya pandemi ini. Alhamdulillah dilewatkanlah oleh Allah ya. Ini tapi dampaknya memang kita rasakan cukup besar lah bagi dunia kita. Dan tadi sudah disampaikan oleh moderator juga, maka tentu kita belajar dari situasi ini. Apa yang akan kita hadapi, apa permasalahannya, apa pembelajaran yang kita dapatkan dari kejadian ini. Maka banyak sekali para ahli-ahli yang membahas mengenai ini. Nah, salah satu saya ambil di buku ini ada namanya yang menulis dari industri Megaship, boleh di mana di download itu, jadi sangat bagus pembahasannya. Nah, dia melihat bagaimana dampak pandemi ini dari berbagai aspek. Jadi dia lihat dari sisi mikro, dari sisi makro, kemudian dari sisi mega juga dia lihat apa dampak dari pandemi ini pada waktu itu. Ini sangat penting kita lihat sebagai lesson learned bagi kita ke depan, bagaimana kita menyimaki kejadian-kejadian ini ya supaya tidak terulang kembali. Jadi kita melihat dari 3 aspek, yaitu yang pertama dilihat dari sisi mikronya, ya, kemudian kita lihat dari sisi makronya, kemudian kita lihat juga dari sisi meganya. Dari sisi mega kita sudah merasakan sekarang ya bagaimana dampak COVID ini yang memaksa kita harus bisa menerapkan era digitalisasi, ya, dan nasionalisme dan sebagainya, ya. Dari segi mikro juga timbullah apa yang dikatakan empati sosial, gaya hidup baru, dengan tadi dikatakan kita sekarang belajar di rumah, ya kayak sekarang yang saya lakukan. Zaman dulu kita mungkin tidak terbayangkan ya seperti ini ya, bahwa dengan ini kita bisa berbicara dengan teman-teman di Malang ini, yang mahasiswa di Malang, ya. Nah, kemudian mungkin juga dari sisi makro juga kita rasakan dampaknya ya, dampaknya kepada perusahaan kita. Nah, orang makin senang dengan apa yang dinamakan izin itu semakin dibutuhkan. Nah, di sinilah perannya ketiga ya, peran ketiga. Orang jadi sadar sekarang pentingnya menjaga kesehatan, menjaga kebersihan, dan sebagainya. Dan bagaimana mobilitas manusia itu bisa meningkat dengan cepat, kemudian adanya interaksi sosial melalui IT ini kan interaksi kita jadi cepat, bicara dengan ibu di kampung, saudara yang jauh di Amerika, kita gampang dengan mudah. Nah, kita lihat saja lah sekarang apa yang terjadi di Palestina itu, kita semua di seluruh dunia tahu, kita bisa mengamati semua kejadian apapun. Nah, inilah salah satu manfaat yang kita rasakan dari kejadian pandemi ini, membuat manusia itu berubah gaya hidup, berubah pola pikir, dan berubah dengan teknologinya juga sangat berubah. Nah, kita melihat dari sisi ketiga nanti, ya. Nah, kemudian dalam bidang ketiga itu kita juga mengenal apa yang saya katakan tuntutan-tuntutan global dari manusia ke depan. Jadi ini sudah lama ya yang kita katakan global trend in safety. Itu ada, saya nulis buku ya mengenai global trend itu. Jadi bersamaan juga dengan eranya pandemi ini terasa juga bahwa memang dunia kita ini semakin sempit. Bahwa dunia kita ini sudah semakin arah menghadapi kelakuan manusia. Kalau saya katakan kelakuan manusia ya, yang buang sampah sembarangan, yang membuang emisi, itu membuat dampak terhadap dunia. Makanya kesepakatan masyarakat dunia yang melalui United Nations ini ada yang dikenal dengan ISG itu ya, atau environmental, sosial, dan government. Tapi itu yang menjadi tuntutan manusia sekarang ini adalah yang dikatakan kita menyebutnya adalah to sustainable development goal. Jadi tuntutan yang dikembangkan oleh kesepakatan negara-negara yang ada di serikat di PBB, bahwa kita harus menjaga dunia kita ini. Nah, salah satu aspeknya itu adalah aspek keselamatan yang ada di S-nya itu, dikatanya S sosial itu. Di sosial itu bicara mengenai keselamatan, workforce, health, and safety, diversity, and training. Jadi, you can see from the ESG program is including all aspects, safety, environmental, sosial, and so on. Ini kalau Anda baca di buku saya, buku Global Trend and Safety itu, saya sudah nulis lama sekali, sudah 20 tahun yang lalu sudah ditulis bahwa manusia itu menuntut tuntutan-tuntutan manusia. ya manusia yang hidup di muka bumi ini. Karena bumi kita ini katanya kan kecil, tidak bisa diperbesar dan sebagainya ya. Kita tidak punya bumi lain, only one earth katanya gitu ya. Nah, tuntutan masyarakat global itu misalnya shift air to breathe. Nah, ini yang kita rasakan sekarang. Banyak teman-teman kita yang kesulitan bernapas di berbagai negara karena polusi, kena pencemaran, emisi udara ya. Nah, itu mengakibatkan kita tidak aman lagi bernafas, safe air to breathe. Tuntutan kedua, safe water to drink, air yang aman untuk diminum. Jangan kita buang air mencemari laut. Sekarang terkenal ya pencemaran laut ya, limbah-limbah ke laut dan sebagainya. Safe food to eat, makanan yang aman untuk dikonsumsi, ya kita tidak tercemar oleh pestisida. Safe place to live. Nah, ini yang sekarang jadi isu besar di manusia ini. Menuntut tempat yang aman untuk bermukim, bebas dari berbagai bahaya dan bencana. Kemudian safe product to use, bagaimana kita menjamin bahwa semua produk yang kita pakai, yang kita gunakan, yang kita makan, yang kita aman untuk kita. Ada yang terakhir ketiga, safe and healthful workplace. Itulah yang jadi tuntutan global. Maka kita kenal dengan istilah ESG itu kan, environmental. Ini sekarang sudah jadi isu semua, terutama setelah pandemi selesai. Maka manusia ingat lagi kembali ke tuntutan ini. Maka ini sekarang lagi tren di seluruh dunia ya. Ya, oke. Nah, inilah yang kita lihat ya. Environmental itu kita bicara clean air, kita bicara affordable and clean energy, industri, innovation, infrastruktur, sustainable, ya, dan kemudian responsible consumption of production, climate. Nah, ini climate sekarang lagi tren nih, climate change ya. Nah, kemudian life below water dan life. Jadi intinya saya nyampaikan bahwa dengan selesainya pandemi ini kita menghadapi suatu tuntutan yang lebih besar. Bagaimana menjaga bumi kita ini supaya tetap sustain. Nah, bagaimana kita melihatnya dari aspek ketiga? Kita di K3 kita sudah punya pedoman yaitu Undang-Undang Nomor 1 Tahun 70. Dalam undang-undang itu di ayat 3 itu sudah ditekankan yang dinamakan syarat-syarat keselamatan kerja. Ini sudah 50 tahun yang lalu, tahun 70 ini sudah ditayangkan. Dalam 70 itu kita sudah menginginkan suatu tempat kerja yang sehat, yang nyaman bagi kita semuanya. Tuh lihat di poin nomor 7 itu. Mencegah dan mengendalikan timbul atau menyebar luasnya suhu, kelembaban, debu, kotoran, asap, uap, gas, hembusan angin, cuaca, sinar radiasi, suara, dan getaran. Nah, ini kan semuanya itu namakan keselamatan lingkungan kerja. Ini tidak diperhatikan oleh para ahli K3 bahwa tugas kita sebagai ahli K3 mencegah ini, mencegah dan mengendalikan. Kalau ini sudah tercapai, tentu tidak ada lagi pencemaran, tidak lagi ada emisi keluar, ya. Itu dari sisi K3. Nah, ini yang dari K3 tugas jawab kita sebagai ahli K3 ini ya, semuanya. Ada 18 persyaratan kalau menurut Undang-Undang Nomor 1 tadi. Nah, dari sinilah saya akan mencoba membahas lebih dalam apa peran kita dalam menghadapi setelah pandemi ini, setelah bagaimana strategi risk management kita, gitu ya. Itu yang akan saya coba bahas. Nah, di sini saya pertama mengajak teman-teman dulu. Kita tuh posisi kita di mana? Sekarang sedang ribut di masalah emisi. Banyak perusahaan ditutup karena mengeluarkan emisi. Kemarin ya udara Jakarta semua kotor katanya ya. Semuanya banyak perusahaan batubara yang membuang emisi ke udara. Nah, di mana kita? Jadi kita sebagai ahli K3 itu ada di sini. Kita sebagai ahli K3 bertanggung jawab menjaga keselamatan tempat kerja kita ini. Tempat kerja kita agar tidak mengeluarkan emisi-emisi seperti ini tadi. Nah, oke. Nah, inilah tugas seorang ahli K3. Nah, di sini sudah ada regulasinya Permen nomor 5 2019 tentang K3 lingkungan kerja. Kan sudah ada ya. Nah, jadi kita sebagai ahli K3 juga bertanggung jawab bagaimana mengendalikan emisi ini, aspek lingkungan kerja ya supaya tidak terjadi semuanya, baik faktor fisik, kimia, biologi, ergonomi, dan sebagainya lingkungan kerja ini supaya tidak berdampak ke lingkungan. Nah, kalau sudah kita bicara lingkungan, ini namanya lingkungan hidup. Nah, ini ada di KLA kan. Nah, lingkungan hidup itu menerima dampak dari industri ini. Industri ini yang menimbulkan dampak, mengakibatkan ini kepada lingkungan. Nah, ini yang akan kita perankan sebagai ahli K3, yang akan kita bahas. Nah, bagaimana tuntutan masyarakat ke depan? Jadi dalam kita lihat ke depan itu kita menerapkan continual improvement. Jadi K3 itu sudah berkembang sejak tahun 1930. Nanti teman-teman mahasiswa coba lihat histori K3, secara K3 itu sudah mulai dari tahun 1930 ini ada K3 sampai sekarang ini terjadi terus ya perubahan di dalam K3 ini. Kita lihat ya, mulai dari era tahun 80 dinamakan era sistem manajemen. Nah, keluarlah di sana berbagai model sistem manajemen dari ISRS, dari mana-mana ya. Tapi itu juga tidak cukup, berkembang lagi pada tahun 90. Nah, memang kesisteman. Maka timbullah berbagai ISO, OSAS, dan sebagainya. Nah, sekarang kita ada di mana? Tahun 2000 dan tahun 2000 ini ternyata kita sekarang berubah kepada membangun culture budaya. Nah, ini nah kenapa? Ini saya kaitkan dengan efek pandemi tadi. Dimulai dari era pandemi itu terlihat rupanya ini sangat penting sekali. Ini juga kalau kita lihat perkembangannya, perkembangan K3 itu ya, K3 itu berkembang menurut ini ya, menurut CCPS ini, kalau zaman-zaman dulu kita berorientasi kepada standar strategi, jadi dulu kita yang penting standarnya mengatakan ini, bising ada standarnya, ini ada standarnya, tangki ada standarnya, semua ada standarnya. Nah, itu dulu fase dulu berbasis standar. What should we do? Tapi itu sudah berubah. Mulai tahun 70 dulu kita mengacu ke compliant based strategi. Dibuatlah regulasinya. Yang tadi standar itu sifatnya voluntary, bersifat mandatory. What do I have to do? Itu kan. Nah, tapi itu tidak cukup. Bahkan tahun 80-an berkembanglah sistem manajemen disebut continual improvement based strategy. Tapi itu tidak cukup, masih juga terjadi kecelakaan-kecelakaan. Nah, ahli-ahli lari ke yang terakhir sekarang ini risk strategi and culture. Nah, ini yang akan saya bicarakan dalam kita menghadapi pandemi ini. Bahwa kita ada pada fase sekarang kita berbicara risk based ini, risk based strategi. Kan sesuai dengan omnibus law ya kan juga menggunakan pendekatan tuh bisnis berbasis risiko ya itu yang kita kejar ke depan. Oke, kita masuk sekarang ke risk manajemennya. Nah, di dalam berbicara risk management ini kita harus melihat tantangan kita ke depan, tantangan kita di new era ini. Apa yang kita lihat? Di mana kita sekarang? Potret kita ada di mana? Kita akan menuju revolusi 4.0, malah katanya sekarang 5.0, itu ya ke sana. Nah, apa nih yang sangat terkait yang harus kita manage di sini? Jadi kalau kita lihat di sini interaksi K3 ini yang paling intinya itu adalah yang di tengah itu apa? Tempat kerja. Kalau tidak ada tempat kerja, nggak ada K3. Nah, tempat kerja itulah yang pertama berdiri. Misalnya saya niat mau bikin pabrik, ya saya bikin pabriknya. Saya berniat mau bangun apa, saya dirikan di situ. Nah, yang pertama adalah tempat kerja. Tempat kerja. Nah, di tempat kerja itu ada pekerja yang bekerja di situ. Nah, masuk ke sini. Ada pekerja yang bekerja di sini ya. Pekerja, ini manusia ada di sini. Nah, di sini ada yang namakan ahli K3 yang mengelola ini. Ya, saya tuh melihat hubungannya di mana. Kita sebagai ahli K3, praktisi K3, lulusan strategi kesehatan malah akan berada di sini yang menjaga ini, menjaga tempat kerja dan pekerjaan ini aman. Tugas tanggung jawab kita nih sebagai ahli K3, menjaga tempat kerja dan pekerjaannya aman, tidak menjadi kecelakaan. Nah, inilah perannya. Ahli K3 itu adalah sebagai payung pelindung, aper. Nah, ini dia bahaya itu bisa dari berbagai versi. bisa juga dari luar yang kita namakan adalah lingkungan kerja. Ada 3 ya, 4 ya, tempat kerja, ada pekerjanya, kemudian ada lingkungan kerjanya. Oke, ini yang penting. Nah, bagaimana kita melihatnya? Kita sudah tahu dalam teori-teori bahwa terjadinya kecelakaan itu adalah disebabkan oleh unsafe act dan unsafe condition katanya ya dari teorinya Franberg tadi. Jadi teori zaman dulu tadi kan saya katakan kan, nah, kita melihat upaya unsafe act dan unsafe condition sudah berkembang oleh Hendrik sejak tahun 30. Itu yang kita lihat ya. Nah, kemudian ini yang akan kita lakukan sekarang. Bagaimana kita melihatnya ini fenomenanya ini. Jadi teman-teman tuh jangan hanya menyebut K3 unsafe act, unsafe condition, tapi bagaimana skenario-nya ini yang kita penting. Jadi kalau kita bicara unsafe act dan unsafe condition sebagai konsep holistik, kita akan melihat ke sini bahwa kecelakaan itu terjadi adalah bila mana seseorang itu melakukan unsafe act praktis atau adalah kondisi yang tidak aman. Ini yang memicu terjadinya kecelakaan. Jadi ada 2 sisi. Ke kiri ini unsafe condition, ke kanan adalah unsafe act. Kalau kita bicara unsafe condition, kita bicara tempat kerja, teknikal, maka ilmunya adalah ilmu safety engineering. Kita bicara keteknikan ini, kita bicara tempat kerjanya, kita bicara ergonominya, kita bicara desainnya, kita bicara man machine system, kita bicara lingkungannya, kita ini tempat kerja. Kalau ke kanan ini kita bicara unsafe practice, kita bicara pekerjaannya. Ini pekerjaannya yang dominan di sini. Kalau pekerjaannya kita akan bicara cara kerjanya bagaimana, human error-nya bagaimana, kompetensi manusianya, perilakunya bagaimana. Jadi inilah kita melihat K3 itu secara holistik. Nah, ini nanti kita kaitkan dengan terjadinya kecelakaan. Ya. Jadi di dalam K3 itu kita mengenal yang namakan pilar K3. Jadi teman-teman tolong diperhatikan ini sangat penting ya, yang namakan pilar K3 itu. Apa yang namakan pilar K3 itu? Pilar ketiga itu terdiri dari 3 komponen, yaitu namakan technical safety, pilar pertama, kemudian pilar keduanya ada human and organization, kan tadi manusia dan tempat kerja. Betul kan tadi? Nah, di tengah-tengahnya ada sistem manajemennya yang menghubungkan antara technical safety dan manusianya ini. Ini kita bicara di tempat kerja nih, technical safety, aspek keteknikan, tempat kerjanya, peralatannya, sarananya, proses kerjanya, ini namakan technical safety. Nah, di sini manusianya, human pekerjanya. Nah, di sini di tengah adalah sistem manajemennya. Untuk mengelola keteknikan dan mengelola manusia ini perlu sistem. Nah, inilah namakan pilar K3. 3 pilar K3. Ini di sini saya akan banyak membahas. Nah, pilar K3. Nah, pilar K3 ini didukung oleh fondasi yang dinamakan safety culture, budaya keselamatan. Jadi kita sekarang banyak bicara budaya. Di mana posisinya budaya? Jadi budaya itu adalah merupakan fondasinya ya dari K3. Nah, kemudian inilah yang mendukung terciptanya safety performance kita. Ya, maka di sini teman-teman bisa melihat ini budaya K3 itu yang menentukan semuanya. Nah, itu maka kita masuk ke sini. Ya, masuk ke konsep 3 pilar ini. Teknikal. Nah, ada yang melihat pilar itu dari kacamata seperti ini. Ada nyebutnya pilar pertamanya keteknikan, pilar kedua proses manajemen, pilar ketiga behavior. Ini yang penting kita pelajari. Sebab kalau kita melihat di sini, pilar engineering itu bersifat given, tidak bisa lagi naik. Nah, karena dia bersifat teknik, selesai kita beli mobil, selesai sudah. Kita bikin pabrik, selesai. Bagaimana kondisinya? Nah, kita buat proses dan standarnya. Bagaimana menjalankan mobil. Nah, kemudian mobil dijalankan oleh manusia. Man behind the gun-nya. Manusialah yang menentukan bagaimana keberhasilannya. Maka ada juga yang menyebut hardware, software, and people. Ini kuncinya. Jadi inilah yang saya ingin tekankan, pilar keselamatan ini. Jadi Dalam membangun K3 kadang-kadang kita melupakan, kita hanya fokus ke sistem aja. Pokoknya dapat ISO, dapat SMK 3, tapi teknikalnya tidak diurusin, maka terjadi kecelakaan. Sebaliknya, kita sudah punya teknikal yang hebat, tapi kalau manusianya tidak kompeten, tidak ada gunanya juga. Oke, lanjut ya. Nah, ini nanti boleh dilihat teknikal safety itu apa saja. Kita bicara kepada semua bahaya yang ada di teknik ini. Kita bicara instalasi, peralatan, mekanik, desain, dan sebagainya. Itu keteknikan. Ya, kita bicara pipa, bicara alat, kompresor, dan sebagainya. Nah, kemudian kalau sistem kita bicara manajemennya. Maka banyak manajemen sekarang ya, ada manajemen lingkungan, manajemen operasi, K3, manajemen risiko, semua sistem. Nah, sistem semua yang kaitan dengan mulai kebijakan, perencanaan, dokumentasi, pelaporan itu namakan kesisteman yang menghubungkan pilar 1 dengan pilar 2. Nah, yang ketiga adalah pilar ketiga, kita bicara manusianya. Manusianya itu kita bicara nanti pembinaannya, kompetensinya, pengawasan, ekonomi, budaya, dan sebagainya. Itulah kira-kira ya secara singkat. Jadi disinilah kita masuk ke inti daripada permintaan dari Lutika untuk topik kita adalah pengendalian risiko di dalam era pandemi ini. Bagaimana kita melihatnya dalam menerapkan risk management ini? Maka kita menggunakan konsep 3 pilar itu. Maka konsep 3 pilar itulah yang dikembangkan oleh yang namakan kita melihat ya Jim Rison ini. Jim Rison itu mengembangkan teori yang dinamakan Swiss cheese model. Nah, Swiss cheese model itu mengacu kepada tiga pilar ini. Jadi terjadinya kecelakaan itu apabila pilar-pilar yang kalau menurut Jim Rison itu adalah ya sebutnya barir. Ini barir-barirnya semua ini ya. Barirnya ada 3 tadi. Engineering, sistem dan prosedur, dan manusia, human intervensi. Nah, di sini kita melihat bagaimana kita nanti melihat bagaimana strategi yang akan kita pakai dalam menghadapi mengendalikan risiko ini. Apa kita fokus ke engineering, apa kita fokus ke prosedur, apa kita fokus ke human intervention atau manusia. Oke. Nah, oke. Ini yang tadi kita lihat. Ini sudah dipraktikkan oleh para ahli-ahli ya pada waktu terjadinya pandemi kemarin. Pandemi kemarin itu juga menggunakan konsep Swiss cheese model ini yang dikembangkan oleh para ahli di WHO dan sebagainya. Bagaimana strategi menghadapi COVID. Jadi kalau kita lihat di masalah ini kan virus itu akan masuk ke dalam tubuh manusia menjadi fatality, akan melalui berbagai-bagai macam barrier. Inilah yang dipasang. Barrier ini yang dipasang untuk mengamankan supaya virus tadi tidak menjadi dampak menjadi fatality gitu ya. Jadi ini maka dikembangkanlah. Nah, barrier pertama yang keteknikan, kita pasang barriernya. Kita semua sudah divaksinasi, ya divaksinasi. Kemudian kita naik barrier lagi, awareness ditingkatkan. Ini berkaitan dengan manusia sehingga semua orang budayanya awareness. Diadakan juga social distancing, jarak yang aman. Nah, kemudian dibangun juga budayanya bersih, hand hygiene, masker dan sebagainya. Nah, ini adalah sebagai apanya sebagai bariernya ya dan tapi COVID. Kalau masih terjadi kasus COVID, misalnya orangnya terkena COVID, maka kita pasang lagi bariernya di sini untuk mengendalikan. Melakukan pengujian, testing dan sebagainya, lakukan isolasi, karantina, dan sebagainya. Kemudian ada klinik manajemen, rumah sakit disiapkan menghadapi COVID, dan tanggap darurat. Nah, inilah pendekatan risk management yang dulu dilakukan oleh para ahli dengan menggunakan teori konsep 3 pilar ini. Nah, sekarang di dalam hierarki COVID dia menggunakan pendekatan ini juga. Pendekatan ini yang kita namakan hierarchy of risk management, mulai eliminasi, substitusi, engineering control, administrator control, dan PPE, sehingga COVID tadi tidak bisa berhasil. Mulai dari eliminasi kita lakukan isolasi, ya substitusi. Nah, kalau tidak bisa kita pindah tempat kerja kerja yang aman, kerja dari rumah, kita kerja ganti menjadi kerja di kantor, kita ganti di rumah, itu bagian dari substitusi. Engineering control, mana kita ngontrol suhu tubuh, skeni dan sebagainya. Admisi kontrol, menjaga jarak aman, ya itu. Tuh, dan terakhir dengan menggunakan masker. Ini berarti kan risk management sudah diterapkan dalam menghadapi pandemi ini. Sekarang kita masuk, bagaimana strategi kita di dalam menghadapi pandemi itu. Jadi strategi yang kita lakukan adalah seperti tadi, hazard kita cari risknya, kita lakukan risk control. Dan resipennya siapa? Resipennya adalah manusia, objek penularan. Nah, manusia itu kita buat risk control terhadap manusia tadi. Risk control dengan barrier tadi, yang tadi digambarkan oleh Swiss cheese tadi, supaya virus ini tidak menular kemana-mana. Dibuatlah bariernya seperti ini. Ya, kita namakan barrier manajemen sampai ke tempat-tempat umum. Jadi diterapkan semua konsep risk based ini. Jadi ini yang dipakai oleh para ahli dalam mengelola COVID ini. Ya, nah ini yang kita lakukan. Jadi maka di sini bagaimana strategi kita membangun risk control yang berkaitan dengan kejadian ini. Nah ini yang sudah dilakukan selama ini kan kita membangun budaya keselamatan kata kuncinya. Fondasinya tadi apa? Budaya keselamatan itu kata kuncinya. Jadi dimulai dari personal safety dulu, dibangun budaya supaya manusianya sadar virus, sadar bahaya, sadar dampaknya, disiplin kepada semuanya. Nah, kemudian berubah menjadi home safety, berkembang. Dari perumahan kita masuk ke workplace, ke kantor, baru semuanya masuk ke public safety, kemudian nasional. Jadi pelajaran kita dari COVID ini adalah membangun safety itu dimulai dari diri sendiri. Karena COVID itu tidak bisa kita ngajak teman, kita tidak tahu. Ya, COVID itu bentuknya seperti apa, binatangnya seperti apa, nah, kita lakukan kan dari diri sendiri. Dari diri sendiri, pemerintah waktu itu membangun istilah yang dinamakan 3M katanya dulu ya, kita tahu iman, aman, imun, dan kemudian menjadi amin, katanya gitu ya. Nah ini strategi yang dulu digunakan. Jadi dalam diri sendiri itu apa yang kita bangun? Membangun budaya keselamatan agar semua sadar apa bahayanya COVID itu, apa dampaknya, bagaimana kita mengendalikannya. Ini ya yang kita katakan bagaimana kita membangun budaya, supaya budaya tadi adalah fondasi daripada safety tadi. Oke ya, lihat. Oke. Nah, sekarang kan tadi saya ditanyakan tadi, bagaimana strategi kita setelah pandemi ini. Jadi tadi kan saya katakan bahwa di dalam mengelola itu strategi kita menggunakan 3 pilar ini. Jangan lupakan 3 pilar ini. Pilar kita dalam angka 3 itu ada 3, technical safety, safety management system, human and organization factor. Jadi 3 pilar itu dinamakan pilar keselamatan. Jadi selalu apa saja ini yang kita lakukan setiap tempat kerja. Dan membangun pilar itu tidak akan bisa berdiri. Pilarnya rumah kita aja kalau nggak ada fondasi kan tidak bisa berdiri. Bagaimana kita bisa mendirikan rumah, mendirikan gedung pencakar langit kalau tidak ada fondasinya? Fondasinya apa? Safety culture, daya ini. Nah ini yang akan kita bangun di dalam setelah kejadian ini. Nah ini yang menjadi, nah ini yang saya katakan. Bagaimana kita membangun ke depan. Di dalam kita membangun ke depan setelah kasus pandemi ini, kita juga menggunakan konsep 3 pilar ini. Pilar pertama adalah technical safety, pilar kedua adalah administratif, sistem, pilar ketiga adalah human atau manusia. Nah, itu didukung oleh fondasi safety culture, budaya keselamatan. Nah, ini kita lakukan. Technical safety itu apa? Dengan teknik eliminasi, itu technical safety. Dengan teknik substitusi, technical safety. Dengan konsep engineering control, technical safety. Ya, kita lakukan itu. Nah, dengan manajemen sistem, kita lihat administratif kontrol, ya, dengan prosedur dan sebagainya. Dan terakhir dengan human, dengan menggunakan PPA itu adalah pendekatan manusianya dilengkapi dengan alat pelindung diri. untuk menuju shift operation. Jadi ke depan kita membangunnya dalam membangun culture ini. Kalau kita ingin betul-betul bahwa kita pandemi ini tidak terulang kembali, kita bisa berjalan, bisa meneruskan upaya-upaya kita. Nah, kita lari membangun 3 pilar ini. Pilar 3 ini yang kita sebut pilar technical safety, manajemen sistem, dan manusia. Oke, itu membangun manusia. Nah, ini kata kunci utama adalah safety culture. Ini yang utama yang harus kita bangun. Mengapa kita harus membangun safety culture? Ini adalah hasil penelitian dari para ahli pada saat pandemi dulu apa yang terjadi. Nah, teman-teman tahu ya mengenai Maslow piramide. Maslow piramide itu dulu Maslow itu ada levelnya adalah 5 level yang di bawah ini. 5 level. Levelnya adalah pada level bawah itu psychological need. Naiklah kebutuhan manusia, safety need. Jadi safety yang kedua, naik lagi ketiga, belonging dan naik lagi ke keempat, esteem dan seterusnya. Saya tidak bicarakan itu. Nah, ini ada dibicarakan bahwa terjadi perubahan paradigma dari akibat daripada COVID ini, piramida Maslow itu jadi berubah, tinggal 2 aja. Bahwa pada saat masa pandemi kemarin kita tidak pikir lagi gengsi, kita tidak pikir lagi pangkat, kita mikir jabatan, kita hanya mikir safety aja. Jadi dalam masa pandemi itu ternyata hanya 2 aja level manusia, yaitu physical need dan safety need. Nah, sehingga ada juga nih para ahli yang menuangkan yang atas ya, yang atas ini bahwa manusia itu akan tinggal sedikit saja butuhannya. Physical need, safety need, safety need lagi, safety lagi, jadi safety lagi. Tidak ada lagi orang melihat ke situ, melihat gagah-gagahan, tidak ada lagi melihat ini, tapi yang perlu safety. Jadi safety sudah menjadi fondasi ke depan. Jadi kalau ditanya bagaimana kita menghadapi pandemi setelah pandemi ini, apa yang kita perlukan? Yaitu membangun ini budaya ini harus kita pertahankan. Kalau nanti kita sudah abai lagi, yang kita tadinya sudah rajin pakai masker, kita sudah abai lagi disiplin, sudah ditanamkan dari awal, setelah itu balik lagi. Kayak desak-desakan seperti ini lagi. Nah, balik lagi budayanya. Jadi dalam masalah pandemi itu, kita melihat belajar dari kasus pandemi itu bahwa kita perlu sekali membangun budayanya, budaya manusianya itu yang perlu kita bangun, ya, membangun budaya, ya, itu kata kuncinya. Bagaimanapun hebatnya keteknikan kita, bagaimana bagusnya teknologi kita, bagaimana hebatnya sistem yang kita punya, apa sistemnya sudah lengkap, Pak, sudah dapat sertifikat SMK 3, dapat ISO, tapi kalau manusianya tidak dibangun, maka itu useless, tidak ada gunanya, itu ya. Tuh. Nah, di sini kita lihat bagaimana kita menghadapi ke depan. Setelah kejadian pandemi ini, apa yang kita hadapi ke depan? Kita akan menghadapi industri 4.0, akan terjadi perubahan dengan cepat akibat pandemi ini. Era 4.5 itu yang tadinya tidak kita bayangkan, kita sudah mengenal sekarang IoT ini, sudah semuanya sudah pakai internet semua kita lihat. Sudah pakai robot, sudah semua di mana-mana pakai robot, simulation, cyber security, sistem, cloud, 3 dimensi dan big data dan semuanya. Jadi kita sudah masuk sekarang era 4.0 dengan cepat. Dampak dari pandemi tadi memaksa manusia mempercepat terjadinya revolusi industri ini. Jadi kalau Anda lihat sekarang sudah luar biasa ya, AI-nya semua sudah menggunakan artificial intelligence dan sebagainya. Bahkan kalau saya baca di TV itu selama perang Palestina dia menggunakan AI juga, teknologi juga sudah digunakan, jadi luar biasa sekarang. Apa dampaknya bagi manusia? Ya, dampaknya bagi kita-kita, nah, remote operation, terjadilah otomatisasi, penggunaan robot. Nah, bagi kita apa? Dampak manusia dengan alat akan berkurang. Jadi nanti yang belajar di STIKES ya, kan selama ini diajarkan aspek manusia dengan tempat kerja, terjadinya paparan bahan kimia. Mungkin ke depan tidak ada lagi, karena kita tidak kontak lagi, kita tidak berada di tengah mesin lagi, kita tidak berada di tempat kerja. kita cuma memantau dari jauh aja ya dengan peralatan gitu. Kontak dengan bahaya atau virus, personal risk, dan health hazard. Jadi ini yang kita temukan ke depan dalam menghadapi era setelah pandemi ini. Jadi dalam era pandemi ini kita tentu akan merubah mindset kita sebagai pekerja, mindset kita sebagai ahli K3, mindset kita sebagai anggota masyarakat, tidak bisa lagi seperti lalu lagi. Karena dalam revolusi industri itu kita harus menanamkan nilai-nilai budaya keselamatan pada semua pekerja. Apa nilai-nilai yang harus kita tanamkan? Harus peka lingkungan. Kita harus sadar lingkungan kita, bagaimana kalau terjadi ini, bagaimana kalau kemungkinan jadi gempa bumi, terjadinya ini, terjadi ini. Nah, ini yang kita rasakan sekarang. Kita nggak peka terhadap lingkungan kita. Kita tidak tanggap dalam menghadapi ini. Karena sekian detik-detik aja itu bisa merubahnya. Kalau salah misalnya mengambil kebijakan, ya semua sudah dikerjakan secara otomatis, secara computerized. Bisa salah kalau kita tidak tanggap. Kerjasama juga perlu kita bina dengan kondisi yang saat ini. Dan taat prosedur. Tidak bisa lagi kalau kita sudah bicara IT, nah harus taat prosedur. Tidak bisa nanti bagaimana ada rubah-rubah prosedurnya, kita passing rate, dan sebagainya. Ya, gitu ya. Nah, kemudian kita menanamkan sadar bahaya, peduli keselamatan, waspada, dan disiplin. Inilah nilai-nilai moral yang harus ditanamkan dalam menghadapi pasca pandemi ini. Maka kami dari WSO sekarang banyak lari ke arah city culture nih. Kita membangun budaya, karena pilar 3 itu yang saya anggap penting sekali. Dan fondasi tadi. Fondasi tadi adalah budaya keselamatan, ya kan? Tadi dijelaskan bahwa fondasi kita di dalam membangun itu adalah budaya. Keberhasilan kita kemarin menghadapi pandemi itu adalah karena pendekatan tadi, pendekatan human tadi. Manusianya yang dibangun, ditekan, siapkan supaya taat pakai masker, jaga jarak. Nah, imunisasi, diperkuat manusianya. Sehingga lama-lama virus bisa kita kalahkan. Gitu ya. Oke. Oke, kita lihat lagi. Nah, itu kira-kira yang bisa saya sampaikan. Waktu diminta 45 menit ya. Cukup ya, Mbak ya? Kira-kira, nah ini saya akan menekankan yang terakhir ini penutup. Nah ini yang ingin saya tanamkan kepada teman-teman. Teman-teman sekalian sebagai ahli K3, kita berperan di dalam menjaga keselamatan dunia ini. Kita berperan dalam mencegah dan mengendalikan timbul atau menyebar luasnya suhu, kelembapan, debu udara seperti disebutkan dalam Undang-Undang Nomor 1 tadi. Jadi seorang ahli K3 itu tugas utamanya adalah tugasnya menjaga keselamatan masyarakat, menjaga keselamatan semua pihak. Nah, untuk itulah di dunia itu dulu dilahirkan lambang K3 sedunia. Lambang K3 sedunia itu adalah palang hijau namanya. Makanya disebut Green Cross for City. Ini lambang K3 pertama. Dan di Indonesia dijadikan lambang K3 ditambahi roda gigi di Indonesia. Ya, tapi tetap yang palang hijaunya ada. Sekarang banyak ahli K3 itu nggak memahami apa makna palang hijau itu. Kenapa logo K3 itu palang hijau? Kita nggak pernah menyadarinya. Nah, kan di dunia ini ada 2 macam palang. Ada palang hijau, ada palang merah. Yang kita kenal hanya palang merah aja. Palang merah itu kita bicara mengenai Red Cross, kita Green Cross. Jadi apa bedanya Green Cross dan Red Cross? Ya, ini semuanya adalah gerakan kemanusiaan. Palang hijau dan palang merah. Nah, ini yang kita tidak sadari bahwa kita sebagai organisasi K3 ini adalah palang hijau. Maka logo kita selalu dipasang dipakai palang hijau, palang hijau. Tapi kita tidak memaknai arti dari palang hijau itu. Apa makna palang hijau itu? Bahwa kita mencegah kecelakaan sebelum kejadian. Bersifat pencegahan. Maka di sini, mencegah dan mengendalikan timbul atau menyebar luasnya suhu. Kalau Anda jalan palang hijaunya, maka tidak ada kecelakaan, tidak ada orang celaka, tidak ada bencana, tidak ada kejadian. Palang merahnya tidak ada kerjaan. Nah, sekarang yang hebat adalah palang merah yang banyak kerjaan, karena banyak orang celaka, banyak orang sakit, banyak orang ini. Jadi palang merah ini menjadi prioritas, dibangun oleh masyarakat, disediakan dana yang luar biasa untuk palang merahnya, palang hijaunya tidak dikasih apa-apa. Nah, inilah kesalahan salah pikir kita. Yang harus dibesarkan harusnya palang hijau. Kalau palang hijaunya besar, maka palang merahnya aman, palang merahnya ringan kerjaannya, gitu ya. Nah, ini yang ingin saya ajak kawan-kawan semuanya, mengingat di mana peran ahli kita itu. Kita adalah sangat berperan sebagai pergerakan kemanusiaan. K3 itu adalah misi kemanusiaan, mencegah sebelum kejadian. Palang merah adalah menanggulangi setelah kejadian. Maka ada BNPB, ada bagian kebakaran, ada SAR, ada CMI, itu adalah gerakan setelah hal kejadian. Nah, kita sebelum kejadian ya mencegah sebelum kejadian. Nah, itu aja sekadar penutup dari saya ya. Jadi itulah karena kita ke depan akan membangun budaya. Karena fondasi setelah pandemi ini adalah city culture. Itu kata kuncinya yang sudah kita tanamkan selama masa pandemi. Kalau bisa jangan hilang. Saya khawatir nih nanti degradasi nih. Nilai-nilai ini menurun lagi. Nanti balik lagi kejadian-kejadian lagi. Nah, sekarang kita dihadapin dengan berbagai macam isu, ada isu climate change, ada isu macam. Itu kuncinya adalah di palang hijau. Kalau palang hijaunya jalan, itu dapat kita kendalikan. Nah, itu sekarang itu yang menjadi kunci kita. Baik, saya kira itu aja dari saya. Terima kasih atas perhatiannya. Waktunya pas ya. Tanya 45 menit.
Ya.
Baik. Terima kasih Mbak Tika.
Terima kasih, Bapak. There was such a very wonderful and we feel so grateful we can meet today in this Zoom meeting, Mr. Suhatman Ramli. Terima kasih, Bapak. Pemaparan yang sangat jelas dan memberikan banyak pencerahan. Karena bagaimanapun tempat kerja itu tidak selalu di manufaktur atau yang di pabrik begitu ya. Sejujurnya perkantoran tempat kami setiap hari bekerja ini adalah kategorinya tempat kerja begitu ya, Pak Hatman ya.
Ya.
Artinya kita sebagai kategori pekerja nih, sebagai SDM-nya barangkali relate sekali dengan apa yang tadi Pak Hatman telah paparkan, upaya-upaya tadi menarik tentang konsep Green Cross for Safety gitu ya, karena sebetulnya poinnya adalah pada preventif gitu ya, dari upaya-upaya pencegahan untuk bisa pengendalian dari bahaya itu bisa kita optimalkan di fase preventif. Baik, barangkali 2-3 menit Pak Hatman, kalau ada audiens yang ingin bertanya, mendiskusikan
Silakan,
tentang
monggo.
paparan yang disampaikan mumpung ketemu. Jadi beliau ini adalah living legend, banyak sekali buku karya beliau yang menemani kami, para mahasiswa public health gitu ya, mahasiswa Kesmas, mahasiswa K3 belajar. Terima kasih Bapak karya-karyanya, kesimpan rapi di tiap perpustakaan gitu ya.
Ya,
Jadi disilahkan boleh kirim di chat room atau bisa bertanya langsung karena beliau juga cukup sibuk dan terima kasih Bapak telah meluangkan waktu untuk menghadiri undangan dari kami meskipun di last minute begitu ya. Nah, Bapak tadi satu hal lagi yang menarik adalah tentang perubahan konsep piramida Maslow gitu ya. Kita tahu bahwa piramida Maslow itu menjelaskan tentang kebutuhan dasar manusia, basic human need. Secara umum, kebutuhan manusia itu apa sih yang paling basic? Makan, minum, mendapat udara segar, dan seterusnya, sampai kebutuhan untuk eksistensi diri gitu ya. Tapi dalam sudut pandang kita melihat kondisi pandemi dalam aspek safety di tempat kerja, ada hal menarik yang ternyata pada saat terjadi disaster, kalau yang tadi dicontohin tuh ada pandemi gitu ya, orang tuh kebutuhannya bisa berubah prioritas ya Bapak ya. Sehingga ada penyederhanaan nih dari piramida Maslow yang tadinya mungkin ada 6-7 layer, sekarang hanya tinggal 2 layer. Barangkali mohon pencerahan atau penegasan sedikit terkait dengan adanya perubahan paradigma dari piramida Maslow itu sendiri, Bapak.
Iya, itu pada saat pandemi, memang demikian. Pada saat pandemi itu kan tidak ada lagi orang mikir jenderal-jenderal pun, menteri pun, presiden pun nggak bisa kena pandemi. Jadi semuanya mencari kesehatan ya kan ya. Jadi tidak ada lagi isinya gengsi-gengsian karena virus itu tidak melihat siapa. Dia bisa mengena siapa saja, di mana saja dan bagaimana saja. Jadi itu intinya. Jadi pada masa pandemi itu hilanglah gengsi-gengsian, orang tidak bisa gengsi-gengsian lagi, sehingga konsen kepada keselamatan. Makanya dikatakan tadi yang penting bagi Indonesia pada zaman pandemi itu adalah keselamatannya. Inilah maksud saya yang kita tanamkan ke depan, bahwa dalam kehidupan kita tuh kita butuh keselamatan juga. Maka walaupun pandemi sudah berakhir, tetap ancaman itu ada di mata kita. Cuma bentuknya yang berubah. Kalau tadinya yang datang virus, nanti kemudian ada lagi yang lain. Ada lagi penjamin ini, misalnya gangguan alam. Ada lagi sekarang masalah climate change katanya. Nggak bisa juga, bisa jadi turun penurunan lahan misalnya, air naik menjadi banjir, banyak sekali gangguan-gangguan. Apalagi dengan penggunaan teknologi sekarang yang dikembangkan tentu akan membawa dampak. Kita akan menggunakan misalnya elektrifikasi, mobil-mobil dengan listrik, semuanya akan membawa dampak yang luas. Semuanya kata kuncinya apa? Yaitu fondasinya tadi si kan Pak? Fondasinya. Nah, safety culture itu apa? Ya itulah tadi apabila orang itu sudah berpikir safety. Nah, itulah di dalam teori Maslow itu nilai-nilai safety itu tetap kita tanamkan gitu. Jadi itu maksudnya. Jadi mungkin piramidanya sedikit mengalami degradasi, perubahan ya, karena kita akan lebih mengutamakan safety first gitu. Sehingga itu akan bisa melindungi kita dari berbagai bencana. Itu kali Mbak. Monggo silakan
Ya,
teman-teman kalau ada yang mau
terima
ngobrol,
kasih Bapak.
sharing.
Ya, itu sebuah sudut pandang baru gitu ya Pak. Ternyata setelah ada kondisi genting pada saat kita harus bertahan gitu ya, harus survive untuk menghadapi pandemi, kebutuhan kita yang paling utama justru safety gitu ya. Yang penting kita selamat
Iya.
dulu deh gitu ya. Nanti setelah selamat baru deh mikir yang lain-lain begitu ya Bapak ya. Itu sangat relate sekali apalagi di di beberapa area kerja yang tidak punya pilihan untuk tidak berinteraksi dengan manusia pada saat itu gitu ya. Jadi betul sekali Bapak, kami sepakat tentang itu. Nah, mengingat waktu juga Bapak Ibu serta seluruh undangan yang berbahagia yang masih join di dalam room Zoom ini bahwa eh, kita harus mencukupkan dulu untuk sesi ini. Mungkin ada last statement, penguatan dari rangkuman materi kita pada sesi ini, Bapak, sebelum kita mengakhiri sesi di topik yang Pak Hatman sampaikan. Barangkali bisa disampaikan, Bapak.
Iya, jadi akhir statement kita bahwa kita melihat masalah safety itu masalah kita bersama. Jadi kalau bisa, jadi kita semua ini ya yang ada di sini, apalagi dari Poltek Kesehatan, ya tentu sangat konsen kepada keselamatan ya, keselamatan semuanya. Nah, dalam membangun keselamatan itu sangat diperlukan eh, kepedulian kita semua. Makanya kalau kita sudah berusaha menempatkan safety sebagai nilai-nilai di dalam diri kita manusia, dan mudah-mudahan semuanya bisa kita hadapi. Tapi kalau kita melihat hanya safety itu hanya sebagai beban, safety itu hanya sebagai penghambat, safety itu dapat mengganggu saya, operasi saya terganggu, nah itu masih sulit. Jadi kita membangun ketiga ke depan ini, fondasinya adalah budaya keselamatan. Dengan tiga pilar keselamatan itu. Nah, tiga pilar
Ya.
itu tolong diperhatikan. Technical safety, sistem manajemen, dan human manusia. Saya kira itu. Terima kasih, Mbak.
Thank you very much. That was a very grateful speak from Mr. Suhatman Ramli. And before we end the session, let me show the certificate. So from committee, please. Ya,
Thank you very much
Bapak
for your
Suhatman
attention.
Ramli,
Oke, thank
mohon
you
dapat
very
diterima
much.
sertifikat. Ya,
Oke.
nanti akan kami kirimkan melalui
Baik, Mbak.
email dan kami sampaikan terima kasih atas nama
Baik,
Sivitas Poltekkes
selesai ya.
Kemenkes Malang. Perkenan
Bos.
waktunya, Bapak. Semoga kita bisa
Monggo.
berjumpa
Terima
di lain
kasih.
waktu dengan event yang lebih baik. Terima kasih. Selamat
Baik.
siang. Assalamualaikum
Selamat siang.
warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi
Waalaikumsalam warahmatullahi wabarakatuh.
Terima
Thank
kasih.
you so much, Ma'am Rizky Mustika Riswari. And also thank you so much for Mr. Swetman. Terima kasih Bapak Swetman for the sharing the
Terima kasih,
interesting
Pak.
topic. Yeah. Terima kasih. Once again, for all participants, the attend for this information for all participants, the attendance link will be shared later at the end of the conference. Thank you. For the next session, maybe my partner will be continue.
Okay. Okay, thank you, Mr. Andy. And now we will have our next session or topic presentation from Dr. Kuria Abdul Hamid, and the topic is potential formulation of traditional natural ingredients in treating metabolic disease. So, Dr. Kuria, good afternoon.
Hello, Assalamualaikum, good afternoon. Okay, hi, can you hear
Waalaikumsalam.
me?
Yes, we can hear you, ma'am.
Shall I
Okay.
start sharing?
Wait a little bit because okay. Now, I just want to say hello first to you, Dr. Kuria, and let me briefly introduce you first. Dr. Kuria Abdul Hamid is a senior lecturer from University Teknologi of Mara. And this session will be led by Mrs. APT Retno Ikayanti as FAM MFAM, as the moderator. And okay, Mrs. Retno already here. And Mrs. Retno graduated from Department of Pharmacy, Gajah Mada University for her bachelor degree. And for her master degree, she was graduated from Department of Pharmacy, Erlangga University. And now she is a lecturer from Department of Pharmaceutical and Food Analysis at Health Polytechnic of Malang. Okay, so without further ado, please, for Dr. Kuria and Ms. Retno, the time is yours.
Thank you. Good afternoon, everyone. Welcome to the fourth session of this international conference. My name is Retno, and I will moderating this session. And I like to greet Dr. Kuria Abdul Hamid. Hello, Dr. Kuria.
Hi.
Okay, welcome to this session. And your topic for this session is potential formulation of traditional natural ingredients in treating metabolic disease. Before we begin, I have a few housekeeping notes. The presenter will have total 1 hour for presenting the topics, and after presenting the topic, we will have a discussion for about 30 minutes. And all the audience can ask a question by typing the question in the chat box, and I'm going to read them for you. Before the presentation, let me read your profile first. Next, Dr. Kuria is senior lecturer in pharmaceutics of University Teknologi Mara, Malaysia, with educational background. She pursued his PhD in Kyoto University, Japan, and with working experience as a senior lecturer in pharmaceutics in Faculty of Pharmacy, University Teknologi Mara, from 2010 until present. She is also research associate advanced material and healthcare technology in the University of Nottingham, UK. And she is also drug formulation executive in Pharmaniaga Research Center, Berhad. And before that is a science officer in cord blood unit for National Blood Center. His profile for grant acquisition is from principal investigator and co-investigator is totally more than 1 billion ringgit Malaysia. Next. This is the profile of the publication of Dr. Kuria. She has published more than at about 39 publications since 2020 until now. And I think this is a lot of publication. Next. And Dr. Kuria is also have I think this is the student for main supervision, post supervision, and external supervision. Next. This is the expert reviewer, and the academic award is he gained nomination in MDPI Pharmaceutical Best Paper Award in 2022, Anugerah Perkhidmatan Cemerlang from University Teknologi Mara in 2014, and Anugerah Insentif Penerbitan Artikel Berimpak from UITM, and Anugerah Perkhidmatan Cemerlang from UITM in 2020. Next. I think that is your profile. And now we go to the presentation. Dr. Kuria, please. So please give your presentation.
Okay. First of all, thank you very much. Miss Retno, right? Retno Ika,
yes.
For your kind introduction. Okay, so I shall, and to all the participants, and for inviting me to this conference today. So, so I shall start presenting my slide. Okay. Okay, can you see this slide clearly?
Yes.
Okay, actually, so the topic that I received is actually potential formulation of traditional natural ingredients in treating metabolic disease. Okay, and my research, this is for me, the main topic is quite not really broad, it's quite general. So I include my research project, which is chitosan coated alginate nanoparticles and for enhanced absorption profile of insulin via oral administration, because I would consider chitosan as a natural ingredient because it's obtained from chitin. Okay, natural resource. So I am from Department of Pharmaceutics, Faculty of Pharmacy, University Teknologi Mara, and also I affiliate with Taur Rahman Institute for Natural Product Discovery, Aurins UITM. Okay, so next. So so the current treatment options for metabolic disease is like for diabetic, for example, we have currently practice injected insulin injection, which is the most common method of insulin delivery, but has limitations, which is quite invasive and non-patient compliance. And also, in order to reduce this metabolic disease risk, is to change our lifestyle, which is to our diet and exercise, which can help manage metabolic disease. But this one may not be practical for some people due to sedentary lifestyle or due to, inactive lifestyle that hinder or reduce the life change to make it more healthy lifestyle. Okay. And then so the overcoming limitations like with traditional ingredients, for example, cinnamon, that may improve blood sugar levels and insulin sensitivity in people with metabolic disease, or can use ginger, fenugreek, T cell. This is the traditional practice, not really traditional, but naturally people consume this. Okay. And for my study, why I use chitosan for delivery of insulin. Insulin is a drug to treat diabetic. Why use chitosan coated alginate nanoparticles? Because it is a natural polysaccharide which derived from chitin, fibrous material found in the shells of shellfish such as crab, lobster, and shrimp. So when we so this chitosan is actually small spheres and degradable polymers, which is suitable to develop, to formulate as a delivery system to carry this insulin drug. Okay, so why this chitosan is special? Because they have positive charge that increase their absorption through the intestinal walls. Okay, so how the chitosan protect insulin, how this delivery system works, because as we know, insulin is a type of peptide drug which if we ingest orally is going to be degraded in the stomach due to the harsh environment, acidic condition. So we enteric coated the insulin with the help of this chitosan to degrade and to release in the intestinal, because as we know, intestine has a larger surface area, which is villi structure. So many villi structure that provide a surface area, bigger surface area for the absorption to happen, meaning that when the consume these enteric coated insulin nanoparticles, it will not degrade in the stomach. It will go directly into the intestine, and where the most absorption happens there. Okay. So the benefits of oral insulin administration as opposed to parenteral injection, like insulin injection just now, because it's more convenient. Of course, it's no need for injections, making therapy more accessible for patients, and no gastrointestinal discomfort, because we don't introduce this pierce into the stomach or into the fat layer to deliver the insulin to treat the diabetic. Okay, and then and also because of these enteric coated nanoparticles, the benefit is it will give faster absorption, which it help insulin pass through the intestinal membrane quicker. Okay, and improve effectiveness, because it will protect the insulin from being degraded in the stomach. Okay, and also these nanoparticles is lower dose as compared to the conventional like tablets, for example, metformin, that people take orally. Okay, so the potential of chitosan coated alginate nanoparticles is because it's from natural ingredients, it's biodegradable and obtained from natural sources such as crustacean shells and seaweed. Okay, but for further research is required. It's still ongoing and it's required for the to develop safe and effective treatment. It requires, of course, the preclinical and clinical study prior to this to the use or the consumption of this kind of delivery system dosage form. Okay, and then so for the introduction, diabetes mellitus, as we know, is a disorder when the pancreas does not secrete sufficient amount of insulin and the ability to utilize insulin, because it plays important role in sugar and carbohydrates regulation that acts as a hormone which coordinates the uptake of glucose by organs such as muscles, liver, and fat tissue. So this untreated, if diabetes mellitus is not treated, it will lead to heart failure, stroke, kidney failure, and blindness. Okay, so which people or which type of people require exogenous insulin injection is diabetes type 1, while patient with diabetes type 2 is require anti-diabetic medication to boost insulin production, and only receive insulin injection whenever the medication is no longer relevant. Okay, like I mentioned before, oral administration of protein drugs like insulin faces great challenges, harsh pH in the GIT, enzymatic degradation. Therefore, we formulated, and we developed this insulin carrier system to provide a stable and biocompatible environment to ensure that insulin remains biologically active and enable the nanoparticles to deliver an accurate concentration of insulin to control the glucose in the plasma in our blood level. And besides this, Ketosan also has a characteristic of mucoadhesive property that shows promising results in increasing residence time in the small intestine. Okay. And besides, it also shows low toxicity, compatibility, and excellent biodegradability. So we in this work, okay, we successfully formulated a multi-component structure encapsulated insulin, which we can reconstitute without the loss of activity that enhance the oral bioavailability of insulin in the is the novelty in this study. Okay, so for the materials and method for this work, we use these are the formulations, formulation 1 until formulation 4 that we developed using alginate, chloronic, dextran, insulin, and Ketosan as a carrier system together with the insulin. Okay. So this is the schematic diagram of insulin nanoparticle preparation, how we prepare the nanoparticles. This alginate with dextran sulfate, and then we mix that, and then the ionic gelation process occurs, and finally we able to produce these insulin nanoparticles. And of course, after we formulate these nanoparticles, we have to, this nanoparticle is subjected to characterization study, which is we have to check its particle size, its size distribution of nanoparticles, its zeta potential, its morphological analysis, for example, scanning electron microscopy and TEM, okay. And also Fourier transform infrared spectroscopy, which is FTIR, SRD, and also we have to perform HPLC analysis to determine the concentration of the insulin that being absorbed in the plasma. Okay, in this study we use animal as rat model, but also if we also advise to use the more high-end technology, for example, LCMS with a small quantity, we already can detect the amount of insulin. Okay, and of course we need to see is drug loading and encapsulation efficiency of the formulation that we developed just now. And it's not sufficient if just this formulation. This formulation is also subject to in vitro release using simulated fluids to see whether it can release in certain pH condition, whether it can release in stomach or intestine, whether we can retard it release in stomach so it can release in intestine. So this is why we need to conduct in vitro release study, and also finally the in vivo absorption study to see how much it is being absorbed in the circulatory system or in the blood plasma. And then so for the results, particle size analysis, as we can see here, we measured the particle size, the uniformity, zeta potential, PDI, polydispersity index. Yes, and this is to see whether which formulation exhibit the smallest particle size, but also with good uniformity, meaning that closest to zero. The smaller the value means the better the uniformity, which when we run, it will give the quite sharp peak or narrow distribution, meaning that it's uniform. And yes, PDI also is better when it's closest to zero. The lower the better. Okay. And then, so as you can see here, formulation 2 produced the smallest particle size of around 300 nanometer with narrow uniformity and PDI value of 0.56. Okay, so when we see this, we can see like, okay, it's like formulation 2 or formulation 3, the size, particle size, uniformity is okay. Because of this, when we screen this, and this formulation is gonna be proceed to the subsequent analysis. All right. So this is the morphological analysis where we to see this is the SEM image, scanning electron microscope under 2 times 10 to the power of 5 magnification. So as we can see here, the distribution of A is like formulation 1, formulation 2 is B, formulation 3 is C, and formulation D is formulation 4. Okay, so formulation C is quite, the spheres is quite uniform throughout formulation. Okay, on top of that, we conduct the TEM analysis. As you can see here, TEM image. So it shows that almost spherical or subspherical with visible ketosine coating around the core shell of the nanoparticle. Okay, so this is to see more clearly in addition to the SEM image study just now, right? And then this is we conduct the FTIR or Fourier transform spectroscopy. Okay, where we see here insulin, and this is figure 4.1 on the left side is the contain all components as shown in table 1 except insulin. We have our formulation excipients general or ingredients, but without insulin, this is what we get from 4.1. Okay, which it shows it has 2 distinctive peaks, which were amide 1 and amide 2, which were determined at narrow peak at 655.18, and amide 2 was observed at 1543.40. Okay, and in comparison to the spectrum of blind nanoparticles in figure 4.2 on the right side, low intensity was observed at 1527 due to the absence of insulin. Okay, once insulin was added, the intensity of amide was shifted. So we can see that when we add the insulin, so the intensity, the peak was shifted, okay, from 1527 to 1543. So, so the high intensity peaks that we observed just now, respectively, which indicate which we observe were observed at 1655 and 1543, indicated the possibility of insulin present in the nanoparticles as compared to bland nanoparticles on the in the figure 4.1. Okay, and for SRD, SRD is used is an important equipment for the determination of crystallinity and amorphous state of the compound. As we can see here, is it shows our formulation is amorphous. What amorphous characteristics is good is because when we see our formulation shows characteristic of this amorphous, is meaning that it is easy to solubilize. It doesn't have the solubility issues as compared to crystalline peak. Okay, so this one, when we see this, so it's good to proceed, and we doesn't face so much problem in terms of solubility. Of course, when we formulate something drug, we need it to be soluble in order for the drug to distribute homogeneously and evenly. Okay, in the system, right? And then, so this is, we further check the drug loading capacity and encapsulation efficiency or EE in our formulation. As we can see here, the encapsulation efficiency of formulation 2, 3, and 4 is comparable, and it shows a high encapsulation efficiency of insulin in that formulation. But as we can see here, like formulation 2, formulation 3, 4, it's considerable, being formulation 4 is the highest EE. Okay, so all this formulation, we will proceed to the in vitro release study of simulated fluids, of gastric simulated fluids where we prepare one pH 1.2, the other one is pH 6.8. 1.2 is to mimic the gastric fluid, our stomach, and the other one, pH 6.8, is for intestine. As you can see here, all the formulation, the release were retired in the pH 1.2, but it can release in pH 6.8, meaning that it is safe in the stomach. It will not be degraded and it will go into the intestine to be released. Okay, and this is the finally, we conduct the in vivo absorption study to see the bioavailability or pharmacokinetic profiles of our formulation after the administration of this insulin chitosan nanoparticles after oral administration in rat model. Okay, and on you can see on the left figure 7a the pharmacokinetic profiles of insulin in rat plasma. As you can see here, the formulation 2, formulation 3 shows good absorption profile as compared to control, and also at the same time we also measure the glucose concentration in blood plasma after oral administration to see how much glucose is being reduced after the administration of these insulin nanoparticles. Okay, and this table shows clearly the bioavailability study of pharmacokinetic study that we conduct just now. It shows that the area under the curve or AUC for formulation 3 is the highest as compared to the rest. Okay, Cmax at 12.49. Okay, and Cmax meaning that the maximum concentration achieved at 12.49 microgram per milliliter, Tmax at 90 minutes. Okay, and F% is the absolute bioavailability. When we conduct the oral absorption study, we also did this intravenous injection of this insulin nanoparticle to get the absolute bioavailability profile, which you can see here is 40% is considered high as compared to the other previous study before we conduct this formulation. Okay, so for the conclusion, we can say that these insulin nanoparticles were successfully developed using polyelectrolyte complexation and ionic gelation method to further improve insulin protection and absorption via oral administration. Okay, so we optimize the formulation as shown. Okay, and it's shown that from our simulated intestinal fluid study, the formulation retard in pH 1.2 but release at pH 6.8. Okay, and the EE value achieved the highest at 72%. However, formulation 2, 3, and 4 is quite comparable, so it's acceptable. Okay, and however, the pharmacokinetic profile of formulation 3 is the best because it shows the highest insulin bioavailability of 40% with reduced glucose level at 30%. So meaning that this study we can conclude that these insulin loaded chitosan nanoparticles, alginate coated with chitosan nanoparticles, enhance the delivery of insulin with EE value of 73% and bioavailability of 40% through oral administration. So it's a so this finding is like a key factor or provide a fundamental study in providing safe delivery of insulin should we choose this drug as an alternative delivery system rather than injectable insulin. Okay, so where's the future of this metabolic disease treatment? Current research current research is moving towards the development of new treatments for metabolic disease that are more effective and easy to administer, meaning that is safe and it's patient compliance. Okay, so the continued research on the potential of natural ingredients in treating metabolic disease may lead to a new innovative treatment in the future. And these are the references that I use for the introduction. And the acknowledgement, I would like to acknowledge all the writers, my students in producing the papers, the research articles with regards to chitosan, where we conduct study on chitosan with insulin nanoparticles, and also for levodopa is for Parkinson's disease through intranasal delivery as opposed to oral administration. And also I would like to acknowledge the grants, internal grants from University Technology Mara that fund this study so that it can be completed to this level. I think that's all from my presentation. Thank you for your kind attention.
Okay, thank you, Dr. Korea. I think this is very interesting. You use the chitosan as an agent to improve the delivery system for the insulin. May I ask you that are this formulation has been used for the patient there or somewhere?
Okay, sorry. This study is just we did until animal study and also like histopathological study. We didn't proceed yet to clinical trial or preclinical trial.
Okay. Why you don't continue to the clinical trial?
Because yes, it should, but because for the clinical trials, it requires massive documentation, the bioequivalent study, the article approval. So, but maybe in the future we might try, we might proceed to this clinical trial. Inshallah, I hope, because looking at the documentation, the process to apply, it's quite it's quite a lot. It's quite massive. Yeah. But in the future research, I think it should, because it shows a good bioavailability profile. Why not we introduce through oral? But of course, we need to conduct this preclinical and clinical. For preclinical, I think I still need to include a study like cell culture study to further confirm the toxicity of this formulation, whether it's really safe, or is there any other angles that I haven't checked to see whether it's really safe for human consumption.
Okay. Now it's time to invite the participation from the audience for the question and answer session. I think I will read the chat. This is a question from Hananda Yuviastuti. Such an interesting topic, Dr. Korea. I'm planning to work on the starch nanoparticle, but I'm having difficulties to make sure that the size under 100 nanometer. Maybe you have the tips to make the size smaller. Dr. Korea, please answer.
Sorry. Once again, the question. Sorry, my bad.
Okay. I'm planning to work on starch nanoparticle, but I'm having difficulties to make sure that the size will be under the 100 nanometer. Maybe you have the tips to make the size smaller.
Cool.
For the chitosan.
For the chitosan, like that before we did is ionic gelation technique. Okay, ionic gelation, and when there's this one method when you want to drip your formulation and you prepare formulation, the rate how you drop the formulation when you prepare, make sure that for example when you want to stir or to drop wise whatever solution that you prepare, make sure that it's consistent, meaning that in case for my student, he used this at the clinic when we have this drip equipment, drip tool, when they hold syringe to drip patient. So that's where he used it to control the rate of dripping the solution into the beaker, something. And even the homogenization process of course to control. And in my project, this one we use this freeze dryer and then reconstitute, okay, and use. And of course when you prepare your particles, first you have to check using master sizer, because you're not sure whether it's master size or nano size. When the size is like five below 1000 nanometer something, 500, then you can proceed with zeta sizer measurement. But the technique, the important is ionic gelation technique or any other technique, make sure the consistency, the technique that you use to make sure it's consistent, the rate the speed, something like that. Okay, am I answering the question?
Yeah, I hope this explains question from Anandayu. Dr. Korea, are you using freeze drying for your formulation?
Yes, for this one, yes. Because insulin is a thermolabile protein, so the method that we can use only freeze dryer to preserve the intestine. Not intestine, this insulin. Sorry.
Okay, I will invite the audience maybe want to make a question directly by raising your hand. Please.
Yeah, thank you, Mr. No. Dr. Korea, excuse me, I want to ask something. I want to it is interest for your explanation about if some people make oral insulin with oral, so the insulin get degradation. I want to ask for you, what the factor the insulin oral get degradation after absorption in the small intestinal? And then first my question, and then second my question, all of the people can use oral insulin get all of degradation. It is my second question. Thank you very much.
Yes, because insulin is a protein drug, is a protein peptide drug, meaning that it cannot be exposed to harsh environment like in our stomach. The environment, the condition is not suitable for insulin to survive. Okay, because of this acidic condition, the pH extreme pH acidic, so it cannot survive. So we try to introduce insulin just to see, yes, it's true, it's being degraded in the stomach before it being absorbed. So that's why we enteric coat. We enteric coated. We coat first with alginate and then with chitosan to protect. Sorry, so when we protect, it means and so when we conduct this gastric simulated fluid, so we introduce pH 1.2 something just now, and 6.8. 6.8 is mimic our intestine condition. 1.2 mimic our stomach condition, and it shows that the release retard in stomach condition, meaning that it's preserved, so it can be released in the intestine, which is it did release in intestine when we further conduct the absorption study. Because playing around formulating peptide drug or protein drug, it's not easy. It's not easy because it's susceptible to degradation by the heat, by the pH condition, by the acidic condition, by the enzyme yang present dekat stomach condition. So I answer the question.
Thank you very much for your explanation.
Okay.
Okay, Dr. Korea, you have mentioned that there is cinnamon, ginger, fenugreek, and milk thistle for the therapy. Have you researched them between cinnamon, ginger, fenugreek, and milk thistle?
Oh, no, it's just that one is I obtained from literature search, meaning that so many people try this and try that traditionally, but research-wise, we didn't conduct. I also for other studies, I'm not sure whether they achieve good results or not using this ingredient traditionally, but it might. But maybe how much concentration that it can reduce really the blood glucose level. We can eat this natural ingredient product, but of course the consumption, the concentration that we need to consume, and also whether the higher concentration is safe or is toxic. That's something that we have to consider. That that one also. Yeah.
Yeah, okay. Okay, thank you. And I think, what about the economics consideration about using this Skyterson
Thank
for
you
the
for the
formulation?
question. Economic consideration, meaning that whether it can be marketed in the pharmaceutical industry.
Okay.
I'm not sure if there's already pharmaceutical industry already market nanoparticle, because it's quite it's quite costly actually to prepare nanoparticles. You need the nanotechnology to prepare, whether it's really worth to proceed. But when it shows the profile of insulin level, the good profile, but maybe the pharmaceutical company can think that why don't you use or other oral insulin, other oral tablets, oral medications such as metformin or glycoside to reduce the glucose level other than insulin, right? But in terms of economic wise, maybe I'm not sure. I think it's quite costly for the pharmaceutical company to introduce nano medicine something. Because like for us in Malaysia, it's not yet being done due to this high high cost, I would say. And then before we can introduce to market, we have to conduct this bioavailability study, bioequivalent. Sorry, it's also involve a lot of money to do that study. Yeah.
Yeah, but I think it will a chance for us to make some research that can make it more economically useful, I think.
For economically useful, you mean what kind of research or something like that? Is it?
Maybe we can make the procedure more simple, and then we can get it more effective.
Yes, I do agree. I do agree. For example, if we can provide this nanotechnology, like for us here, university collaboration with industry, we provide this nanotechnology scale, we provide this material, and you at the industry can push to make it into tablet or into whatever kind of dosage form, as long as it can administer orally. Maybe, yeah, we can think kind of ways, some ways to do that. Because like for me here, besides this oral study of insulin delivery, I also did topical formulation, for example, cosmetics and also like pharmaceutical formulation, like from gels or cream, something. But for topical application, for example, like cosmetic is quite easy. The application process, the documentation is less work as compared to this oral or pharmaceutical delivery something. But this is just this is other part. This is for research that really needs a comprehensive study, and other part like formulation, cream or whatsoever, herb-based cosmetical cream, herb-based pharmaceutical product, just for topical application. So meaning there's two different study, but if we can get the pharmaceutical insulin delivery oral, that would be good enough with the reduced cost. Maybe collaboration between university and industry, how we can market that thing.
As you know, maybe there are another dosage form that use the nanoparticle for orally. Have been using the nanoparticle for orally administration.
For oral nanoparticles.
Yes.
I mean the already medication that in nanoparticles. That one I'm not sure about that. I think it's through oral maybe, but I think it's not nano, microparticles, yes, like micro pellets, microparticles. But for nano, I'm not sure yet. micro, yes, but like for nanoparticles or micro, not only we can deliver through oral but also through nasal delivery. It's another alternative approach to better enhance the therapeutic level. Because for nasal delivery, normally we target like brain kind of brain type of disease like Parkinson's, amnesia or something. So because it can direct to the brain, at least closer as compared to oral, where it can get first pass metabolism, go through stomach, go through liver metabolism. So that's the other way. But nanoparticles consumption, I'm not sure. I need to do more reading on that. But micro, yes. Okay.
Okay, thank you for your explanation. And I think this is the last question. What dosage form are you planning for this formulation for orally? This chitosan nanoparticle for the insulin? This
How much dosage form? You mean?
No. What type of
delivery?
Yes, to delivery.
Yeah, it's oral.
Tablet or something?
A tablet. Maybe capsule.
Capsule. Okay.
Yeah, maybe capsule. Entry. Maybe entry-coated insulin. Entry-coated capsule, because capsule also come with entry shell to protect.
Okay, thank you for your answer and explanation. I really like this idea of using the chitosan as an agent to improve the delivery system for the insulin. I think this is the end of the session. Thank you very much for your contribution to this webinar. I will give it back to the Mrs. Anandayu. Thank you.
Okay, thank you very much.
Okay.
Okay, thank you all.
Thank you very much, Dr. Kuria. And of course, thank you for Mrs. Retno for the valuable insight. And for the appreciation, we would like to share our certificate for you, Dr. Kuria. So please, the committee. Okay. And please also allow me to take to the documentation. Okay, thank you so much, Doctor, for joining us today, and we hope that we will see you or we can see you in the next opportunity.
Yes, thank you. So I can leave now.
Yes, you may. Thank you so much. Thank you so much, Dr. Korea.
Thank you
Maybe
for
you
the
have another
invitation.
schedule. Yeah.
Okay, see you again. Okay,
See you
bye.
again. Thank you. Okay, so that was our speaker for the afternoon session. That's Dr. Kuria Abdul Hamid, and now do we already have Dr. Nurul Hakimah in the room? Dr. Nurul? Okay, because this is the last session for today, and actually Dr. Nurul Hakimah was have to present tomorrow, but she will be scheduled for today, and we would like to invite Dr. Nurul Hakimah. Maybe she is already in the room. Doctor? Dr. Nurul Hakimah, good afternoon. Okay, so because maybe Dr. Nurul Hakimah still have some schedule that need to be done, and it's already 14:43 for the time. It's already in the Asar, for prayer. So I think we have another break for maybe 15 until 20 minutes, and then we will proceed to our last session for today. Okay, so please, for the participant to stay in this room until we start again, maybe around 3 p.m. And we will have Dr. Nurul Hakimat to present her topics. Thank you. Wassalamualaikum warahmatullahi wabarakatuh. We will have the break.
Terkesan LDR. Aku naman bibigyan na ano. Anak bibigyan na karo. Kita nga iya terus di kaya kan lama lagi first baby Thank you, Arlene.
Okay, dear our participants, thank you for your patience, and we now have finished our little break just now, and we will be proceed to our next and our last schedule. For today, there is the presentation from Dr. Nurul Hakimah, and please allow me to say hello first to Dr. Nurul Hakimah. Good afternoon, Doctor. Are you already here? Okay. Okay, good afternoon, Doctor. Can you hear my voice?
Hello, Miss Witty.
We cannot hear clearly, ma'am. Your voice is too small. Yeah. Maybe the volume you can increase your volume up from the device, maybe.
Hello, Miss Witty.
Okay. Yes, we can clearly hear you now. Okay, so ladies and gentlemen, now we have Dr. Nurul Hakimah here with us, and she will present her research. And the topic is development of a prototype model for a popular healthy diabetic mellitus menu based on the fuzzy genetic system. Okay, and the moderator that will accompany Dr. Nurul is Ms. Rizky Mustika Riswari, SSD MPH. So yes, because it's already at 3 p.m. So without further ado, Dr. Nurul and Ms. Rizky, please, time is yours.
Thank you again, Mrs. Widi. Introduce myself and good afternoon, all our participants. Thank you very much for still here with us in our Zoom meeting to attend our international conference and workshop of health in 20 and 23. And here we go in last session for today, the first day of our conference. I'm with Mam Nurul Hakimah, Dr. Nurul Hakimah, Dr. T. DRA Nurul Hakimah, SSD MKes. She is yeah. Thank you. Yeah. You can drop out first. Yeah. This now as our Vice Director in Academic Affairs in Health Polytechnic of Malang, and in this event, she will become one of speaker come from Health Polytechnic of Malang to deliver topic about development of a prototype model for a popular healthy diabetic mellitus menu based on the fuzzy genetic system. I think the topic is so incredible of participants, ladies and gentlemen. So, Ma'am Nurul, are you ready to talk about your topic today?
Okay, Miss Rizky.
Yeah, so I would like to assist you to share screen your material on PPT, and please tell me if you want we to play your video. So here we go. Ma'am Nurul, I will give time for you.
Okay.
Okay. So please, Ma'am Nurul.
Okay, thank you, Miss Rizky. Can my voice be heard clearly?
Yes, very clear, ma'am.
Okay, thank you. Sorry, I can only join because there are still activities discussing superior health polytechnic education centers in Semarang. Thank you for moderator, Ms. Rizky Mustikariswari. Previously, please allow me to deliver the opening remarks as follows for the Honorable Ibu Dr. Gigi Arianti Anaya MKM as Direktur Jenderal Tenaga Kesehatan Kementerian Kesehatan Republik Indonesia, the Honorable Bapak Dr. Maxiren Rondonuwu, IHSM Mars as Direktur Jenderal Pencegahan dan Pengendalian Penyakit Kementerian Kesehatan Republik Indonesia, the Honorable Bapak Dr. Muhammad Wildan as Director of Poltekkes Kemenkes Malang, and the Honorable Ibu Rizky Mustikariswari as SDMPH as Committee Chairs of the International Conference and Workshop of Health at Today, and the Honorable all presenters and all audiences who joined on the 6th International Conference and Workshop of Health or ICWH organized by Poltekkes Kemenkes Malang at this time. I hope all of you are always in good health and happiness. Amin amin ya rabbal alamin. Good afternoon and assalamualaikum warahmatullahi wabarakatuh. Welcome to my presentation. I am Dr. Nurul Hakimah. I am representing the Poltekkes Kemenkes Malang, and the focus of my talk on this international conference today is about prototype model development of popular healthy menu for diabetes based on the fuzzy genetic system. Next slide. We know that every November 14th, World Diabetes Day is celebrated. The World Diabetes Day is celebrated each year to draw attention to issues of utmost importance to the diabetes community. Between 20 and 21 and 20 and 23, the theme is a topic close to our heart, access to diabetes care. We all know that diabetes mellitus or DM, especially type 2 DM, is one of the non-communicable diseases with the highest prevalence, and today approximately 537 million people worldwide live with diabetes. According to the International Diabetes Federation or IDF, and the number is expected to rise to above 700 million by 20 and 40. The increasing prevalence of DM, if not controlled, will have a bad impact on the health system and the country's economy because of the high and long treatment costs. Next slide. Okay. I am going to divide my presentation into 4 parts, namely the first part, the background of why I made this application. Then the second, what is the methodology? Then the third, what is the flow of the system? And the fourth, conclusion and what recommendation can be conveyed from these application systems. Health is closely related to lifestyle and diet. To get diet and pattern eat a balanced diet, each individual has different nutritional and calorie needs, considering that each individual has a different weight, different height, and different age. Even other differences, physiological and pathological conditions. The medical nutrition therapy or MNT concepts of DM lays down 3 principles in diet management, including the right amount, the right type of food, and the right time, and is known as the right 3 principles to provide a basis for dietitians to be able to serve food according to these principles and be personal. People with diabetes can actually consume all types of food that are commonly found around them or are commonly known as a popular foods or popular menu. However, what needs to be considered is the immune. So the popular menu has a healthy effect for people with diabetes because it can control blood sugar levels. There are many factors that become variables in the diet, such as the number of calories, the amount of protein, carbohydrates, lipids, dietary fiber, value of glycemic index and glycemic load, etc. So we need a simple system that can personalize the food menu based on the needs of each individual. The implementation of these principles will be easily assisted by a computerized program, including using a genetic fuzzy system approach. With this system approach, the calculation process for providing diet menus in accordance with the right three principles becomes easier, faster, more efficient, and more accurate. From the results of my research, the fuzzy genetic system approach can be used to adjust the energy macronutrient and fiber content to obtain the glycemic index and glycemic load on the food menu packages according to the requirements for diabetes, as well as equipped with the concept of menu engineering calculations. Of course, these results is expected to have a positive effect on both the health system and the economy because it can be a tool to prevent the increasing prevalence of diabetes. Next slide. The result of my research show that the correlation between glycemic index and glycemic load values is with peak blood glucose and 2-hour postprandial. In the main meal menu with various types of menus, it was found that there was a significant correlation between the glycemic index and glycemic load values with peak blood glucose and 2-hour postprandial. Next slide. Applied the results of my research to about 33 people with diabetes and obtained the following results. 38% of subjects with this diet and medication showed a decrease in their blood sugar levels through glycated albumin examination. This shows that the concept from the results of this research can have a positive impact on people with diabetes. Therefore, we need a tool that can be used to guide users in realizing their daily healthy eating habits. So, through today's international conference, I will present a summary of my further research on how to develop a prototype model of a popular menu that is usually eaten a day to stay healthy and have implications for controlling blood sugar levels. And this is very important for consumers in general, especially for people with diabetes. There are two methodologies that I use to develop diet menu formulas. Next slide. by combining energy content, macronutrient content, fiber, glycemic index value, and glycemic load from many types of popular menus that we eat to get portions that suit the needs of each consumer. Namely, by one, regulate the portion size of food that should be consumed using a genetic algorithm. And two, choose a variety of food menus that will be consumed to meet daily nutritional adequacy and the glycemic load values required for people with diabetes to control their blood sugar levels. So there are two system approaches that were chosen as the method used in preparing healthy menus for people with diabetes and produced several algorithms. The first system approach using a genetic algorithm and the second approach using a fuzzy logic. Nutritional guides can solve the problem at hand. The guide can adapt to basic information from the user in the form of information on daily calorie needs. This information will be combined with a food menu database containing the number of calories, carbohydrates, protein, fat, and fiber from each food, so that a personalized food menu solutions will be produced in accordance with the daily target of each individual. And through the operation of the genetic algorithm, modification can be made to the size of the menu serving weight to obtain the energy content, nutrients, and glycemic load values according to the need of each individual or adjust to a personalized diet. And the second system approach using fuzzy system. Raw data from the input variables in the form of nutritional content, glycemic index, glycemic load, and menu engineering variables such as popularity index and contribution margin were collected as deterministic values known as Cripps value, which were then converted into fuzzy sets in the menu items per day. The Cripps values of the input variables are then falsified and thus assessed together to determine the menu from the healthy level and the menu engineering category based on the pre-row value. Based on the value on the input variable in linguistics as nutrient content as well as the glycemic index value and glycemic load in the first stage of the study, a membership function for fuzzy was made according to the required category, with a fuzzy system to analyze the variation of the diabetes mellitus diet menu on the glycemic index and glycemic load. The expected output from this state is obtaining a number of choice of diet menu offerings that have low glycemic index and glycemic load for patients with the type 2 diabetes mellitus with fuzzy input variables used are total levels, energy, carbohydrates, fat, protein, fiber, glycemic index, and glycemic load, as well as some information such as menu engineering data, including popularity index and contribution margin required by food producers. And next, the two systems in my research methodology were developed into application system, which I named the Healthy Menu application for people with diabetes. And through the video that I have prepared, I hope the committee can have presentation.
Okay, please wait for a while, ma'am.
Okay.
I would like to play your video.
And next, I explain about the healthy menu application system flow with genetic fuzzy algorithm approach. Nusan came out, Miss Rizky.
Survive saya kartu. Apotik sehat kota Bandung.
Do you need the sound on, ma'am?
Nah, siji satus revisi polo itu 38, tapi satus 58. Ini kan 20 tablet, jadi kan satu sisi satu apotik sehat. Ini bagaimana settingnya? Ya, ayo sampai ini. Dari kartu ini belinya online
Okay, Miss Rizky. If the time is too long, maybe you can.
Okay. Is it enough, ma'am, to play your video?
Yes, enough.
Okay. So we continues with your PPT?
Yeah, okay. We continues. Okay, and the next I explain about the healthy menu application system flow with genetic fuzzy algorithm approach. Early states, manufacturers provide a wide variety of food menus with initial serving weight, and based on the menu weight at the initial stage, then the system gives calculation the content of energy, macronutrients, fiber, glycemic index and glycemic load of its food menu registered. Then the systems modifies the initial serving weight of its food menu to have a glycemic load of under 20 with a genetic algorithm. And the next step, consumers choose a number of menus to be consumed at its mealtime according to the distribution of its individual's mealtime needs. And the next, system profits an alternative measure of consumption weight for its menu of the consumer's choice by considering the adequacy of energy. And the last, system ranks its alternative measure of consumption weight with a fuzzy database based on nutrients content of carbohydrate, protein, fat, and fiber. And the next, okay, this, yeah, the conclusions of my presentations. The power of genetic algorithm combination with fuzzy system logic algorithm is able to generate alternative ranking schemes related to the priority evolution criteria, thus demonstrating the potential to provide a reliable decision framework and prove a powerful tool for representing human knowledge. It can be operated to accommodate the development of menu engineering models in the preparation of Indonesian local food-based diet menu formulations that meet the requirements of the glycemic index and glycemic load for diabetes and become a tool to make personalized dieting easier, faster, and more accurate. The results of fuzzy values obtained per menu serving can be optimized when combined in a day based on the distributions of meal times. And the recommendations can be confined as follows. Next slide. The application program can improve the professionalism of nutritionists and dietitians in the field of food production and service, and the field of nutrition consulting, mainly related to information on the glycemic index and glycemic load values on the food served, complemented by data on popularity index and contribution margin. The design of this application program can be applied to all areas of food delivery, not only limited to hospitals, but to all areas of the institution that provide food for the diet menu needed for outpatient diabetes mellitus anywhere. Okay, Ms. Rizky. That's the end of my presentation and maybe useful. Thank you. And I return it to the moderator for Ms. Rizky.
Yes, thank you very much, Dr. Nurul Hakimah. It was such a very grateful topic that we need to discuss after this. So, a participant, the honorable, who still attend in this event, I would like to invite you all, if you have any question about Mam Nurul Hakimah topic was delivered recently, maybe I would like to, what is that? There is a question in this chat room from Rizka. I think she's a student. Dr. Nurul, does the application considering the person weight to corn the menu? Jadi aplikasi ini apakah bisa melakukan penghitungan atau menentukan menu berdasarkan dari weight, berat badan. Barangkali bisa dijelaskan Dr. Nurul tentang cara kerja dari aplikasi tersebut secara lebih spesifik. Disilakan.
Okay, thank you for Rizka ya, for Rizka.
Yes,
So
from
I
Rizka.
in Indonesia saja ya, supaya jelas.
Yes.
Yeah, thank
Yes,
you. Because my English is not good ya. Rizka, untuk aplikasi ini memang didasarkan semuanya pada penilaian atau pengukuran antropometri ya di awal ya. Jadi untuk mengetahui berapa kebutuhan energi, kebutuhan zat gizi dari konsumen, awal kita memasukkan data terkait identitas dan antropometri daripada konsumen ya, mencakup berat badan, tinggi badan, kemudian usia, kemudian jenis kelamin ya. Aktivitas seperti itu ya, termasuk kalau untuk yang penderita diabetes faktor koreksinya juga kita masukkan. Oke, sehingga dari sini kemudian sistem menghitung berapa kebutuhan zat gizi dari masing-masing konsumen, kemudian konsumen memilih makanannya apa saja. Ya, setelah itu sistem memilih makanan tadi itu berdasarkan nilai kandungan gizi, energi, kemudian makronutrien, serat, nilai indeks dan beban glikemik ya, untuk dihitung berapa porsinya, gitu, berapa porsi yang harus dikonsumsi. Kemudian setelah itu karena makanan tidak hanya satu jenis, banyak jenis ya, maka dengan menggunakan pendekatan fasi genetika ini, sistem akan menghitung juga berapa jumlah porsi yang harus dimakan dari semua makanan yang ada. Jadi tidak hanya satu, tapi dari semua makanan yang ada, dihitung berdasarkan jadwal waktu makan pagi, kemudian selingan, makan siang, selingan, makan sore atau malam, selingan. Jadi bisa fleksibel, bisa 3 kali makan, 3 snack, atau mungkin sesuai dengan kebiasaan masing-masing konsumen. Dengan sistem ini, konsumen akan bisa mengukur atau memberikan atau mendapatkan informasi tentang berapa ukuran saji yang harus dia makan sesuai dengan antropometrinya tadi ya, dan sekaligus juga sesuai dengan batas beban glikemik yang dipersyaratkan. Di sini sistem menghitung beban glikemik yang ada dari makanan yang variasi makanan yang dikonsumsi itu ada di bawah nilai 20. Kita ketahui beban glikemik itu ada 3 kategori ya, rendah, sedang, dan tinggi. Nah, sistem ini menghitung untuk kategori sampai sedang. Jadi kalau tinggi, makanan itu sudah di skip ya. Artinya dari sisi porsi akan di skip oleh sistem. Sehingga memungkinkan seorang diabetisi ya mengkonsumsi bermacam-macam makanan, tetapi tetap dengan batasan beban glikemiknya bisa di bawah 20 ya, dengan menggunakan model SFG atau sistem fasi genetika algoritma ini. Seperti itu jawaban dari saya untuk Rizky.
Yes, thank you very much for your explanation. I hope that Rizka getting the point of the explanation. Then one more question, Dr. Nurul, come from Mam Ika Yudi. Is that fuzzy algorithm also applicable for female with gestational diabetic? Apakah aplikasi tersebut dapat diterapkan juga untuk apa
Hamil,
namanya ibu
yang
hamil
yang
yang
diabetes.
menderita diabetes, Ma'am? Ya, mohon penjelasan.
Ya, bisa. Jadi aplikasi ini memang diperuntukkan untuk sasaran sebenarnya masyarakat umum ya, konsumen umum bisa juga menggunakan karena apa namanya untuk kategori makanan dengan indeks dan beban glikemik rendah sampai sedang ini sebenarnya bisa dikonsumsi oleh siapapun ya. Nah, memang khususnya untuk diabetesi karena diabetesi harus betul-betul mengontrol makanannya supaya tidak terjadi lonjakan kenaikan gula darah yang tajam ya. Jadi untuk penderita diabetes semua jenis baik yang type 1, type 2 ya, kemudian gestasional maupun dari jenis diabetes yang lain itu bisa menggunakan sistem ini ya karena sudah kita formulasikan ya perhitungannya untuk konsumen dengan penyakit diabetes. Seperti itu Miss Ika.
Aduh, saya dipanggil mesin muda lagi. Bu Nurul, saya ini pengen tahu. Mohon maaf, Bu Tika. Terus bahasa Indonesia aja.
Silakan,
Anu ya,
bisa
saya
langsung Bu
tertarik
Ika.
ini dengan
Saya enggak.
makasih.
Tapi
Terkait dengan rencana SUP kita ini, Bu Nurul. Kalau di kebidanan itu di buku KIA yang sudah difasilitasi kan kenaikan berat badan ibu hamil yang normal gitu, tanpa penyakit penyerta. Nah, ini kebetulan SUP kita ke diabetes, ke DM, mengingat ibu hamil itu sepanjang yang saya tahu BMI-nya nggak boleh dihitung menggunakan berat badan saat hamil ya, menurut nggak salah. Ini teman-teman gizi yang lebih expert ini harus pakai BMI yang sebelum hamil atau paling tidak yang awal kehamilan. Nah, ini apakah sudah kondisikan ke arah sana ya. Kalau memang tadi menurut Bu Nurul aplikasi ini atau teori ini bisa digunakan juga untuk diabetic pregnant woman gitu Bu Nurul. Ya, nanti ada perhitungan BMI-nya juga ya kayaknya ya.
Ada sih.
Nah kalau ibu hamil kan BMI-nya yang dihitung itu yang awal kehamilan gitu Bu Nurul. Nah ini apakah sudah sesuai gitu. Makasih Bu Nurul.
Ya, terima kasih Bu Ika. Jadi memang kemarin memang kami tidak menggunakan saya yaitu tidak menggunakan responden ibu hamil ya. Jadi diabetes tapi dalam kondisi apa fisiologinya normal gitu ya. Jadi tidak ada hamil memang. Tapi secara formulasi perhitungan-perhitungan yang ada itu sudah kita sesuaikan dengan perhitungan untuk kebutuhan diet penderita diabetes atau penyandang diabetes ya. Sudah seperti itu Bu Ika. Jadi memang untuk BMI kita sudah masukkan ya. Jadi nanti ibu-ibu hamil yang gestasional diabetes ini bisa juga menggunakan ini ya. Cuman belum kita launching, memang saya sedang proses memasukkan ke Google Play Store. Ini masih banyak review, ya masih direview, kemudian dikembalikan, diperbaiki seperti itu. Nah, mohon doanya semoga nanti bisa segera diterima dan bisa digunakan ya oleh seluruh penyandang diabetes ini. Seperti itu Bu Ika, sudah kami perhitungkan untuk formula atau rumus-rumus yang dipakai ya untuk menghitung kebutuhan diet memang khususnya untuk diabetes.
Terima kasih Bu Nurul. Semoga sukses.
Amin, iya. Ya semoga bisa membantu ya Bu Ika untuk
Thank you very much.
Yeah.
Mrs. Ika, for your attention to join with discussion in this afternoon. I think this was a grateful idea to development application because for now we will using a technology approach to solve any problems about non-communicable disease in community level. So I think there's no other question from the audience and we have enough time in this session with Ma'am Nurul Hakimah. Thank you very much for your time, ma'am. We really know that you are very busy for this week, but thank you very much to or just giving your time for us to support this event. So me as a moderator in this session say thank you, and we say to end this session. Thank you very much, Ma'am Nurul Hakimah, and give us apologies if there's any mistake that I've done in this session. So I would like to giving back to MC, and here we go, Mrs. Hanandayu and also Miss Hanandayu and also Mr. Andi Hayon. Thank you very much.
Okay, thank you very much for Ms. Tika. Okay, so we would like once again to thank Dr. Nurul Hakimah for the presentation. And of course, we will now give the certificate symbolically to Dr. Nurul. Okay, and please allow us to capture this for the documentation. Okay, thank you so much.
I received this certification.
Okay, thank you so much. Yeah, thank you so much, Dr. Nurul, for the attendance and of course for the insightful matter for today. And of course, we would like to thank you for the moderator, Ms. Tika, for joining us today and for accompanying us for this whole day. And because
Miss Nandayu,
yes, ma'am.
I will leave first.
Oh yes, yes, you may. Thank you so much for the attendance.
Okay, thank you.
Okay. Good afternoon, Doctor. Okay, so because right now we already reached the end of the first day of the conference, because the session with Dr. Nurul just now was the final session of our event, and therefore our activities today are not complete. But don't forget that we still have our second day tomorrow, and hopefully that we can start it on time at 8 p.m. So please, for all the participants that have been attended today, please join us again tomorrow, hopefully on time at 8 p.m. because we will start the agenda for the second day. For the first one is the oral and poster presentation, and then we also have some invited speakers that will share their research. And we also have the internal speakers for tomorrow. If we see the schedules for the speakers tomorrow is from Dr. Eti and from Dr. Roni. So we totally hope that you can join us tomorrow to watch and to have some discussion with them. So yes, that's for all for today, and that's the information for tomorrow agenda. And before we ended this meeting, I also would like to inform you that the attendance link has been shared, I guess. The attendance link has been shared in the comment section. Maybe, yes, okay, Mr. Tapriadi, wait for a second. For the committee, maybe you can go copy paste the link in the comment section so that the participant can directly access the link. Okay. We will wait for a bit. No, I mean for the committee, please copy paste the link, the bit.ly link, into the comment section so that the participant can access it directly. Actually, thank you for showing us the PowerPoint presentation. Thank you so much. But actually, I think the participant needs the link. Okay, so while we wait for the committee to share it, we also would like to remind you that to get the certificate, you have to fill the attendance for the 2 days. So for today and then for the tomorrow, please fill the link so that at the end of the conference tomorrow, the certificate will be automatically sent to your email. And of course, because we will send it up automatically to your email, please type correctly the email so that you can receive it almost directly after you press the submit button. Mbak Ola, yes, thank you for Dr. Talusik. Thank you so much for Dr. Talusik for the sentence. And we also would like to thank you for joining us from the morning until right now in the afternoon. We know that you have a lot of schedules, but thank you so much for joining us today. And thank you, of course, for all the participants. And okay, from Lily Ines. Okay, just wait for a little bit. We will open it first for you and of course for all the participants. Okay, it has been shared in the comment section. You may try it first. Maybe you have, if you have any difficulties or anything with the link, please inform us right now so that we can correct it. Say, okay, the link has been shared, and once again, we would like to remind you that please join us again tomorrow at 8 a.m. because we still have the second day of the conference. And for all the participants that will be the presenter for oral presentation, please be ready at 8 a.m. or maybe if you want to, or maybe if you need our help to share your presentation tomorrow, please send your PowerPoint presentation to us maybe before 8 a.m. so that we can prepare it for you. So at the session of oral presentation, we can share it from the admin. But you are allowed to share it for yourself, and just make sure that you attend the session on time. Okay, thank you so much. I think that's all for today.
Ma'am Widi,
yeah, yes.
Link attendance, and we need permission.
Yes, sir. I think you have to open it with your Poltekkes account, your email, but with Poltekkes Malang ACID. But maybe for the okay, we have the newest information for all the participants, especially for Pak Dewa. You can access it once more because we already corrected. And please tell us if you have any difficulties.
Okay, ma'am, already.
Okay.
Okay. Next.
Okay, you
Thank
can.
you.
Okay, you can access it. Yeah. Okay, thank you so much. Yes, and finally, this is the end of our first day of the conference. Once again, thank you so much for the attendance today. And on behalf of the committee, I would like to thank all the participants for all the attendance. And we actually want to apologize maybe if during the events there are some inconvenience. Thank you. Good afternoon and see you tomorrow at 8 a.m. Assalamualaikum warahmatullahi wabarakatuh.
So,
Thank you very much.
Thank
We're
you.
waiting for your coming for tomorrow, ladies and gentlemen.
Wandayu,
Ya, Pak Nur.
besok jam 1 ya? Jam 1.
Oh yes, yes, for your schedule with Prof. Barokatun tomorrow at 1 p.m.
Okay. I'm ready. Thank you.
Okay, thank you so much.
Yeah.
But Dr. Nur Rahman, join us tomorrow at 8 a.m. ya?
At 8
8
in the
a.m.
morning. In the morning.
Yes, we need the participants.
No, I cannot follow in the morning because I have a
Okay.
meeting in the PKD Zoom.
Okay, I see. Okay, thank you.
Okay, thank you. I leave before. Thank you very much, Miss Andayu.
Okay, thank you so much, Doctor.
Yeah.
Miss Anandayu, good speaker.
Yes.
Good speaker. Very nice.
Oh, I'm still learning.
You're good. You're good English. Your English is fluently.
Thank you.
Yeah, very
Thank
fluently.
you so much. Thank you so much, sir. I'm still learning actually.
I learn with you.
Of course. Joining us tomorrow, yeah, sir.
Sure. Yes. You should remind me.
Okay. Okay. I will send you text message.
halo, ready.
Ya, Pak Tap, selamat sore. Pak Tap.
Ide distreni. Jurus.
Daftar hadirnya sudah diisi, Pak.
Sampun.
Sampun, matur nuwun. Besok hadir lagi, nggih.
Ya.
Telat-telat dikit nggak apa-apa, Pak.
Siap.